I'm the current chair of GHN. So I'm a solicitor by day, and the chair and the voluntary director of the network. So this is very much different from my day today. So I'm really looking forward to hearing from all of the speakers and presentations today. I first want to thank a couple of people, in particular everyone who sat on the subcommittee involved in the organisation of today, in particular the representatives from our member organisations. So James O'Hagan from LGBT Ireland, Jess Anderson, David Field from GMHS, and Kelsey Doyle from Belong To. It's great to have member organisations involved in the organisation of this event, and we would encourage as many members as possible to get involved in the organisation of this, but also to attend and participate in our network meetings, which I know many of you have, because obviously as a network we are the sum of our parts and very much stronger together. I'd also like to thank Peter Keogh and Bill Foley, who are directors of GHN, and our staff, Alicia Byrne-Keane, our administrator, and our communications director, Padraig Burke, for their work in the subcommittee. So they have met weekly over the past number of months and worked tirelessly to get today organised. So we're really grateful to them. I'd also like to thank Dublin Pride and Luke McLaughlin, who are assisting us in streaming the event. So I'm just going to touch on some of the speakers that we have and the agenda for today. As you've seen, there are a number of brilliant speakers that you're going to hear from. So firstly, we have a recorded address from the Minister of State, Colin Burke. After that, we're delighted to welcome back Professor Fiona Lyons, who many of you know is the clinical lead of the SHCPP, and Fiona is going to speak and also sit on the panel that David Field will be chairing on DoxyPEP and the new HSE interim guidance on that, which is very much hot off the press. Then after that, we have updates from a number of health services and LGBT organisations. I'm not going to name check everyone, but we are looking forward to hearing from all the speakers in the morning and leading up to lunch. Then in the afternoon, we have a number of sessions on trans healthcare. So we are going to look at the state of trans healthcare in Ireland today and the shortcomings with the CAS report. So that will be led by Jason Shuleil from Trans Healthcare Action. That was the subject of our last network meeting, for those of you who were able to attend that, and it's an area which is obviously very topical and one which we hope to be able to make an impact and are very conscious of our role as allies to the trans community. We also have a keynote from Dr. Beth McGallagher on models of trans healthcare as part of that section today. Then in the afternoon, we have presentations on Chemtex, and to close out the afternoon, Peter Keogh is going to speak about the history of GHN. So this year marks the 30th anniversary of the establishment of the network, and there will be an exhibition later this year, which is going to be created by Brian Teeling, and he's here to speak about that. And that promises to be a brilliant event with a number of speakers and ancillary events, and promises to be really brilliant. So again, I encourage all of you to get involved in that. So that's largely it for me. You'll be happy to hear. There are plenty of opportunities to ask questions throughout the day. The hashtag is GHF24 for any of your socials. And to kick off, we are firstly going to have a housekeeping video on fire safety, etc. here at the venue, and then we will have the address from the Minister of State, Colin Burke.
Ladies and gentlemen, may we please have your attention for this public safety announcement. This is the main conference hall. The conference hall has 3 emergency exits. Exit signs will remain illuminated at all times. Please take a moment to check the exit nearest you, bearing in mind that it may be behind you. In the event of emergency, you will be asked to proceed to the exit and move up the stairs to the assembly point located in the lower castle yard beside the church. For your convenience, restrooms are located outside the main entrance to the room. Please ensure that mobile phones are switched to silent while in the conference hall, and remember that Dublin Castle is a no smoking and no vaping building. If you are using headsets, we would request that you return them to where you found them when you finished.
Good morning, everyone. Thank you all so much for your kind invitation to speak at today's event. I'm delighted to be able to support your valuable work. The Gay Health Network and partners play vital roles in promoting inclusion and diversity, supporting LGBTI+ community, and particularly working to support LGBTI+ health in partnership with the HSE. It was wonderful to be able to reflect on how far we have come in recent decades while supporting the Pride celebrations last month. As Minister of State at the Department of Health and Public Health, Wellbeing and the National Drug Strategy, I would like to stress the importance of ensuring that healthcare is inclusive of the needs of LGBTI+ people across society. The National LGBTI+ Inclusion Strategy provides a whole of government framework supporting equality and inclusion. This has been extended by the Department of Children, Equality, Disability, Integration and Youth. To implement outstanding actions, it will remain in place until a successor strategy is finished. The inclusion strategy vision is of a safe, fair and inclusive Ireland where people are supported to flourish and to live inclusive, healthy and fulfilling lives, whatever their sexual orientation, gender identity, expression or characteristics. Health is one of the main themes of the strategy, and the Department of Health, the HSE and our community partners such as yourselves work together to implement the health-related actions outlined in the strategy. An independent review of the inclusion strategy was published recently, focusing on progress made under the first strategy and also on identifying priority areas for its successor, which is currently being developed. Moving on to transgender health, the government is committed to the development by the HSE of a well-governed patient-centred healthcare service for adults and children in the transgender community in line with the programme for government. A new clinical programme for gender healthcare has been initiated by the HSE. Over the next 2 years, an updated clinical model for gender healthcare services will be developed. A national clinical lead for gender identity services has recently been appointed. They will lead a multidisciplinary team to develop a new model of care under the auspices of the HSE National Clinical Programme. The Department of Health has provided €100,000 in funding to establish a programme which will be informed by the best evidence-based clinical care. Emerging and evolving international evidence, including the CAS report, will be reviewed as part of this work. Our partners in the HSE aim to provide a wide range of services for people with gender dysphoria, ranging from local care in the community to more specialised and complex care. The HSE are committed to building a service based on experience and clinical evidence, respect, inclusiveness and compassion. Developing a model of care for gender healthcare services is expected to be a complex process. I would like to assure you that the HSE and the department will work closely together to support the process ensure transparency, and to keep the patient at the centre of the process. Sexual health is a key area in terms of supporting LGBTI plus health. I would like to assure you that it is also a key priority for ourselves in the Department of Health. The original National Sexual Health Strategy, published in 2015, is a key component of Healthy Ireland, our framework for supporting national health and wellbeing. The National Sexual Health Strategy takes a life course approach, acknowledging the importance of developing a healthy attitude to sexuality in young people and then building on that foundation for positive sexual health and well-being into adulthood and older age. The strategy supports positive sexual health and information and prevention of adverse sexual health outcomes such as STI infections. Following an independent review by Pro Ireland published in 2023 and available on the Healthy Ireland website, we are in the process of renewing the strategy, which will be published this autumn. The review judged the first strategy as being very successful, with the majority of actions, 49 out of 56, successfully progressed. We've had some very significant successes. These include joining the HIV Fast Track Cities programme, launching and expanding HIV PrEP scheme, free home STI testing, the free contraception scheme for prescription contraceptives, and expanding the national condom distribution scheme. There's been a lot of work done, but a lot more to do. As we're all aware, STI rates are rising both nationally and internationally, and we have a rapidly growing population. Just to give you a very high-level overview, key priorities for the new strategy will include additional capacity for preventing, testing, diagnosing, and treating STIs and HIV, strengthening supports around HIV and for people living with HIV through fast-track cities, improving access to pre- and post-exposure prophylaxis, PrEP and PEP, refreshing and renewing education, training, public information, resources, and research for sexual health. Continuing to improve access to contraception, including the National Condom Distribution Scheme. More information is available on www.sexualwellbeing.ie. I'd like to thank those of you in representative organisations, including Gay Health Forum, for continuing to feedback. This has been very valuable in supporting strategy development. I know that you have a full and diverse range of presentations during today's forum, which I'm sure will be a source of great interest and debate. It only remains, therefore, for me to thank you all again for your support and to wish you an enjoyable forum. Thank you.
How do you follow that? My name is David. I'm the clinical specialist in the Gay Men's Health Service. I am going to be chairing the first session. I just wanted to let everyone know that there's some QR codes on your tables for answering questions. If you want to log into those now, it would be really helpful so that you can just kind of go forward asking questions to each of the panelists. I'm going to introduce our first speaker. Our first speaker is Professor Fiona Lyons. She is a consultant in genital urinary medicine in the Guy's Clinic in St. James's Hospital. She is a clinical professor of genital urinary medicine and in the Trinity School of Medicine. And she's the National Clinical Lead for the HSE Sexual Health Programme. Her special interests include HIV infection in women, pregnancy, HIV prevention, and new models of STI care delivery. Thank you very much for your time.
Thanks, David. Good morning, everybody. Just give myself a chance to get into this. So I'm providing an update on behalf of the sexual health programme, so it includes all elements of the programme, not just the work the clinical team do within the programme. And by way of introducing that, just to show the structure of the programme, so we have a research function, an education health promotion function, a communications function, and finance function, and also our clinical function. And overall, we're managed by access and integration within the HSE with a clinical line to the CCO and for the clinical team on the work that we do. So over the next number of slides, I'm going to give updates on the different aspects of the work in the programme. And please forgive me, I'm most familiar with the clinical updates because that's my area that I work on, and I'm relying heavily on the team who've given me lots of information for the other updates of our work. So firstly, information on campaigns and our campaign and our communications at work updates, and then thanks to Maureen and Rachel for their updates on this. So within the programme and within the HSE, we manage the sexual wellbeing website, which was established shortly after the programme, the sexual health strategy was launched in 2015. I just realised I'm probably speaking very fast for you, and I'm sorry. Do you need me to slow down? I'm sorry. I always do this. I beg your pardon. So this is a comprehensive website that was established when the Sexual Health and Crisis Pregnancy Programme was formed and with the launch of the first strategy back in 2015. And the intention of this website is to provide comprehensive information on sexual health, consent, STI testing, contraception, HIV, PrEP, and much more. There are almost 470,000 tracked visits to the sexual website in 2023, which suggests that this actually does have a significant reach. And these are just some snaps from the front page of the website, and you can see that you can easily access information about the free contraception scheme and also free STI testing and lots of other information resources. We also, in 2023, did a number of sexual health campaigns, and this includes digital, out-of-home, and social media campaigns aiming to engage particularly with 17 to 30-year-olds to raise awareness of sexual health, reduce STI incidence, and prevent unplanned pregnancies. But given the particular increase in gonorrhea in 2023, we did a particular focus on young people aged 17 to 24, and this content, which had was reaching 37.5 million video views in 2023, again suggesting that this isn't actually engaging, engaging the audience that we want to engage. And you can see, I'm sure if I can keep a pointer. On the bottom page, over the Castle Lounge, is a picture that Caroline and I took one day when we were out and about for a short bevy after a Friday day of work, and that was a log that was projected onto the side of the Castle Lounge, and we were very proud of that. Some poor random guy passing by had to take a photograph, but we've edited ourselves out of this research. The other campaigns that are very importantly and particularly relevant to this audience are the work that we do with Gay Health Network in promoting STI and HIV prevention, raising awareness about testing campaigns, and targeting gays, bisexual and other men with sex with men nationally. And this includes the information that we would have seen probably on social and in the restrooms around access to free condoms, how management, access PEP, and information about Shigella, which has been a trouble for us in the last couple of years. Other very important work is around the work and the unfinished business that there remains around addressing HIV stigma. Unfortunately, many people who live with HIV still experience significant stigma within society. And just before COVID in January 2020, on a Lewis trip into town, we had the posters, these lovely posters on the top right-hand corner, showing basically that the HSE is endorsing that basically when people living with HIV are on effective treatment, they are uninfectious. There's a new stigma campaign under development, and last year I had in the run-up to World AIDS Day on the 1st of December, I had the privilege of sitting down and doing a podcast with the absolutely amazing Aoife Cummins on addressing some of the issues around HIV stigma, particularly in healthcare settings, and this was targeting our colleagues working in healthcare settings, because we know that people living with HIV still experience significant stigma within healthcare. And just to highlight the important research that was done, particularly by Elena Vaughan in 2023, which was launched by HIV Ireland last year, and also RCSI in development of a number of undergraduate students have developed a module on addressing HIV stigma, particularly targeting health and social care professionals to address and hopefully combat and overcome the issue that we still experience with HIV stigma. There's lots of information on STIs and HIV, all available on the Sexual Wellbeing website, giving a range of information on individual STIs and conditions and overall STIs as well. And these are available in a number of different languages. And thanks to a very good tip actually from David, we developed QR codes now, so you can click into them rather than having to have a printed thing, because I suspect that when somebody is given a handout leaflet, printed leaflet on something they've done every year when they attend us in the STI clinic, the first thing they do on the way out of the clinic is to have it in their skin. But much easier to have a QR code when you can click into it when you're in a safe space and have access to the information. So moving on now onto the clinical updates, and huge thanks to my colleagues, my right-hand women, Caroline and Rachel in the programme for these updates. And we're going to focus on a number of areas, and one of them particularly is going to be the National HIV PrEP Programme. And so as you know, and as the Minister alluded to, we launched the National HIV PrEP Programme in 2019 with the specific objective of preventing sexual acquisition of HIV. We've got standards and guidelines which were updated since the first published in 2019, and we have information leaflets available in a range of languages, including Ukrainian, Polish, French, Spanish, Portuguese, and Irish. We currently have 13 public PrEP services and 17 approved, HSE-approved GP private PrEP providers. Since the programme started in 2019, over 7,000, almost 7,500 individuals have initiated HIV PrEP. That's from zero in 2019. And currently there are over 6,000 individuals attending for care in one of our approved services. We know that that's not enough, and we know that people are still experiencing issues in accessing new appointments for HIV PrEP. And with that in mind, we've almost completed development of an e-learning programme, which is the specific intention of which is to provide individuals who would like to be approved PrEP providers with the skills and the competency and the knowledge that they can do so in a safe way, and in a culturally competent way as well. And that should, I'm hoping when I get back to the office on Tuesday, there's going to be a lot of work for me to review so we can get that signed off and up to HSE land in the not too distant future. Interestingly, when we were developing this e-learning programme, the medical education company that we've been working with and myself independently came to the conclusion that we actually needed a standalone sexual health history taking module. So this is going to be available to all health and social care professionals on the HSE website, and we will do some promotion of that through webinars in the autumn of this year. Specifically looking at PrEP activity, we don't have a system where we can actually exactly monitor what's going on in capturing the number of people attending services, but we do have information from the primary care reimbursement scheme, which is the mechanism through which individual community pharmacies are reimbursed for providing free PrEP medication. So with that in mind, this very busy slide, basically the bottom line is, if you look at the take-home message from this slide is that if you look across the top rows, everything's getting bigger every year. And most importantly, one of the things that we really want to see is that we're continuing to get new people on PrEP. So in 2020, not surprisingly, it's the second last row, not surprisingly in 2020, 1,433 people were initiating PrEP because we just launched the programme. That was in the midst of COVID. Next year, 1,761, 1,240, and then almost 1,700 in 2023. So despite the capacity issues, we are still continuing to get new people on HIV PrEP. And in the first and second quarter of this year, almost 800 people have initiated HIV PrEP. Moving to the home STI testing service. So thankfully, this has been, when we did the pilot, it kind of, the horse left the stable and was never going back in. It's going to be very difficult to undo what we did in the pilot because it's such a success. And thankfully we were funded to provide a national STI testing service, which is free from October 2022. Almost 110,000 STI test kits were ordered in 2023 with an overall return rate of almost 70%. Because some people will get a kit and not actually do it. I've done it myself once where I ordered one kit and didn't do it, and I ordered a second kit and I did do it. So there will be some curiosity in engaging with the programme at the beginning. What we have seen very significantly in the last quarter of 2023 and throughout this year is the return rate is increasing up to 75%, and in some months as close to 80%, which means that the people who are ordering the kits are doing the tests and returning the kits. That is very good, and we do know, because that's what we want. We want to have a mature system that is being used for what it is intended. We also want to ensure that we have a service that is actually identifying infections, and it's not just picking up nothing and that there are no significant infections, because that's the purpose of it, is to have earlier identification and management of infections. And this is reflected in our overall reactive rate of 10.5% in 2023, suggesting therefore that the right people are engaging with this free home STI testing service. One of the big challenges that people face in face-to-face services is the time to getting their results. This has been completely revolutionised by the home STI testing service, where the turnaround time where people get their results within receipt of the laboratory is within 72 hours, within about 99% of individuals. And for significant individuals, it's actually within 24 hours. So as I said, the STI testing reactive rate overall was in 2023 was 10.5%. It contributed to almost 5,500 of the National Committee notifications in 2023, 1,600 of the gonorrhea notifications, and 1,000 individuals had. I just see my slide transition animation thing is not working. Apologies, that healthcare was not meant to be there yet. That's meant to be a big reveal next. So we know that we're actually contributing significantly to the community and gonorrhea diagnosis in the country. And in recognition of this innovative piece of work, we was awarded the Irish Healthcare Award in Innovation in 2023, something of which we're very, very proud of in the programme. So the user journey, many of you may already be familiar with it, but it is very patient-centred and person-centred, and is continuously evolving around what the feedback is on what's easy to do and what's not easy to do. My animation is now working, except the colour hasn't come up, but basically what this is to say, this is the problem of coming back from holidays the day before you go to give a presentation. What this is meant to say is that in 2023, between September 2023 and February 24, we piloted managing low complexity chlamydia within the programme. This was very successful, and I'm happy to say that this has now been relaunched in June with a national reach, such that individuals with low complexity chlamydia can have the option of having their chlamydia managed digitally within the programme via SMS and a telephone call, with then an electronic prescription to the community pharmacy if they're choosing, and for their medication. This has significantly reduced footfall of low complexity chlamydia into our face-to-face services, and therefore gives us capacity and time to deal with individuals and to support individuals who are experiencing more complex sexual health needs. And I can tell you, every clinic is more complex than it used to be 3 or 4 years ago. Things that are coming soon is the ability to order condoms and lube at the time of the STI testing kit. And I think I may have actually said this last year, and you say, well, why is it taking so long, Fiona? But who knew that I would end up, and within the programme, we'd end up having conversations about the weight of condoms and the impact that the weight of condoms and lube was actually tipping things over into a new postage package weighting grade, and therefore the cost associated with that. And could we get them into smaller packaging and make them lighter? So that's been part of the delay for that. And also coupled with the fact that our provider of the free home STI testing service has very appropriately engaged with trying to use more environmentally friendly packaging. So there have been the delays that have led to that. Another piece of feedback that we've received consistently has been the ability for individuals to have a user-activated STI test kit, so that services and supports can assist people who find it difficult to navigate the free STI testing platform themselves, can support them to do that. And that will be piloted with an NGO in the last quarter of this year. Yeah, in the last quarter of this year. And the Minister mentioned the HIV Fast Track Cities Initiative, which is an initiative that Ireland signed up in 2019, where Dublin, Cork, Galway and Limerick signed up to be fast track cities, and the objective of which is getting to zero new HIV transmissions within those cities. At the time, the Sexual Health Programme was tasked with managing this initiative from a HSE perspective, and so engaged in a big, huge multi-stakeholder HIV scoping study. And the objective of this was to provide the information from which individual cities could develop their own in-city implementation plans to getting closer to zero within the individual cities. I'm delighted to say this is now published and available on our website, and huge thanks, and actually a massive pool of us served to Caroline and Richard, who put in an enormous amount of work. Every time I crept out of my office over the last 18 months and I looked over my shoulder, what was open for Fast Track Cities? It was a huge piece of work. It's never been done before, and it's certainly within the Fast Track Cities community in across the world. Doing this kind of scoping study is something that other cities said, that's an interesting approach to take to trying to get your city implementation plans in place. DoxyPEP. We're going to the panel on DoxyPEP, but just to a taster about it. So what is it? It's doxycycline used as post-exposure prophylaxis, sometimes called DPEP, but we've made a decision to call it DoxyPEP so that it's not confused in any way with HIV-PEP. It's using doxycycline after a condomless anal or oral sexual contact, 200 milligrams within 72 hours, with a view to reducing incident bacteria and STIs. What can it do? Well, we do know that there is literature that supports that it, both real-world and randomized controlled studies to suggest that it will reduce incident syphilis and chlamydia, and in some circumstances gonorrhea, but not in all. But it isn't a binary thing. It doesn't give you no infections, and there are many side effects potential side effects associated with this. There are many unknowns, particularly around the impact on antimicrobial resistance and the ability to have antibiotics to treat it and treat incident STIs and other infections. Changes to the host microbiome, and also changes to the impact to how people's syphilis serology, for example, will evolve when they've been taking DoxyPEP. I just see the time has me in my last 4 minutes, so I'm going to speed up a little bit, and I may skim over a couple of slides, apologies. So National Condoms Distribution Service, as the Minister pointed out, this was launched in October 2015. It was actually the first time we had a National Condom Distribution Service, and I remember it well. And in 2022, over 1 million condoms and almost 620,000 lube sachets were ordered. In 2023, this is approaching 1.5 million, and with almost 700,000 sachets ordered by over 150 services and organisations across the country. Sometimes when we get off the Lewis stop, I live on the north side, when I get off the Canberra Lewis stop, I'll see sexual well-being torn and think, great, hopefully it was used to good purpose, but maybe not. So this is my slide animation not working again, sorry. So the where to get free condoms is another button on the sexual wellbeing website, and so some of our NGO partners have a postal service where you can actually order condoms and they will post it to you free of charge around the country. Moving on now to research updates, and many thanks to Nicola and Fiona for their information from here. So from an overall sexual health perspective, there is work going on to have a general population survey, and this scoping study being done between January and June of next year to inform a larger national general population survey on sexual health with a target of 5,000 individuals in 2027. Within the programme, everything that we do is evidence informed, and that's why it's so important. We have this kind of general population surveys. They've been done before, they are enormous pieces of work, and so it's a huge amount of work to get ready to do another one. And this information is really useful for informing where have we made gains, where do we need to make more gains, and where are we not making any gains at all. Other research updates from 2024 specifically for GBMSM is the EMIS study, which has recruited 55,000 individuals across the European Union, 900 individuals from Ireland. Importantly, within this year's survey, 800 transgender respondents, 80 of them from Ireland, and it includes new things on information on MPOX, PrEP, suicidal ideation, substance abuse, stigma, and stigma for trans people. So hopefully that information will help us to see where we are in terms of meeting the needs of individuals, and certainly I can tell you that its predecessors and NICE have been extremely useful for the work that we do within the programme. Within the ESRI, between the partnership between the ESRI and SHCPP, there's a retrospective review of data from the Growing Up in Ireland. You will be aware that there was the publication of the pornography review in 2024, and later on this year they will be looking at data around time, sexual initiation, sexual behaviours and sexual health literacy. Education and training updates, and many thanks to Moira and Quiva for the information on this. So within the, specifically within the GLGBTI arena, in the NO program was developed for young GBM. In 2023, the Belong To services delivered online and in-person facilitator training to 46 professionals. The HSE learned available LGBT awareness and inclusion training. The basics, and it's a very simple but very important online course that is for anybody working within health and social care, and there are over 10,000 individuals have engaged with that since it was launched in October 2019. And the section in partnership with the Sexual Wellbeing and Intimate Relationships for Lesbian, Bisexual and Queer Women, apologies, and there's a resource available on sexualwellbeing.ie, and almost 2,000 booklets have been distributed since 2022, including as part of sexual wellbeing higher education roadshows, so the importance of engaging with education and other arenas like children, Department of Children, Department of Education, because sexual health affects all aspects of our lives. Sexual health promotion trainings continue to be delivered and 13 programs were delivered in 2023. And there's a Work Safely and Effectively in Sexual Health Promotion one-day course, and there were 6 of these delivered in 2023. And there are a range of other RSC training workshops for youth workers and parents available. Lots of educational resources available to parents and to teachers and people who are providing education to our young people. I'm sorry, I'll say a little bit more about this. So working in conjunction in partnership with the Department of Education and the NCCA, there's work going on to develop 3 RSE junior cycle supports, and they will be due early next year, and continuing to develop. The program continues to develop in partnership with many other organisations, resources for children, parents and teachers. And with that, I'd like to say thank you, and you will note that there was no MPOX update on this year's slide on this year's presentation. That's because I sent my slides to Alicia like a good girl before I went to my holidays, and everything that has happened more recently happened whilst I was away. So thank you very much. Thanks very much. It's hard to see the amount of work that goes on over the course of a year, to see it all condensed down into a presentation is impressive. I might invite up our panelists for the next session. That is Dr. Sean Gilmore, Adam Shanley, and Aaron Sullivan from Cork. And I didn't get bios for everyone, so I'm going to ask them to introduce themselves. She's not introducing myself. And I see that the questions have started as well on Slido, which is great. You can continue to use those. I'm going to stay standing because I have a lot of bits going on here. So, I don't know if you did introduce yourself.
Adam Shanley, I'm the Empower Program Manager at HB Ireland. So at Empower, we respond to the sexual health and wellbeing needs of gay and bisexual men and other men with sex with men, including cis and trans men, and people who are non-binary who feel comfortable accessing services that are potential.
Excellent. And John.
Hi, I'm John Gilmore, Colenso here. I'm an assistant professor in nursing and health systems at UCD, and I work in kind of all things sexual and gender minority health. I'm also a Fulbright scholar, so I spent 6 months in the States last year, based in San Francisco, so lots of clinics and community spaces where DoxyPEP was available and being used and being prescribed. And I didn't give an STI in 6 months in San Francisco.
So my name is Aaron O'Sullivan. I'm the LGBTI plus sexual health support worker in the sexual health sector in Cork. And we're an organisation that has a range of different, I suppose, kind of health promotion wings in the areas of HIV, LGBTI supports, outreach and support for marginalised communities. And we have some counselling services as well in terms of crisis pregnancy counselling, post-termination counselling, HIV And then my own role, I just do kind of mainly one-to-one support for people that might be struggling with their sexual orientation and their gender identity, and sexual education, LGBTI inclusion workshops, and rapid HIV testing.
Great, thanks very much. The first couple of questions that came in from the audience perspective, so I might start with them first, Fiona, if that's okay, were just around some of the prep bits. So I suppose the two questions were, are there any plans about injectable prep, which people may have seen kind of online and stuff like that? And the other one was around plans to expand prep provisions.
So the injectable prep, so cabotegravir is licensed by the European Medicines Authority, so it has got a license in Europe, which means then that the company who own it can then seek for approval in Ireland. That's the process. So we can't ask them to do that. They need to actually decide whether or not they're going to do it. I do know that, so right now it's not currently available. I do hope that it will become available. And there certainly are individuals for whom it would probably be a really useful intervention in terms of not having to take a medication on an event-based basis or every day, rather to have an injectable. So it's not currently available, but I do see that it will be available. Whether or not it's going to be through licensing or through in Ireland, or having a reimbursement improvement or approval in Ireland, or through research, I'm not entirely sure at this time. And then access to PrEP, yeah, so increasing access to PrEP. So I suppose one of the things that in parallel, so when we did the estimates for trying to work out how many people we thought would benefit from HIV PrEP, that was using the information around who got HIV. So people who had incident bacterial STIs, people who had used chemsex, people who needed post-exposure prophylaxis. So using that, we came up with an estimate through work we did with HPSC and also then through the health technology assessment. And that was based on people's proven risk. So you had to kind of play Russian roulette in a way and kind of prove your risk as opposed to an anticipated risk. And appropriately, there's been a significant move internationally away from individuals having to prove their risk to actually saying, well, actually, I think I benefit from this. And that therefore will push capacity. And our guidelines have reflected that, where we actually do give anticipated risk as a good reason for somebody needing PrEP. So that's one of the factors why it's difficult to meet need, because there's been an appropriate move towards general relaxation of actually proving your risk before you go on PrEP. And so what we're doing about that is hopefully the e-learning program will serve to increase the number of GP providers, and also within sexual health services, if there are clinical nurse specialists and candidate ANPs and ANPs who want to do HIV PrEP, that they can do this and they then be deemed competent to deliver HIV PrEP. The other thing is we need to consider our other ways of doing it, and we're always trying to think of new ways of doing care. So if there are opportunities to us around delivering care in a slightly different way, then we will certainly explore those. And I suppose the first foray into that has been where we've now included the option for people who are in the PrEP program to have their interim STI testing done through the free home STI testing service. And we also ask for more resources.
Absolutely, always. John, I was going to ask you, you mentioned that you were in San Francisco with I suppose, that initial rollout that happened. What did that look like?
I think it was just a very upfront approach to kind of acknowledging that STIs were an issue particularly within the gay male community and also the trans community in San Francisco. And a willingness for the clinical community to meet that. And this was at a time where there wasn't as strong evidence as we have now. We have much stronger evidence now. But talking to clinicians, it was quite interesting because they were almost kind of talking about HIV PrEP, and they're like, we hedged a bet with this, and we went with this, and it worked, and we're doing it again. But there was a kind of acknowledgement that this mightn't actually be the thing. But it was, I suppose, the responsiveness is we have a need. And one of the things I've been saying that Fiona and I said on the batch guideline item group, and one of the things I've continually said is we talk a lot from a public health perspective around STI burden, and we talk about this in a very quantitative measure, and quantitatively gay and bi men do face a significant STI burden. But also from a person-centered perspective, sometimes getting an STI can be absolutely a catastrophe for somebody because of their individual circumstances, or just because it just feels that way. And sometimes that's totally out of that person probably needs a lot of emotional support and psychosexual support to think about kind of the possibilities of treatment and things. But for some people it is significant. So we do need to think about it in that way. And I think that was very much the approach I saw with clinicians, was that it was having exercise were impacting people, and we could prevent it in a certain way. And it was all over the city. I mean, we've talked a little bit about what promotion of DoxyPep might look like. The bars in San Francisco had like big posters on the wall saying, taking a load, take a DoxyPep. Giving a load, give a DoxyPep. It was like really like, oh wow, I can't imagine this in lovely Catholic Ireland. But I mean, why not in some ways? But I think it was very much out there, despite it being early days. I think we've been a little bit more cautious, and maybe rightfully so, to wait for stronger evidence.
And Adam and Erin, I suppose you're working directly with the community as kind of peers and boards and things like that. Are you seeing questions come up? Are you having conversations, and what's that looking like?
Yeah, absolutely. So, and I think, I suppose, Fiona and her team to be commended in terms of this very progressive piece, and that it is interim guidelines. And I think that is, I suppose, a real indicator of the excellent work that you do in recognizing that the need is there. There are people who are taking DoxyPep, and we need to recognize that and provide them with the information to support them. So that, I suppose, taking that harm reduction approach. And I suppose we have had people come in and interestingly, I suppose, they're not necessarily raising the question in the spaces of the public gun clinics. And I suppose that it's only in the space of maybe if they're in for a rapid test or things like that, that they raise these questions. And even in that, they can be a little bit cautious. But there have been cases, I suppose, where people are taking it, but are taking it in a way that isn't really providing them with any protection. And so kind of, I suppose, arbitrarily once a week, but not tied to any particular risk pattern or things like that. So I think this guidance, ideally, and we always encourage people to, in those scenarios, to go and have that conversation with their clinician, because that's so important, both from, I suppose, their own perspective, but also from the clinician's perspective, that they're aware of what's happening in the person's life. But this is a really useful step, I think, in going forward, that at least where people are accessing it through other means, that they at least have some guidance that they might have a better chance, as well as interfacing with the clinicians themselves.
I agree, and even in the interim, it's still really helpful to have something to refer to when people come to like this is something very concrete that we're using here. Adam?
Yeah, I definitely second what Aaron said about the progress on this piece. It's great that I suppose, Fiona, as you have kind of listened to our kind of advocacy calls over the last number of months and years, I would say, around Doxy. And the development of the interim guidance is really helpful, so that we're acting now and what we know is actually really happening now, and not necessarily waiting for flash guidelines, so that there's something in place now. Because we do see a lot of it, we have a lot of conversations, and we're a really well-connected international community, so and an invested community in our sexual health. So I think when new interventions and new items come onto the table anywhere in the world around our sexual health, that information very quickly gets disseminated, and people want to take proactive steps towards their sexual health, which is obviously a very positive thing. And what's precipitated from that is people kind of self-sourcing both the information and the drugs. And we would have conversations through outreach. Also, you can see on many of the hookup apps and dating sites of people who are actively saying that they're using Doxy. And so it really does, it has been a feature within the community for a while now. So it's really positive that we have some guidance, and what can come from that then is the development of information resources and more kind of direct support, so that community members that are taking or are interested in taking it, take it safely, know how to take it correctly, and have a relationship with their sexual health services, their clinicians, and about Doxy, and ensuring it's right for them and it's working for them.
Yeah, I just wanted to say, Aaron said commending the team for doing something about this, but actually it was very much on the foot of one of the priority actions within our multisectoral GBMSM sexual health group within the programme, so which was a call to action. We all knew it needed to happen, so it wasn't just the programme who decided to do this. It was very much a collaborative piece of work. And just to add, in addition to providing information for the communities who may be interested in or already using DoxyPEP, this is really, I think it's very important to provide our clinical colleagues and our clinician colleagues with information around where we are with DoxyPEP and where we hope to be and where we may end up with DoxyPEP. There are many unknowns, as I alluded to in my talk, and I think that it's a really important step for us to, we kind of have an ethical duty when there's evidence there to say, actually, here we are today, this is what we know today, and this is what we can do today, and hopefully we can get to a more secure place in time. Because in addition to Adam and colleagues through peer work they're doing, hearing about people asking about DoxyPEP, within consultations, where actually people are being asking me about PEP and DoxyPEP, and one of the things we want now is for us to actually be more, that the clinician will be more likely to initiate a conversation, and also that the individual who's actually in receipt of the consultation will actually be more likely to say, actually, can we have a chat about DoxyPEP? And that's kind of bringing everybody together, so we've got a position to bring ourselves forward.
Yeah, I think that's true. I think as well, like as a community, we're so health literate that it can often be like almost challenging. And I've experienced it, and I'm from a community and working in healthcare, so it's like it's great to have this for us. I suppose, thinking about community, I think one of the things that clinicians and community are also concerned about DoxyPEP is antimicrobial resistance. Can we talk a bit about that as a panel? Come on up, Derval.
I'm certainly happy to start this conversation. So, what is antimicrobial resistance? And that's one of the questions that the document that's on your table is the fruit of our collective labours to come up with a sort of an FAQ that can be used for messaging for people who, for clinicians, for the community who may have questions about DoxyPEP, and it's supporting a document that is available to clinical colleagues around recommendations around how, when and if to use DoxyPEP and for pending the BASH guidelines. So antimicrobial resistance is where antibiotics or bacteria, which are antibacterial agents or microbes, can become resistant to the treatment options that we have. And we know that this is something that has evolved both in fungi, bacteria, viruses, everything can become resistant to the treatment options that we have. And therefore, we have a response. One of the reasons that this can happen is if you don't appropriately use the medications that we have, the tools in our box that are so important for saving lives and for reducing morbidity. So if we don't use them properly, then we may actually facilitate resistance. And if we don't know what we're up against, then we may not be using the right antibiotics to treat infections we identify, and also people may not get, we may not get I talk with my hands, we may not get the desired outcomes when we treat people. So antimicrobial stewardship is a really important part of prescribing antimicrobial agents. So is this really needed? Is it an appropriate use of this agent? And so antibiotic resistance with respect to DoxyPEP is particularly concerning around gonorrhea, because we know gonorrhea is not likely to be prevented in the same way that syphilis and chlamydia may be prevented by taking doxycycline. And the reason for that in Ireland is that our background rates of resistance to this class of antibiotics is already very, very high. So we're not going to have a significant gain. But in countries where there was a lower resistance, there has been some reduction in the cases of gonorrhea associated with using doxycycline if they were sensitive. But there's also been a shift upwards in resistance in that class of antibiotics. So we know with the limited evidence we have so far that if you do have isolates that are sensitive to this class of gonorrhea isolates that are sensitive to this class of antibiotics, and you put that pressure on, you will drive the resistance. And gonorrhea is one of those ones that's kind of on the blacklist of really big concerns about it becoming a superbug and an untreatable infection. There is also a concern, ceftriaxone is our sort of first-line agent for treating gonorrhea now. It's a third-generation cephalosporin. We started using 250 milligrams of it, went up to 500 milligrams of it. We're now at a gram. Those shifts in dose have been to protect it and to ensure that we still have that in our toolbox to treat gonorrhea infections. There are some concerns, and we don't know yet whether or not this will happen, that by using doxycycline, we will actually drive cephalosporin resistance. If that happens, we could potentially be in a very worrying situation, and we don't know the answer to that question. I would say that in my head, part of that worry is offset by the fact that in time we will hopefully have a vaccine against gonorrhea. We don't have one yet, but in time we should have a good vaccine against gonorrhea. So hopefully that's not too.
No, I think that's really helpful to just understand antimicrobial resistance concept as well.
And I think it's wonderful to have, because I've witnessed this a lot, both in clinical communities, but also in community discussions. And I think it's wonderful so many people are thinking about antimicrobial resistance. But also we need to think about how antibiotics are manufactured in certain countries and how antibiotics are used in the agriculture industry, and we can all activate and advocate in those things. It would be brilliant. So I think we just do need to be careful around sometimes when that's thrown at us. Sometimes it comes from a different perspective, and we saw this with HIV PrEP as well, that people were challenging HIV PrEP because it's going to make gays more promiscuous, and that was their issue, was kind of a little bit around the erotophobia and a little bit around institutionalized homophobia that we have. So I do think we need to be aware and conscious and cautious, but also recognize that this can sometimes be used as something to challenge us when we're trying to improve the sexual health of people, and people don't often like that, and just sometimes explicitly and sometimes implicitly.
The call to action is please do have regular STI testing. If you are diagnosed with gonorrhea, please do get yourself to a service where you can avail of having cultural sensitivity, because our very sophisticated sensitive tests that we use with the chlamydia and gonorrhea on the same platform does not tell us, does not predict what antibiotics will work. So if we are changing the sensitivity of our gonorrhea, let's make sure that we have enough isolates to detect that. So you need to go to a clinic to have a separate swab taken for the culture and sensitivity taken at the time of treatment.
Yeah, I think that's a really, I suppose, that's a really good individual intervention for me to prevent STIs, but then testing is a good community intervention to keep us all safer. That's a really strong message to kind of send out there, I think. Does anyone else have any thoughts on resistance?
Yeah, I suppose just in terms of the, if you want to put it really well, and I think there's an onus on maybe those of us on the health promotion side to actually communicate that message as well. And, a person might, that health literacy piece, and people might see the research and maybe look at an American study where actually it was more effective against gonorrhea, but the context is different to, say, the French study where, that background resistance is higher, which is more akin to, I suppose, the Irish context. So it's that kind of nuance that I suppose maybe if you're somewhat dabbling in, I suppose, kind of awareness and doing your own research and things like that, that there is an onus to actually maybe, I suppose, make that clear and the nuance to things, rather than, I just take Doxypep and sure, look, we're grand. I suppose there is an onus on us to do our antimicrobial resistance stewardship in its own way as well, and just having those kind of nuanced pieces, and even, I suppose, beyond, obviously the biggest concern being gonorrhea, but even, I suppose, that antimicrobial resistance and maybe other aspects, maybe Staph aureus and things like that, that maybe it's a little bit removed if you're just taking, I suppose, Doxypep. You're very much focused on STIs, but those kind of broader pieces as well.
I can't remember what I was going to say. I'm having a menopausal moment, so let me try and gather my thoughts.
I think coming on to the kind of getting the testing message out there as well, because it is really important that people aren't just being like, I'm self-aimed, I have protections and everything. Is that Doxypep is not a solve-all for every infectious disease, but also it's a challenge to the clinical community as well to provide access. Because if people can't get access to their testing service, where you bring them in, they get their Doxypep and they toddle off for like 2 or 3 months and come back again, then they're going to source it elsewhere, and they're more likely to have those views of, well, I don't need to go into clinic because I'm getting my Doxypep. So I do think kind of trying to, obviously not force clinicians to do something they're uncomfortable with, but really consider this is a way to hook people into regular testing as well, because it's, as Alan said, it's something people are proactively wanting to protect themselves and protect their lovers from sexual STIs. So let's try and hook them in and engage with them.
I remember it. So basically, the one thing that I want to add to what John just said, but also just about, it's really important to make it really, really clear that the evidence is for doxycycline 200 milligrams within 72 hours of a sexual episode. It does not, so if you find Augmentin or Fluclox in the cupboard in the bathroom, they're not going to make any difference at all. And just in respect of clinicians, one of the important things on one of the pages here is that this interim guidance has been developed and is being used out with any additional resource for our clinical colleagues and for me as a clinician working in services. And David will tell you, I mean, we're absolutely out the door already, so we're taking this on without any additional resource. So please be kind to us if we are struggling to meet those needs. We will do our absolute best.
And I suppose to kind of segue with that, there is an onus on all of us, I suppose, maybe that are not in the clinical settings, to lobby for that. Sexual health is under-resourced generally, and never to forget that. I suppose it's not specific to ToxyPEP, but more generally across the country, both in Dublin but beyond as well, and it's very much under-resourced, and the wonderful staff that are working there across all aspects of it are doing the very best they can with what they have, but it's very restricted, which I'm sure we all know, but just as a reminder to kind of keep agitating and lobbying for that wherever you can.
I mean, prospective elections coming up might be a particularly good time. I wanted to ask, I think, like we mentioned that people in the community are already taking doxypep. Other countries and jurisdictions are further ahead than us with it. So I think we have a good selection here maybe to say, but like, what does it look like now? What do we want it to look like when it rolls out? Adam and John are smirking.
I mean, I think right now that people are using doxycycline for prevention of STIs. That's a fact. People are getting them in many different ways, and we won't discuss all of them on the panel, but there are lots of ways to get doxy. And I think what I would like to see is that people get a real person-centered approach to their sexual health care. So when they come in, they have a clinician there in front of them or a community partner who can offer them an array of advice and support and interventions that will work for them in that initiative. And we often, we talk about it, we have this conversation, and sometimes in HIV PrEP services, you people who really don't need PrEP, but they're there because they're really worried that if they fall out of the PrEP, because maybe they're in a monogamous relationship, or maybe they're in a semi-monogamous relationship, but they only have oral sex with other partners, and they're not at really any significant risk of getting HIV. But they're staying in the service because they really need to, because just in case they broke up with their partner, or things change intermediately. So I think it is about that capacity and openness. So I think if we can create a system where people can access it, but also where clinicians can feel comfortable to say, I really don't think this is for you, and that we can have that kind of negotiation and discussion in a really kind of person-centered partnership way.
You go ahead.
I suppose where would I like to see it be? I'd like us to have more information so that whatever we do in the next while with doxypep, we do it collaboratively together, and we gather the information that helps us to better understand the role of this intervention in our overall toolkit in preventing incident STIs. I think if you look at, looking at the evidence is that it gives a modest protection. It's nothing like the protection that we get with HIV, which is much more binary. It's like yay or nay. If you take it properly, you're not going to get HIV. It doesn't apply with doxypep. So I think that we have an onus on ourselves, and I've been working with the community for such a long time now that we have an onus on ourselves to collaboratively work on this and make sure we gather the information to continuously learn around where this fits within our overall role. I think that it will have a modest role to play. I'm not sure it's an absolute game changer. We'll have a modest, but not an absolute game changing role in the way that HIV PrEP had, for example.
Yeah, just kind of building on that, I think what we have, as with any kind of new intervention, I think we need to make sure that we're responding to what the needs of the community is in this intervention. I think we've tried our best to foresee and kind of develop an FAQ around what we kind of foresee as the information need, but I think as this starts to roll out and more people engage in the use of doxypep, it'll be really important for us to be able to reflect back what the needs and the understandings are within the community, build more capacity around understanding this as an addition, potentially an additional tool to your STI prevention toolkit. And I think we've worked really well in being a two-way street when new interventions come about, and I think that needs to be maintained and be at the very centre of what DoxyPEP looks like going forward.
I have two more questions. So I wanted to ask, I suppose, sometimes I would have concerns around now for gay men, they may be taking, you know, 2 Truvada tablets 2 hours before they have sex, followed by 1 24 and 48 hours after, and then adding in, you know, 200 milligrams of doxycycline within 72 hours. Do we have any concerns around the medicalization of sex? Yeah?
Yeah, of course we do. I mean, but these are the biomedical interventions that can help to lead to better sexual health outcomes. So that's kind of like we have contraception that's medicalizing sex as well. And sex is quite medicalized, but it doesn't stop people having good sex, I think.
Yeah, I'd agree. I think this is a really important tool in the pursuit of pleasure, and being able to take some of the weight and heaviness and difficulty out of the pursuit of pleasure and sex that comes with STIs and all that goes with that. I think we have a nice opportunity to kind of reframe how the use of biomedical interventions can actually support us in achieving the sex that we want to have.
Yeah, I suppose 100% yes, there is, I suppose, that kind of procedural element maybe to sex, and to an extent I suppose that is the reality anyway, and so this is just another aspect of that, but it is about kind of getting that message about that well-being piece and protecting yourself and your partners, and I suppose it being more of an empowering and enabling piece as opposed to the actual requirement, and I think like part of that is the actual piece that it is a modest game changer as opposed to absolutely earth-shattering change. I suppose to a conversation I had where somebody was taking it kind of haphazardly based on peer misinformation, I guess, and they were like, oh, it doesn't work. It was that piece of, well, actually, it's not going to eliminate the risk, it's just going to reduce the risk. So you may still get whatever STIs, but yeah.
And the last question, I suppose, I'm a sexual health advisor, so I give you advice around the sex that they're having most days. And to kind of go back to the beginning, condoms. Yeah. Where are we? Are we entering like a post-condom sexual health world? Is it? No?
The lads are laughing at me here. There are lots of people who will continue to use condoms, and the important thing is that we have, like, just to, John alluded to the fact that both he and I are sitting on the BASH guideline development group, and it is like from the outset that guideline development group around DoxyPEP is a holistic approach to improving sexual health. And so Kraton condoms are a part of our toolkit in promoting better sexual health outcomes. So I don't think we've entered a post-condom era, and there may be people, you know, your life changes. You know, as you get older, as men get older, and they may experience erectile dysfunction, using condoms can be more difficult. So DoxyPEP may be a very important intervention for some individuals who are experiencing erectile dysfunction that is made worse by using condoms. But you know, and things change. Maybe as a young person, you may stop using condoms, and then at a period in your life you start using condoms again. I think we have to have the jigsaw puzzle of all the tools in our box available for people as they move in and out of different phases in their lives.
I think what we've entered into is not necessarily a post-condom era, but a proud kind of choice era. We have much more at our disposal to make the sexual health choices that work for us. As we know, I think, you know, it is very, we hear it through outreach, and we probably all have our own experiences if you're using apps or engaging sexually, that there is a move away from condoms, and there is a lot of people who will only engage in sex without condoms. And I suppose what we need to do alongside the work of, you know, implementing these new kind of interventions to increase choice is also to build on self-efficacy, so that we have the confidence and the understanding that if someone is saying, well, I'm only going to have sex without condoms, that you have the self-efficacy and the confidence to say, oh, no, that's not the agency to say that's not the sex that I want and that I enjoy, and these are the choices that I've made for myself. And I think that's are really important parallel conversations to these interventions that we have that increase choice.
And it's dynamic as people go through different stages of their lives.
I think one of the things, I had a conversation recently with some people involved in some research, and the first thing they want around promoting sexual health, the first thing they want to do is understand why people aren't using condoms. And I always get it like, there are two reasons. They don't understand kind of the role of condoms, or they don't want to. I think a lot of people don't want to, and instead of trying to continually convince them that they should want to, we need to acknowledge that and move forward. And this allows us to do that in a way. There are some people who will never want to use a condom, and that's fine because that is their choice. And again, allows the agency of the sexual partners that they have needs to come into that. But again, this may allow us to give them a little bit more protection from certain things, and maybe not others. But it's again, that kind of choice is really important.
Was it very important reason around why people may not have used condoms, and EMIS 2017 showed that a significant number of individuals who responded to that survey didn't have access to a condom the last time they had sex. So we've tried to overcome that by flooding the market, as it were, and flooding loose stocks.
Yes.
So next time you see one on the street, you can chuckle and think of me. Okay? But we have to improve access and give people choice and agency around having the toolkits to ensure that they have better sexual health outcomes and they have good sex that they don't feel guilty or shameful or regretful about or worried about what the consequences of it are.
Yeah.
This isn't about condoms, but I know we're coming to the end. I think one thing we do deal with in the FAQs, but one thing we haven't talked about is who uses DoxyPEP and who the evidence is around. I'm conscious as well, we have a whole panel on trans healthcare, but also on the health of cis women maybe, or people who have frontal sex. And basically, like what we're seeing is there isn't the strength of evidence there. We're not saying that that's never going to be there. I challenge the guys, like the research in itself is transphobic in that it's institutionalized, it's left out trans people. Some of the strongest research has focused on gay and bi men and trans women because they're safe, but I think it's something that we just need to be conscious of and cautious of, and to continue to push forward sexual health equity for everybody, including heterosexual people. I'll even say that. But, I think this is we can see this maybe as working at some point within communities, but I think continue to try and push forward. And again, if somebody is that person who maybe thinks they're having the type of sex that DoxyPEP could help them, but part of their sex life is maybe having vaginal or frontal sex, to have a chat with the clinician around whether DoxyPEP would work or not. Maybe use a condom for that. There's lots of ways in which, like, sex isn't this like planned kind of algorithm like we use sometimes in medicine, where you go this way, this way. It's dynamic, it changes, and as Fiona said, there changes over the life course, but also within the engagement. And we've talked about what about people who, aren't having kind of penetrative receptive sex, anal or frontal, but some maybe don't need kind of HIV PrEP, but actually they might be really beneficial from DoxyPEP. So there's lots of these conversations. So again, I think for me, I'll be continuing to tell people, go into your clinician, tell them you want it. If they say no, say why not, and kind of move along that way.
For me, whilst the data isn't there for cis women, and that's probably because of adherence, I think that it's really important to get a really good space to consider this intervention, and I think that hopefully we will have data to support this, is post-sexual assault. I think that individuals who are in whatever sexual identity, sexual orientation, people are, if they're victims of sexual violence, having an incident bacterial STI is just another kick when you're down. And so I hope that this would be an intervention that would be very useful post-sexual assault. And yeah.
Absolutely. That's great. Thank you so much. And now I'm going to welcome up my general manager, Jesse Ennis, to talk about the Gay Men's Health Service update from the last 12 months.
Good morning, everyone. I'm Jessie. I'm the Service Manager at the Gay Men's Health Service. It's great to be back here again this year presenting for the Gay Men's Health Service. Some of our staff are dispersed amongst the audience. Yeah, so we're good. Just a background, it's a sexual health service for the gay, bisexual, and other men, intersex men, and the trans community. And we're a national service, so anyone across Ireland can attend. We're currently located in the Meath Primary Care Campus in Hastings Street. We're a flagship service in the Community Healthcare East, part of the HSE, a part of social inclusion in primary care. We have a very small multidisciplinary team who have very specialised knowledge and skills to provide the high quality sexual health care. Just a background, it was founded in 1992 in Baggot Street. Some of the photos there can show the old clinic. It was in part of the community response to the HIV. It started as a one-night service and it now serves daily across 4 days. We're now into the 32nd year of service. We've now seen over 155,000 patient visits into the service since opening. In 2019, we moved from the old service Baggot Street into the Meath Primary Care Campus. Post-COVID, we've had a lot of changes. We're now fully electronic. We have sort of new staff and continue to see more patients year on year. We don't provide a walk-in service, we have appointments only. You can see here the number of patients visits every year. It's very small, sorry, but this one here, 2023, we've about a 12% increase from the year before. We're continuing sort of to increase year on year, and you can see there for this year, 2024, the very last one, it's just already the first half of this year. If we project to see the double amount, we're looking to see just under 9,000 patient visits this year. I've also just added in this, I talked about it last year, we introduced the SH24 for our PrEP patients. Not that it's actually patients going to the clinic, but it's to show the capacity that we're making. So there's an extra 370 SH24 pathway patients this year, last year as well, and this year. If we look at our patient demographics, 22% have never previously tested for HIV or other STIs, which is actually a decrease from the year prior. I'm not sure if that's because we're seeing more of the same patients, or they're also obviously availing of all the other testing services, such as the online testing. 70% of our patients are age 24 and younger, 45% are just under 30. 48% of our patients are from abroad, 50% reside outside of Dublin, and 4% identify as trans and non-binary. Sorry, I don't know if you can see that, but we had 927 new patients attend the Gay Men's Health Service in 2023, which is roughly the same as 2022. Sorry, these are really small, I don't know if you can see them. If we look at our clinics, the grey is the 2022, and we look at the green is 2023. The very first one is our PrEP appointments, so there's an increase in all of our appointments there except for the vaccines. So this is actually so small, sorry that I can't even see this here. Year on year increase of our appointments attended. Can you do the other way, whoever just done something? Yes, thank you so much. The top right is just our schedule for the week. We have clinics on Tuesday, Wednesday, Thursday, and then in the background we have a lot of the preparation and the results management. We have the same sort of number of clinics as last year in 2022 and 2023, and our DNA rate continues to hover around 14%. Just looking at it there for our clinics, we have the highest DNA rate in our asymptomatic clinic. I think that's often because people make their own appointments and don't tend to show up for them. But our PrEP appointments are sitting around the 10%, and our treatments, nurse treatment, medical treatments are under 10%. Looking at our vaccinations, we have a dedicated vaccination clinic every Thursday, and our PrEP patients receive their vaccines at their PrEP appointments. Since starting in 2017, we've administered over 8,000 HPV vaccines. The HPV vaccine protocol changed in 2022, so there has been if you see the graph here, there was quite a reduction in the number of HPV vaccines administered. That was the orange in 2023. We also administered 177 Hep A vaccines, 292 Hep Bs, and 405 Hep A and Hep Bs. And not to mention as well, we started again the Mpox vaccines, also returned like Fiona from my holidays to discover a new challenge. Just looking at our diagnosis, gonorrhea, the number of gonorrhea infections increased from 2022 to 2023, from 629 to 862. I suppose if you look at that though as a percentage of the total patients that we're seeing, it's hovering around the same 5.4%. Chlamydia has also increased from 452 to 562. Again, when that's a percentage of the patients we're seeing, it's hovering around 4.3%. The graph down here on the right is just showing that we're seeing more gonorrhea infections than we are chlamydias. These here are just showing the site of infections. So for chlamydia, it's around 63% are from rectal, and for GC, it's roughly equal with rectal and pharyngeals. Looking at our syphilis, if we look specifically at the early EIS, early infectious syphilis, we saw we went from 110 in 2022 up to 122 in 2023. Sorry, it's funny how the slides come out very different to what you put in that. We also saw a decrease, you can't see it there, of HIV diagnosis. I think we went from 12 in 2022 down to 3 in 2023. We spend a lot of time trying to improve our results management process. A lot of work goes on behind the scene from the nurses, and we went fully electronic the last 2 years, and it's made a really big impact and improvement of our results management. What used to be over 2 weeks to receive a result from us, we now have that. The data is showing that we get it down to under a week, and across 2 weeks we have 99% of our results managed, which is a huge improvement for us. So a lot of work goes on behind the scenes for that, and it's for 50% of what our clinic activity is, which helps improve patient outcomes and helps them get access to treatment quicker as well. So it's fantastic. Looking at our PrEP, there's year-on-year increase of PrEP in 2022. Sorry, it's so small. I'll just have to read it out. Sorry. As of 2024, 1,530 individual patients have attended Game and Saw service for PrEP. And in 2023, a total of 886 patients attended PrEP. For PrEP, 173 of which were new. And yeah, we're continuously trying to work on increasing our capacity for PrEP. And the little blue there is the new patients every year. So I think we've seen approximately 100 already this year. We're already booked in for another 100 by the end of the year. So that's another 200 patients this year. And then just looking at our appointments, the bottom row there is 2022. Again, you can see there's an increase there in 2023 of our PrEP appointments attended. So we had 2,630 PrEP appointments attended in 2023. We've also added on the SH24 pathway, which allows patients to do their interval screening using the online testing. So that's helping us free up capacity to see more patients. So we had around 370 in 2023 use SH24 pathway, and we're continuing to use that now into 2024. And since 2021, we have had over 800 new PrEP appointments attended. So yeah, this is the SH24 pathway. We have moved 391 of our PrEP patients onto the SH24 pathway, and we're slowly trying to fill appointments with our new PrEPs. Patients. So it's been great to be able to provide more appointments to new patients and to bring them into the service to be on PrEP. It allows patients to self-manage their sexual health and PrEP use, and it also allows them to attend the clinic less. Looking at PEP, there's been a significant decrease in the number of PEPs prescribed year on year, and just very small there. I can't see that. Sorry about this. Just looking at the other activity that our clinic does. We do the online chlamydia phone consultation, similar to what Fiona was talking about earlier. We try to treat as many patients as possible over the phone and send the prescriptions to their pharmacies to save them coming into the clinic, to allow as more complex patients to be treated in the clinic. We also do rapid HIV tests for our new PrEP patients. David, our sexual health advisor, has been with us just over a year now, and he does our partner notifications and health advisor consultations, works closely with Public Health, HBSC. We've also seen an increase in the number of chemsex assessments. We're averaging around 17 a month. I think last year it was around 14. And we have the psychology and counselling service. It's developed to meet the mental health needs of the GBM community and transgender people. It's a free short-term counselling service and psychotherapy service, and they're predominantly patients of the mental health service. And you can see there we have a steady increase year on year of the number of patients seen. We saw 60 patients in 2023. The average age of the client is 38. The presentations include coming out, gender and sexual identity, addictions, chemsex, homo, bi, trans, phobic experiences, and migration displacement is also becoming an increasing issue that's mentioned. We're continuously trying to work with colleagues to promote sexual health awareness and what our clinic does, sexual health education, vaccine information. So we worked at Man to Man last year on different videos, and they're across social media. I think one you want to talk about them later. Just looking at this year and beyond, we're continuously trying to look at increasing our capacity. It has been quite a tough year across all services. As you're all aware, just the HC, there's an embargo, and we're always trying to progress, but it is quite difficult. So we're trying to always look at options of how we can better improve capacity for the patients to come to the clinic, and continue to use our SN24 pathway, work on education, training, and research. We'll try put in for more resources, continue to reduce our turnaround time. Obviously look at the world of DoxyPEP, that's now here, and we are going to have a lot of conversations, a lot of planning. I think that part of what was talked about there was it'd be great when we start to look at the service about how we can measure what we're about to embark on. It'd be really important to see this time next year what this is all going to look like. And continue to try and reduce our DNA rates, improve the patient's experience. We're going to have our counselling and psychotherapy on site hopefully by the end of this year. And we're continuously collaborating with the other sexual health services, especially in the world of the IT. Myself and Brian have been helping a few of the other services set up on the similar patient management system that we have, which is fantastic, and there's a lot of shared learning in that. And David's Health continues to sort of work at different conferences. This one, and David's going international, going to Europe this next week, which is great. And we're also working with colleagues in HSBC on different projects, including the eSure, which is to help for being used as a site and to help improve the electronic sharing for gonorrhea. So yeah, just a big thank you again. The staff, there's someone here, but they do Trojans work. They just are the most friendliest, loveliest people. They're really hardworking, and we've received a lot of compliments. So I just want to say a big thank you to them, and thank you all for listening.
Thank you very much. I'm going to welcome up Martha Geary now, who is Senior Epidemiologist with the HBSC, to take us through some of the science from last year.
So, good morning, everybody, and thank you very much for asking me to talk to you today. So I'm just going to, I'm going to talk about four things. I'm going to talk about HIV treatment audit. I'm going to talk about the acute Hep B cluster earlier in the year. I'm going to talk about gonorrhea data improvements, and I'm going to give very, very brief update on MPOX. And to start off, I just want to acknowledge that none of this work really would be, we wouldn't be able to progress it without the collaboration and the expertise of people in all of these organisations. So first of all, we'll start with the HIV treatment audit. So as all of us know, antiretroviral therapy completely changed HIV treatment since its introduction in the 1990s. And treatment is crucially important for preventing new HIV infections. UNAIDS has a testing and treatment targets for 2025, and they are 95% of all people living with HIV should know their status. 95% of those who know their status, they should be on treatment, and then those, and 95% of those on treatment should have a suppressed viral load. So the HIV treatment audit was carried out by Fiona, Caroline and Rachel, and my own colleagues Mary and Kate. So 8 adult HIV treatment centres were used, and also the paediatric services. This study was done on the people who attended for care in 2022. So we've an estimated total number of people in HIV care of around 7,100. We have data available for 6,652, and the reason for that discrepancy is that some people attend private clinics and their data is aggregate data, and we couldn't analyse that. So males account for 67% of those in treatment, and of those males, 61% identify as gay, bisexual, and other men or sex with men. So our HIV treatment audit shows that in Ireland, 99.9% of gay, bisexual, and other men or sex with men who attended for care in 2022 are on treatment. And that includes all age groups and those born in all regions of the world. Also, 98.7% of gay, bisexual, and other men or sex with men who attended had a suppressed viral load. Then when we look at all other people who attended for care, the values are 99.5% and who are on treatment, and 97.5% who have a suppressed viral load. So this shows that we have exceeded the UN testing and treatment targets, and I think we get a gold star for that. This data will be used to generate estimates for continuum of care, and that will be available later in the year. So the second thing I'd like to talk about is hepatitis B. And so why was that a concern? We know that Hep B is a viral infection, causes inflammation in the liver, and it's far more infectious than HIV. So a small cluster of cases of acute Hep B were notified in men, and this happened in January and February, and it was more than was expected. The people that were impacted were much younger than we would have expected. They were in a small geographic area. Some were gay, bisexual, and other men or sex with men, and some their risk was the use of cocaine and ketamine. But we couldn't see any epidemiological links. And then there was a concern that Hep B could spread during Pride and spring, spring and summer events if people weren't vaccinated. And just to say here also that vaccination is available in STI clinics. So actually, following an initial response, a national incident management team was set up in March 2024, and that was a multidisciplinary team. So one of the key control measures is communication. So people need to know symptoms. They need to know where to be tested. They need to know about vaccination and harm reduction. So Porrick, who is here, I think, he worked very well with the Addiction Service, Public Health and Communications, and co-created these lovely posters that you can see here on the slide. So there were lots of different aspects to this. There was digital adverts, there was messaging on social media, community adverts and articles. And one of the messages that we also wanted to get across was that, using banknotes to snort drugs and that could also spread viruses like hepatitis B. Then we move on now to gonorrhea, and as we know, gonorrhea is a very common bacterial STI. Notifications went up in 22 and 23, and partly there could be, because of the introduction of the very successful STI home testing service, it accounted for almost 30% of gonorrhea notifications in 2023. And in early 24 now, we look like we're seeing a small decline. And why is that? Well, really, we don't have an awful lot we have a lack of enhanced data for gonorrhea, and it's difficult then to interpret trends. We do know that 80% of gonorrhea cases in 2024 are in men, and we know, and where we know mode of transmission, gay, bisexual men or the sex of men account for 90% of those cases. However, we only know that information for less than half of total cases. So basically, we need to know a little bit more. So we've linked in with ECDC, and we have funding for an e-healthcare program. We're working with Grania, Jesse and David to develop a process to extract data electronically from the clinical system. We're going to analyse clinical, behavioural and laboratory data, and that will help us to inform public health messaging. If this is successful for gonorrhea, we would hope to apply it to other STIs. And now, Mpox. On the 14th of August, a public health emergency of international concern was declared. This was due to the fact that there were an increase in the number of cases of Mpox identified in Africa. The virus that's causing concern in Africa is clade 1b, and the cases that we've had in Ireland since 2022 are clade 2. So on the 20th of August, just this week, a national incident management team was set up. They're going to monitor the situation internationally and in Ireland. We're going to issue additional guidance if that's needed, and communications group have been set up to communicate any additional symptoms, testing, vaccination or harm reduction plans. Just to also say that cases of Mpox in Ireland will remain low. We've had 6 confirmed cases this year. Mpox vaccination is available in Vincent's on Monday morning. So in summary, just to say that we've exceeded the UN AIDS targets. We've identified a Hep B cluster and raised awareness of transmission routes. We've started a project to improve gonorrhea surveillance, and we're going to keep monitoring Mpox and provide additional guidance if needed. And just to say a very big thank you to everybody who's contributed to this, and also to my own team, but also thank you very much for listening to me today.
Personal pressure to make it across the stage is in a great We've already seen some of our next speakers' work presented, but it's great to see Padraig come up and present some of the work that's been done by Man to Man over the last 12 months. Padraig is very comms person, content manager for Man to Man.
Everyone, it's lovely to be here. Thank you all for coming. It's really great to be in the room with you all, and I really appreciate you taking the time to come. Just to say, the Gay Health Network, our it's called annual report is on there, so please take one home with you. That highlights the work that we did throughout 2003, sort of looks at our strategy and approach, just all the sort of different ways that we communicate the messages through digital, social media, digital displays, and the various different campaigns we did. But where I am going to start today is where we left off last year in September. So I'm going to start there. So yes, there's a sort of selection of all the stuff that we've done in the last 12 months. And I'm just going to So how we reach our audiences, I do this every year. So we have social media, we have out of home, we've probably prepared here on George Street, I think. Up there you see the Man to Man, that was at the Aviva Stadium, Taylor Swift concert earlier in the year. Thanks to Myrn, who just works tirelessly and does brilliant work with the programs and campaigns. Thank you. Yes. So digital displays, wider inbox messages, print, GCN magazine, paid search, we work along by, so we pick strategic times of the year where we're going to push it. Other block parties and other where we have advertising, and then the film festival is very important one for us this year, and then the Mansion this is a picture here of the party, and there's walking data. So again, how we reach out is just other examples, GCN magazine, billboards, and digital media, there's that's on Twitter, posts. So just to start with from that September. So we went out with a vaccines campaign, lovely design by Lavender. So with that, we had across the board, across all things that were just mentioned, digital displays, posters on the home. And we looked at hepatitis B, HPV, and hepatitis A. So colour schemes for each of them. So that was last September, and that sort of carried on then throughout the year. We would constantly put up messages just around vaccination. So the other thing that happened last September as well, if you remember, there was a slight uptick in MPOX. So we worked with communications group and Empower as well, just to put out messages reminding people when the vaccine system is still up and going, that there was vaccines there available, and to get vaccinated if you haven't already. So the European Testing Week, which comes around twice a year in May and October. And then World AIDS Day, so we supported the Positive podcast at World AIDS Day last year. There was a special night in the George with charity case. So we did sexual health messaging around it, and Robbie invaded it, like lots of HIV, stigma, talks and education in between the acts and everything. So and we're just really delighted to support that night. It was a great to boys. So again, we've some Shigella awareness. This is sort of phase 2. It was travel advice, so people who are traveling abroad, just to be aware and to practice safe habits and healthy practices. Like washing your hands actually has become a very important piece of advice, no matter what the situation. It's always good advice to wash your hands. And we have Christmas sexual health messaging as well. So at this stage, we worked with the HPSC, and thank you very much, everyone. And various stuff there. So again, it's about Shigella, so we mentioned the Mpox, Shigella, here's where you get condoms, get vaccinated. So that was in the lead up to Christmas. And again, GCM, just to say thanks to them, they're always supportive. If we need to put any information up, they do that for us in editorial. So again, looking at what we did, a new website, which went live last September, and then during the year this year, we did writing guidelines as well. So you see that we have a sort of new look. Which is very distinctive, and I think this really helps our branding as well, and awareness of Man to Man and sexual health messaging. And then this is chronological. So earlier in the year we did these leaflets, and I'm really delighted about some new Shigella design with the toilet paper and everything, so we think that's really good. Again, we work really hard with the Sexual Health and Crisis Pregnancy Program, Caroline and the HPSC on these. So everything's forensically done on David as well. So yes, there's a HIV PEP leaflet and the Shigella ones. And we're also going to do the other love bug ones, but we're waiting to see docs, so that information might have to go on there, so we might just pause the updating on them. So yes, the hepatitis B campaign, so this is very good. I was talking to learn about this the other day. It's actually a really good case study because it was a beginning, middle, and end to this campaign. So there's the sort of like a list of things that we did, as a concept group, and just a strategy in place for leaflets. We got Robbie to do a reel with us as well, just to reach the community. So the focus was really to let people know that there was an uptick in hepatitis B and to get vaccinated if they could. And that's why the vaccination was available at your GP. If you had a medical card, it was free. If you didn't have a medical card, it might be free. So yes, there's just some carousels and posters that we worked with. So we used the vaccine campaign in the step that we previously used in September of this year. We were able to segue into that very quickly. So we got that. Bus shelter. I'm not going to play this small bit because we're going to see Robbie again later, so I'll just zoom on through that for some time and stuff. But it was really great. We had 35,000 watches, views of that. So we use Grindr as well, and some of the messages that we got last year, you shared it for less chemsex, that this year shy with chemsex and hepatitis. We also have these Grindr for equality ads, and those stats are from 2023, and 17,000 different Grindr users, 24,750 messages were opened. They said they just website, and the Grindr for equality team then they did this for us in January, just requesting what you get up uptick in that, which is still ongoing. Then we do European testing. So this year we sort of do a push on testing, like we do testing messages all the way around. But and during those 2 weeks we do a specific push. We got the new branding, of course, and we used the old testing, I think it's his name. And then we did a carousel on rapid testing, just where everything's available in Ireland. We work closely with our partners, it's the Sexual Health and Power Project. Gosh. So the other thing we did this year, we evolved. Last year we did Proud and Prepared, but this year we sort of upped the game as well. And we got a new Proud and Prepared landing page, which is to proudandprepared.ie, brings you to the web page on the Dublin Pride website, with lots of sexual health information and links to all the sexual health resources in Ireland. So we have posters, Taylor Swift and Pink concert, Instagram reels with SMEs and influencers, parish tales, 2-page spread at GC and Pride, tote bags, vinyl masks, and this year we have Belong working with us as well, so thanks to them for all of the work that went into that. There's 8 posters, tote bags, and we also had a stand on the day at Pride, so we give out free condoms and information about hepatitis and Shigella and our Proud and Prepared movements. And thanks to Brendan and Health for all that as well. There's carousels and examples. So one of these, this is one of the reels that we did with Keane Griffin, who's actually in the news this week.
Hey, Dorian, my name is Keane Griffin, and mental health is really important to me, obviously, as an ambassador for November. And I find to look after my mental health, it means surrounding myself with people that I like and can enjoy being myself around, and keeping fit. So I go to the gym, and I also play football, Gaelic football, not soccer. There's a difference. Gaelic football in America, Ireland's first LGBTQ plus inclusive GAA club. And for me, sport was something that was very daunting as a gay man, but playing in a club with people that are like me keeps me active, which in turn has an effect on my mental health. And it's all full circle for keeping fit and keeping happy. But for more information, head to proudandprepared.ie.
We're really delighted with this collaboration and sending it to that page. We also did, as part of it, these various carousels. So we did a section on drugs and alcohol, mental health, chemsex, etc. Again, thanks to Belong to Indeed for working with me on that. We hope to do it again next year. And thanks to Dublin Pride as well for bringing us all together. And the other thing we did this year was we just collaborated with drugs.ie, so they created a video for the block party, and we had a quick little pop-up banner there, which I just got back this morning, and we got free comments and everything, sexual health information at the drugs.ie tent. So it's just great to collaborate and work with other groups and people because it's all about it. So we want this as well. So the other thing then, we did having listened to the chemsex sessions of that podcast, which is absolutely brilliant, and we're working with you also. We decided to do an ad for Gays Film Festival. The sort of call to action is to go to our page where we have information, where we link to the Empower Sex Guide section, First Aid Guide, Sexual Charity First Aid Guide. We link to the podcast chemsex sessions, and we also just got our harm reduction advice and the supports around the country, so Sexual Health Centre, Empower, drugs.ie, etc. So.
Hello, gays, festival goers. He's Robbie Lawler.
And they are Beta Lady.
And we are the Pod5 Podcast.
The name this evening of the podcast is called Chem Session, which explores the use of drugs and sex together in the queer community.
And we provide a little bit of chemsex education for all the chosen family. For example, do you know what Tina is?
Tina is crystal meth.
And do you know how addicted Tina is? She is more addicted than Drag Race, baby.
We need more important conversations about consent, caring for each other, and how to use drugs properly.
Mama, kudos for saying that, for spilling. We want to be chem safe and practicing active consent at the sex party.
So whether you're a happy user or feel that you're developing a dependency on drugs for sex, we want you to know that supports are available for you.
Make sure to check out Oswald Podcast and visit man2man.ie/chemsex for harm reduction advice and support.
So remember to stay safe.
Stay sexy.
So that's my music.
And now it's time for some raw, uncut, queer as folk gays cinema.
Huge thank you to Robbie and David for that great teaching and to stuff together again because we are doing amazing stuff in the community and just so the other thing then is our filmmaking waves, which premiered last year at the Gays Film Festival. So you see there's where it's sort of appeared since. Offline Film Festival appeared at the Canton Festival in Washington in the USA, and it's going to appear. It's going to spring this weekend, of course, Home Pride, and next month it's going to be at Guinness Pride as well, and there's an event there with the director and some cast members. So we're thrilled and delighted with how it's done and on a certain journey. And we played that actually last year at the conference. So this is just to say thanks. I had names down there so that I can't name because I'll be people after it. Thank you all, like Mary, Caroline, Derval, Fiona, and so everyone on the GHM board who did loads of work. Thanks to Launch Constitution, Drugs.ie, link, Pulsify, this one's down there. And look, the artists, I said artists and designers like Lavender, Colin, who did the Brown Beard, and Morris. I can do my job without all of you, so thank you.
And coffee. We'll see you all back here in 20 minutes. Just on some housekeeping bits, I've asked that the speakers, probably me most of all, speak directly to microphones. That would be really helpful for everyone. And I think the room is getting warmer, which is good news. Yes. Oh, you're too warm? I'm not. Okay, so we're going to get restarted. Our next speaker is Padraig Rice from LGBT Ireland. Padraig is a policy research manager with LGBT Ireland. He previously worked as parliamentary assistant in the Oireachtas and as the coordinator of the Gay Project in Cork. He has a master's in public policy from the University of Oxford and a law degree from UCC. Padraig was recently elected as a member of Cork City Council, and he is the co-author of the report on Ireland's national LGBTI+ strategy. Thank you very much.
Hey, good morning, everybody. As David said, my name is Padraig Rice, and I'm the Policy and Research Manager with LGBT Ireland. And I'm the co-author of this report on Ireland's national LGBTI strategy shadow report. And over the next 10 minutes or so, I'm going to talk you through the report's findings or analysis and recommendations. It's important to note from the start that the formation of the national LGBTI strategy in 2019 was a significant step forward in the relationship between the state and LGBTI people in Ireland. For the first time, there was a coordinated cross-departmental plan to respond to the unique needs and challenges of the entire community. After wide consultation and examination, this report is our assessment of that plan. As the title notes, a lot of progress has been made since 2019, but a renewed effort is now required to fulfill the outstanding actions and to address the challenges. Before we get into the detailed reports, I just want to spend a moment talking to you about the 400-year history between the community and the state. I think this puts our work in context. So as you'll see, from 1634 until 1993, sex between men was a criminal offence. Until 1861, it was a capital offence punishable by death, and this was replaced by penal servitude for life. These laws remained in place for 70 years following the foundation of the state, until they were repealed by the Criminal Law and Sexual Offences Act in 1993. That is within many of our lifetimes, and that leaves a long legacy of structural and systematic homophobia. In the 31 years since decriminalisation, we have travelled a long and winding road towards greater levels of equality, diversity, and inclusion for LGBTI people. What followed decriminalisation was the Employment Equality Act, Equal Status Act, Civil Partnership, Marriage Equality, Gender Recognition Act, and most recently, the Assisted Human Reproduction Act. These changes were historic and seismic. Communities that were once hidden are now visible, things that were once criminal are now celebrated, and through this process, our collective understanding of sexuality and gender has evolved and continues to evolve. Key to that evolution and progress was the first national LGBTI strategy. The National LGBTI Strategy was launched by Minister Charlie Flanagan in 2019. Speaking at the launch, he said, "I want to set an ambitious vision for Ireland, where the end goal is full equality for LGBTI people. The aim is for Ireland to be a place where everyone, regardless of their sexuality, gender identity, or expression, or sex characteristics, can reach their full potential to live a healthy, safe, and fulfilling life, and participate fully in Ireland's economic, social, cultural, and political life." He went on to say, "The most important thing now is our focus, and that turns to implementation of the strategy, which will depend on our shared engagement of all stakeholders in building a fairer society that allows everybody to flourish." Our report seeks to measure and evaluate the implementation of the strategy from a community perspective. The strategy, which includes 108 actions, was envisioned to run until 2021, but was extended until 2023 following the onset of the COVID pandemic. During that time, there was a change of government, and responsibility for the strategy moved from the Department of Justice to the Department of Children, Equality, Disability, Integration and Youth. And this was just two of the challenges faced. Our full report runs to 30,000 words and examines all 108 actions. I'll speak just a minute about the methodology of our report. The shadow report process began in June 2023, and the central document we used was the government's tracker developed by the Department of Justice to keep track of the strategy's progress. Using a combination of departmental reports, parliamentary questions, news articles, and government publications, an intern at LGBT Ireland, James Morrison, reviewed the government's actions. This initial evaluation was our jumping off point for an organisation-wide review where we got additional input and information on the actions were regraded accordingly. After this, a second review, we had some knowledge gaps remained, and these were filled when LGBT Ireland met with several other NGO stakeholders who had more intimate knowledge on the progress on specific actions. Their feedbacks and comments on the progress of these actions were noted. Incorporating all of this information together, we wrote a progress narrative on each of the 108 actions on the inclusion strategy. This section was written as objectively as possible. It records the facts as known to the best of our ability and based on the resources available to us and the information provided. Following this, we have a progress section and we have an analysis section, and this provides kind of a subjective commentary on the progress of each action, notes the changes in government, in context, and social context, and suggestions for improvements. These sections are subjectively the views of LGBT Ireland, although the views of other organisations are also included. For the final report, LGBT Ireland adopted a letter grading system, and this is similar to used by the Children's Rights Alliance in their annual report card, and it grades from A to F, A being excellent progress and F being no progress or outcomes. Initial draft report was circulated to other organisations working in the area and to provide feedback on their opinions on the actions and on the narratives, and this feedback was incorporated into the final draft, and then the final report was presented to the government departments in October 2023, and the government departments were given an opportunity to issue corrections and feedback on draft, and then it was regraded accordingly. So that was the method for our report. So then we have some of the, here's an overview of some of the outcomes. In particular, I want to focus on some of the health outcomes. You see there's different categories there. So there's visible and included and treated equally. And you see the outcomes for each action are graded, as I said, on an A to F, so there's different grades there. But I might talk through just some of the health outcomes, which are here, which are outcomes 14 to 20. As you'll see, there's a range of different grades on that, going from A in some areas down to F in particular in relation to trans healthcare. I'll give you just a sample of some of the grades and some of our common grades. So outcome 14, for example, which was healthcare providers are trained to understand the identities and needs of their LGBT patients and avoid making heteronormative assumptions. So for that action, or that outcome, we graded a B and noted that a significant number of healthcare providers had received training in different forms, and the training programs should continue to be scaled up to ensure adequate training opportunities are available to healthcare staff. And we continue through the different outcomes, grading them set on an A to F basis. Some of the ones where we did particularly better, there's outcome 17 there, which has got a grade, an A. So that is the LGBT community, particularly the MSM population, are made aware of the risks of contracting HIV and other STIs and the importance of regular testing. For that, outcome was graded an A, and we noted that when the state and civil society work together, the outcomes for the community are greatly enhanced, and nowhere is that more evident than in sexual health promotion. And the Sexual Health and Crisis Pregnancy Programme must be commended for its partnership approach to positive outcomes it produces. On the scale where we've got F, there's two of them there in relation to trans healthcare and intersex. And outcome 19 in particular was graded an F, which was people wishing to transition their gender have timely access to treatment that accords with international best practice. The government's failure to provide adequate access to trans healthcare is a cause of great concern. Outcomes in this area are disimproving as the waiting lists grow and services diminish. The failure is having a significant impact on people's mental and physical health, and the outstanding actions must be progressed as a matter of urgency. Also, in terms of outcome 20, which said that better data will be available on the prevalence of intersex conditions in Ireland, and consideration given to appropriate clinical governance in the context of international evidence and guidance. As with trans healthcare, the failure to make progress on intersex actions is a deep cause of concern, and significant human rights concerns remain unaddressed, and this constitutes a failure on the part of the state. So we went through all of the outcomes and then each of the actions as well. So you see here an example of how we produced it in the full 30,000 word report, where we have the specific action which falls in one of the outcomes. This is an example of 17.4. We gave a grade progress analysis
progress report and then analysis, as just an example. And we've done this with all 108 of the actions. So if there's anyone in particular that you're particularly interested in that relates to your own work, have a link to the full report and you can dig out a particular action, and we have what we think is the progress that's been made, and then our analysis of that, and that full report is there. Might quickly just talk to you about some of our analysis on the process generally. So there was a really good public consultation, probably one of the best consultations with the community before the strategy was formed. However, there was significant gaps in the strategy formation. There was things that were included in the public consultation that didn't make it into the final strategy formation, and there's questions in terms of why some of the community's priorities didn't make it into the final government strategy. There was also some structural flaws with the strategy, and some of the actions were vague, hard to measure. Some of them were beyond, were unclear, were beyond the scope of government action. There was also questions in terms of the depth of impact. So some of the actions were deemed to be achieved through minimal impacts, while others required much greater levels of impact. We also had questions about the wider influence in government policy. In some areas, it seemed like actions were being squeezed into the strategy, whereas others, the strategy was the guide for the actions to be taken. There's particular gaps in relation to people with disabilities, older people, and intersex people, and as I noted, a lack of progress in relation to trans issues. It's also worth noting that there's a change in circumstances with the onset of the pandemic, the war in Ukraine, the rising far right, and other challenges as well. Finally, just quickly through some of our recommendations. So we have 10 recommendations. First is that there should be a new national LGBTI strategy. I'm very glad that the government has started that process, and they're in the middle of working on a new strategy. We're calling for this to be a whole life approach that takes in youth as well as adults and older people. Our call in the report was for a new public consultation, and that has started, and there's been already some engagement with the community on that. In the development strategy, we think more attention needs to be paid to international best practice, using examples from Iceland, Malta, and elsewhere. And that the actions need to be more specific, concrete, measurable, and achievable. The needs of trans and bi and intersex people need to have a significant focus in the next strategy, and it needs to be the intersectional gaps need to be addressed and given serious consideration, in particular disabled people, travellers, Roma, migrants, and asylum seekers. And also, we believe that greater care should be taken to align the strategy with existing government commitments and actions and other future strategies. And we'd like to see better ongoing evaluation of the strategy, in particular with subgroups that involve expertise in various areas, including around sexual health and other areas, and that will be properly resourced. If anybody wants to see the full report, it's available on our website. That QR code will take you to the full report. And we also have a summary version as well. And as I say, the next strategy is currently in formation, and we hope that our review will be part of forming the next strategy. And if anybody does have particular inputs they'd like to make around the strategy, LGBT Ireland and others will be inputting to comment on that, so do get in touch. That's more email address there. Thanks very much.
I think thinking about all the people getting their Leaving Cert results today alongside the grades that were coming up on the screen. It was a lot. Thank you, Audrey. Next up, we have in a change in the schedule, we have Diego Pagetta from Empower. He's going to give the annual report. So Diego is one of the outreach workers for the Empower program, and he's going to speak to us about their work this year.
It was a good try. I love getting people to try to pronounce my surname, because that's my revenge for me not being able to pronounce Irish names. So guys, thanks for having us here. So today it's gonna be very short and sweet. Just gonna give you an update of the Empower program from 2023. So here in the picture, you can see there is Adam, he's the program manager. There is myself and Mark, we are the outreach workers. David is the program coordinator, and Andrew, the chemsex coordinator. And the Empower program, for those who don't know, we do outreach, and we started the program in 2016, so which is meant to think in 2 years we're going to be celebrating 10 years, which is great. So what we do in the program, so our main focus is responding to the sexual health and the well-being needs of the GBMSN community. Focus mostly here in Dublin, because there's always people coming and going. There's kind of like, we get people from other parts, and we are peer-driven, we are community-led, we're doing community-led interventions. We are 100% sex positive, we have no judgment free, and we are also always looking for harm reduction days, because we believe that's part of our ethics and philosophy in our program. And the aim in the end, it's always to try to treat HIV and STI, decrease acquisition here in Ireland. So what we do in the program, so we have different things we do. We have rapid HIV testing that's done by our volunteers in the bars and also in our house in Capel Street. We also do HIV self-testing. It's home HIV test that people can go to our website and order it, and it's delivered to their house. We do outreach work, which we do mostly online, but also if someone wants to do a face-to-face, we also available for that. We also collaborate with our colleagues in the HSC and also in the clinics to respond to outbreaks like the Mpox, which is the hot topic at the moment. We also involved in chemsex education and also in research and advocacy. So in terms of events that we participate in 2023, as you can see here in the picture, there is Adam. He was in Chicago presenting a poster, and the two pictures below, it's us in Berlin for a very interesting meeting. We had that I would say more in here. So Adam, he went and presented a post in the World Congress of HIV and STI in Chicago last year. And the title was Building Trust in Risk Communication and Community Engagement during the Mpox outbreak in Ireland. And then himself and Davey went to Madrid, where they highlighted the importance and different European testing week campaigns that the Empower delivered here in Ireland, and the impact that they had of testing uptake, and also doing a linkage to care. Because one of the things I think the analogy I like to do in relation to the program, it's because we communicate between the community and their needs, and how that's translated then to clinicians and to the HSC, and how we can manage working together and building that bridge between these two worlds that I think is the most important, and I think works well in terms of like bringing the community language to a biomedical world and try to make them understand the community side, but also bring the biomedical side to the community and get them to understand reasons that sometimes things cannot be done the way they are expecting to be done, and but always like information and research. And then in the end of the year, we went to Berlin and for the AIDS Action European GBMSN annual meeting, which was very interesting. We were able to learn from our colleagues abroad what they were doing, but also to showcase what we were doing here in Ireland. And I can tell you we are not far behind any of them. And then at that same meeting, Mark, he presented a paper on the benefits of Grindr as an outreach tool to engage rural-based and not out gay, bisexual, and other men have sex with men. And now everything is social media, we are there too. So we have our website, which is the Empower website, that in last year we had 86,819 page viewers and 46 website users. And we are also on Facebook and Instagram with 653 and 3,412 followers respectively. And I think that's Andrew on TikTok, probably. In terms of campaign, last year we were involved in the Looking For Now, which is a campaign that we had some beer marts and posters in bars, just highlighting how easy it is nowadays to be able to do a HIV rapid test, and there's the poster there. We also did campaign for the European HIV Testing Week, the Irish AIDS Day, the Quick Guide to Pride that we collaborate with Mother, and campaigns for the World AIDS Day. And I think one very exciting campaign we did was a collab with Grindr, which we're very excited and happy to be involved in that, because Grindr, as we know, is the biggest platform for hookup apps, and was the first kind of this collaboration they've done outside of the US. That if you see the poster or the Empower HIV self-test, that would pop up in the app, and then the users, they were able to click there and they would be directly straight to where they could order the test. In terms of the HIV, rapid HIV test, that's all our volunteers that we are delighted to have them. Last year we had 50, and they were delivering testing for different venues. And they did 175 sessions with 778 rapid tests performed. From those, 5 came as a reactive results, and they all been linked to a sexual health clinic to do a confirmatory test and be linked to the care from there. 20% of those, they were the first time testing, and 99.4% of people testing, they was not reactive. So we also use as a harm reduction approach this opportunity to keep informing them of novel technologies that are coming, and also old-fashioned condoms as well, to keep them informed to make the decision they want to. And we also give them a feedback form, because it's always nice to know what we are doing good and also how can we improve. And just like nice message that we get from them, for instance, amazing service, so professional, I am a nurse, congratulations all to the team. In terms of the HIV self-testing with the home kit, they go to our website and they order the kit there. Last year we did 2,514 tests that were sent, and 2 came as a reactive results. They also were linked to care, and 53% of people accessing that service, they were not born in Ireland. 17% was their first time. 100% they were GB MSN. But also we have 79% that did not report their results. So those numbers we have is based on the results we received back. And also just a survey that we send out, and it's nice to hear, like, living in rural Ireland. This was just a convenient and sweet, suited me perfectly, and also the package, they are very discreet, so they can be delivered to their home in case they don't want anyone to know exactly what is being delivered to their house. In terms of outreach, which I'm more involved, and I'm one of the outreach workers, we had 1,918 contacts last year, 42% in hookup apps, but we are seeing an increase of people reaching out to us through WhatsApp because we have all our numbers in the website. So if they are not on Grindr or any other hookup apps, they can reach us out through WhatsApp, which is a nice way as well, because it's not just message. Sometimes they want a phone call, and it can be convenient for some of them. So from those, 92% was the MSM, less than 1% sex workers, 43% they were not born in Ireland. And we also in the outreach, we do condom distribution. And as you can see, it is still going on. That was 2023. Also, again, just feedback coming from the service users. I was quite worried regarding the testing, but the guys helped me a lot and made things easier for me. I thank you for helping me out and got my confidence back. Because one thing, even though we are so advanced and progressed and we have all this new technology coming, and the MSM nowadays, we feel more comfortable, but yet still stigma. And it's nice for them to be able to link with us, and also having us to connect them to service that they can get the treatment they need, or even just for a quick test. Try to break the barriers of accessing service, and also barriers to themselves to be sometimes judgmental towards healthcare workers, think, oh, I'm going to be judged, and then when they arrive in the clinic, they have the best time of their life. So I want to just give a huge thank to the Sexual Health Pregnancy that funded us since 2016. And also a big thanks to all the healthcare providers in the clinics, because even though they are very busy, out of the door, like Fiona said, every time we meet, we give them a call. They always make space to see the referrals that we send to them. And thanks to all our volunteers. And thank you.
Thanks, Diego. I'm delighted that people are having the time of their lives. Our next speaker is Kelsey Doyle from Belong To. Kelsey is also on the committee who was organising today, so thank you very much for that, Kelsey. Kelsey's a youth worker at Belong To, and works on LGBTQ plus kind of sexual health, I suppose. As part of her role working with young people, she provides sexual health harm reduction education. Kelsey has 6 years of experience in the youth work field and has been working at Belong To and the young people supported charities for over a year. She has a master's degree in community and youth work from Maynooth University and is passionate about empowering young people to become agents of social change for themselves, their communities and society. Thanks, Kelsey.
Hello everyone, my name is Kelsey, as you know, I'm delighted to be here and I always love an opportunity to really listen. So as David said, I'm a youth worker at Belong To LGBTQ Youth Ireland, and over the past 20 years, Belong To was grown from a youth project into a unique national service and advocacy organisation with aim for LGBTQ plus young people. So the voice of LGBTQ plus young people inform all our work across youth work, education, training and campaigning as we move to create an Ireland where LGBTQ plus youth are equal, safe and thriving. So my role in Belong To involves working directly with LGBTQ plus young people on a daily basis, and I work with young people who are at different stages in their journey finding themselves. One of the recommendations in Ireland's National Sexual Health Strategy is to support all young people in addressing issues that impact on sexual well-being, such as stigma, homophobia, gender, ability, disability, mental health, alcohol and drugs. So as a queer woman, I know from experience that sexual health for lesbian, bisexual and trans women is very far and few in between. So that's why the Sexual Wellbeing and Intimate Relationships for Lesbian, Bisexual and Queer Women resource that was created by Link is very important for queer women and non-binary people in our community because it was one of the first of its kind. In 2024, Belong To and Trinity College published Being LGBTQ+ in Ireland, the national study on the mental health and well-being of Ireland's LGBTQI+ community. And in this study, a 21-year-old lesbian woman said, "Smear tests on lesbians, still can't work out if I need one. So the last test, nurse told me while trying to insert the speculum that I didn't need one because I had never had sex with a man. I actually have, but she assumed I had not, as she knew I was married to a woman. I'm not sure that is true, I don't need one, even if I had never slept with a man." So that was quite alarming, but not shocking for myself as a queer woman anyway. And this post shows us what most people in this room already know, that there's not a lot of awareness or resources available for queer women around sexual health. So many of us also know that there's a lot of stigma in our community around queer women's sexual health. And one main source of this stigma is the false idea that queer women do not need sexual health education. So when the queer community feels stigma about our healthcare needs and healthcare professionals have the perception that this need does not exist, our LGBT+ young people suffer the consequences. LGBT+ young people miss out on the opportunity to learn about positive relationships and sexual health as a result. So in 2021, Belong To spoke to over 2,000 LGBTQ+ young people about their mental health, sexual health and overall well-being during the COVID-19 pandemic. Among young people aged over 18, 46% had been sexually active during the lockdown, and of these young people, just over half used some form of protection, and only 1/4 of these young people had a sexual health checkup. 21% of LGBTQ+ young people aged over 18 did not have information on safe and supportive LGBTQ+ friendly services and how to access them. 12% of LGBTQ+ young people aged over 18 avoided attending a clinic due to fear of staff being unaccepting of LGBTQ+ identities. And in addition to this, LGBTQ+ young people in rural areas were reluctant to discuss their sexual health with their local GP for fear of being outed. So this research reflected much of what Belong To knew from our frontline service and from working with the National Network of LGBTQ+ youth groups across Ireland. A lack of knowledge, cost and a lack of access in rural areas are key barriers to accessing sexual health care for young LGBTQ+ people. So several years ago, Belong To developed In The Know, and to respond to the identified need for sexual health training for gay, bisexual and trans men. For young people, In The Know participants learn about sexual health, online dating, consent, chemsex and HIV prevention over a number of sessions. Within this program, Belong To also offers In The Know facilitator training for those equipping gay, bisexual and trans young men with information about sexual health, consent and well-being. So this program is a partnership project between the Sexual Health Centre, Belong To and the HSE Sexual Health Crisis Pregnancy Programme. So through this initiative, we aim to equip youth workers, community workers, sexual health workers and other appropriate professionals to deliver the In The Know programme to the young service users. In The Know has been a huge success and has highlighted the absence of similar programmes for lesbian, bi and trans young women and a general lack of awareness among healthcare practitioners with the sexual health needs of this group. At Belong To, we decided to do something about it for our LGBT+ youth, and we believe LGBT+ young people have a right to sexual health education, and we want to provide that for them. So the HSE National Social Inclusion Office supports an initiative that enhances healthcare delivery to the LGBTQ+ community and will be supporting Belong To develop a toolkit for LGBT+ young people aged 17 to 23. So we aim to identify the sexual health needs of this cohort of young people. This toolkit aims to provide access to sexual health information for young LGBT+ women or for anyone who works with queer young women within this age bracket. At the moment, we are very excited to be in the planning stages of this project, and so far we are mapping out the toolkit and what information the toolkit will contain. So our key aims for this initiative are to empower LGBT+ young people to have better sexual health, to increase the knowledge and understanding of youth workers working across key sectors on issues affecting LGBT plus young people, to ensure age-specific training for young LGBT plus women who have reached the age of consent, to help professionals identify the specific health and well-being needs of LGBT plus young people compared to other cohorts, and to break the stigma around LGBT plus women who engage in any sexual activity with other women and the idea that passing STIs is near impossible. Is to take a harm reduction approach to equip LGBT plus young people with the knowledge and skills to be able to protect themselves when engaging in any sexual activity, and to provide young LGBT plus women with safe space to be able to access sexual health information and identify health clinics in their local area. It's also to develop comprehensive training for addressing the sexual health needs of LGBT plus individuals, emphasising consent, healthy relationships, and fostering a positive outlook on sexual health among LGBT plus youth. So we plan to launch this sexual health toolkit for LGBT plus young people in 2025, and we hope that the toolkit will reach as many LGBT plus young people across Ireland as possible, and we will be a vital resource for anyone who may find themselves working with LGBT plus young people. So next year, I hope that I'll be here with you all again and talking about the toolkit and how it has positively impacted the lives of LGBT plus young people. And if anyone is 17 to 23 and is LGBT plus or works with this cohort of young people and would like more information on how to get involved or anything really, I'm going to be here all day, so you can come and ask me. Well, thanks everyone.
Thanks very much. Listening to that, I was definitely one of those health professionals at one stage who didn't think that queer women needed sexual health intervention, so I think it's so important for us all to kind of be aware of that. Our next speaker is Hannah Kelly. Hannah is coming from Outhouse. She is the Programme and Services Manager there, and she's going to talk to us about some of their new requirements.
The worst part is actually walking across the stage to that's finished. So my name is Hannah Kelly. My pronouns are she and her, and I'm the Programme and Services Manager in Outhouse. I'm here to talk mainly about our community casework service, which is the new service we launched this year in April. But I'm going to start by giving a little bit of context of how we see support at Outhouse and the framework, I suppose, that we work off. So at that green section at the top level, is our universal and preventative support. So at this level, what we're trying to do is essentially it's a vaccine to prevent people from needing more specialised or more intensive care at the centre or elsewhere. So here we have things like our social groups, which provide community social connection, building community, which can help protect people's well-being and stuff like that, as well as our information referral and signposting service, where anyone can drop into the centre, give us a phone call or email us and look for information, whether it's a referral to a different service or look for some support within the rest of the support that we offer in the centre. So the next level, the purple section there, is our support function. So here's when we move more into a directive here, the aim of what we're providing is support. So at this level, we have peer support groups and our personal development courses. And so some of these are already in existence, and some of these are in flux to be created over the next coming months and years. The next section then is our intervention, and so here is our community casework, what I'm here to talk to you about today. And I suppose that service is a one-to-one service where someone who maybe has a little bit more complex needs or who needs a little bit more time to talk about what exactly it is that they need in terms of their support. The final section then is clinical, and that's something that is beyond our capacity or the scope of the centre currently, and where we would make a referral to other services that can meet that need, while also trying to loop them in with other services that we do offer in the centre in the meantime. So the community casework service, to give a bit of context as well, the support function. The team at Outhouse is myself as the manager, and we have a part-time key support worker who delivers our community casework service. So essentially it is a one-to-one service that provides key support services and direct advocacy to patrons of the centre. And the service is patron-centred and fits the needs of each patron. So for some people that might be some direct advocacy, us knocking on doors and trying to figure out what the right service or support that they need. Or it could be us working with a patron to create an individualised care plan where we're setting out goals and what they want to achieve over the next number of weeks, and figure out how we can help them in that journey. So the key to the service, and I suppose what makes us unique, is the flexibility and our ability to be quite flexible and to provide that time and space for a patient to figure out what it is that they need and how that can be achieved with our help. And so patrons can be referred to the service for a number of different reasons. Maybe they have a significant emotional, mental health, relational or economic needs or challenges that they need some support on. It could be that their needs cannot be met through our information referral and signposting function because maybe they don't know what referral they need, or they're not sure what's out there and they need a little bit more time to talk through their options. And it could just be someone that their needs would be better served if they had a private space and a longer time to kind of flesh out what it is that they need. So what we currently don't have the capacity to do, or what the service isn't. So the service is not counselling or therapeutic intervention. Instead, it focuses on building resilience or capacity for personal development or growth at their level of need. So the following things then are currently outside the scope of the service, which is people under the age of 18, people who are currently suicidal, because obviously this is an emergency presentation and we have to deal with that as such. People who are currently not capable of engaging in their own personal development, or who are not committed to the process of community casework or engaging in the outbound referrals that we might make. And then finally, people who present under the influence of drugs or alcohol while accessing the service, so we can deal and support people who are going through addiction, but if they're presenting at the centre under the influence, we wouldn't be able to facilitate that. So who is the service for? So the service is for any LGBTQ plus people of any different ages, backgrounds, experiences, or presenting issues. There's lots of reasons why someone might need to access the service, and we don't work off an exhaustive list of things that we will work with or won't work with, and instead we're quite flexible to what presents. So some of the things that might be is a patron who is homeless or is at risk of homelessness and is struggling to navigate services or has never registered as homeless before, a person who's struggling with their identity or acceptance and who's not ready to engage in social groups or peer support groups, but is looking for that connection to the community. And so I can talk through a little bit more on our learning so far. So since we've launched the service in late April, we've had 41 patrons come through the service so far, and on average patrons need 2 to 3 sessions with our key support worker, although some might need a little bit longer than that. So far some of the things that we're seeing come up, so asylum seekers or refugees, that's a big area that is coming through the service, and it could be that they need very practical support like help with housing or reporting issues with living conditions in direct provision centres, or access to healthcare, but also can be a more personal development or a slightly different piece where someone is looking to integrate more into the community, is looking to make friends or build community when they arrive in country. The next issue then is homelessness, which I kind of mentioned already. So this could be referrals into homeless services, into emergency accommodation, but it also can be someone who's been kind of going through in and out of homeless services over the last couple of years and is looking for a way out of that and is looking to maybe, help with budgeting, help with looking for jobs or whatever it might be. Transphobia and trans safety then, if someone's looking for a safe or trans-friendly healthcare, so a GP, or is looking to start their transition and wants someone to hold their hand through that process, we can be there and kind of act as the LGBT lens when they're going into those spaces. And then just generally then for people who are just coming out or who haven't come out yet and who are exploring their identity and again, maybe don't have that confidence to engage directly in our social groups or peer support groups, but instead want to talk one-to-one to someone before they're ready for that. So some other information about the service. So typically we can offer a maximum of 6 appointments. And then, as I said, some people only need 1 session, but some might take a bit longer, and we are a little bit flexible on that as well. So generally, the appointments do happen in our centre, but we can facilitate sessions on the phone or on Zoom as well. And so if people are outside Dublin, or if people have some sort of a mobility issue where they wouldn't be able to get up 70-minute flights of stairs in our house, then we can facilitate them other ways. And then we can also facilitate and do facilitate multi-agency care where needed. So often what we see ourselves in here is sort of like the LGBT lens to bring things together or to help educate when needed, and so that the patron is getting the care that they need. So how to make a referral. So we kind of, when we launched the service in April, we kind of soft launched it, and it was mainly just patrons where we referred them in directly. But we are at a point now where we're ready to take outbound referrals, and so you can fill in. I have a QR code in the next slide as well for people to fill in a quick Google form, and essentially we're just looking for details, brief reasons for the referral, and then at that point our key support worker will be in contact within a week to arrange their first appointment, and there we assess their needs and kind of develop a plan for how we can work together. So yeah, that's the service, and this is the referral form there as well, and yeah, if anybody wants to talk more about it, I'll be here. Thank you.
I think that's such a good example of like if you build it, they will come, because even though it was soft launched, we've sent referrals and it's been really successful. So thank you for that as well, Hannah. Next up, where are we? Next up, we have Ellen Campbell. So Ellen is a PhD researcher at the University of Amsterdam, working on the topic of HIV and assisted reproduction. She's a senior researcher and evaluation lead at RISE, a project based at RCSI that aims to tackle stigma within healthcare settings through education interventions led by people living with stigmatized conditions, starting with the issue of HIV stigma. So Ellen.
Okay. Let me see. Okay. So first, I just wanted to thank Bill and the organisers for inviting RISE here today, and we've been really, really pleased with the positive feedback and response since our launch back in June. And today kind of marks the start of our promo tour for the year ahead. So, RISE stands for Redefining Institutional Stigma Education, and we hope that it will be a platform for educational interventions relating to various stigmatized health conditions, and hopefully will be integrated into healthcare curriculum going forward. But our main focus at the moment, starting off, is HIV stigma. So RISE consists of, at the moment, a free online course that's aimed at people who are either studying to or already working in healthcare and clinical settings. And it was developed alongside several people living with HIV, members of the community, and clinicians like Professor Fiona Lyons, who's here today, and some nurses who are living with HIV as well. It covers both the basics on HIV and stigma, and then it's guided predominantly by video clips from people living with HIV and role-play videos with actors that show examples of positive or stigmatizing interactions in healthcare settings. So today I'm here on behalf of the team, who are Dr. Owen DeBarra, Dr. Amir Bashari, and the infamous Michael D, who many of you might know from Instagram. And these are some photos from our launch back in June, which I know some people here also attended, so this might be a little bit repetitive, I'm sorry. I also want to give an honourable mention to Aoife, who's there in the photograph, who joined us that day to make a speech, and she also contributed a lot to the development of the content within the module, and also for all of the work that she's done over the last year for combating stigma for people living with HIV, especially women. So just to tell you a little bit more about the course itself, it's free to enroll for anybody who wants to do it. I will show this again at the end so you can take a photo of it then. And I also wanted to mention at this point that if you are a qualified doctor, this does go towards 3 credits of CPD for the year, because we do have accreditation from the ORCPI, which is brilliant. So during the development of the course, we carried out a needs assessment survey among students and healthcare professionals. And then we wrote an extensive report, which I have some copies. I only have 4 here with me today because I only flew in from Amsterdam yesterday, and the key to the ORCSI office, I really don't know where it is. So I can send them to you online, or I have like 100 of them in a box that I'll figure out how to get to you after. Yeah, we wrote this report following the survey, and I'm now going to take you through a few of the main findings from it. So to give you just a snapshot of who took part in the survey, we had 117 people in total. Most of them were medical professionals already, with a good mixture there of doctors, nurses, and then some others. And most of them had been working in the field for at least 5 years at the time of taking part. And then in terms of the students, most of them who took part were in their final year of study, so were already pretty experienced when they took part in the survey. And even though we did have some, I think 20 participants who were not necessarily the target audience, who didn't identify as healthcare workers or students, we actually ended up keeping in a lot of the responses because they gave such good examples of how HIV stigma operates in Irish society, and also really good suggestions on how we can mitigate stigma as well. So the thing from the findings that I really wanted to emphasize is that the participants showed an overall very good understanding of HIV and associated stigma, and they answered various questions related to terminology, transmission, and the appropriate use of PPE, and demonstrated good knowledge of these. And they also showed a good understanding of stigma itself and the ways in which it can manifest. And then I also have 2 quotes here from some of the participants that show how they interpreted the term stigma itself. So, the first is from a doctor who's 45, and it says, people being made feel ashamed and isolated for something which they have no control over, which could be avoided with proper education. And then the second one there is from a final year medical student that says, labeling a person in a negative light, projection of negative feelings onto the person, such as shame and disgust, isolating a person emotionally and physically. And the participants also did explore other stigmatized conditions, so STIs such as syphilis and herpes, but when they were asked to rank which conditions that they thought were most stigmatized, HIV consistently ranked as the most stigmatized condition. So. Another promising finding was that the participants were able to identify many of the intersecting things that might affect patients living with HIV. So, as many of us here at the Gay Health Forum would know, sexuality and gender identity, along with lots of other things, play a role in how individuals experience healthcare, but also how they experience stigma. And this highlights to us the importance of an intersectional approach in the development of education interventions, and it's also good food for thought as we develop the courses in the future. So at the moment, I'm working with Aoife Commons and also the brilliant Anne Piercy from HIV Ireland to expand our sections that relate to women and migrants for this exact intersectional reason. And these updates hopefully should be online in the course by September. Also related to this was a section of the survey related to barriers of care. So the respondents seemed pretty aware of the various factors that might affect or make it difficult for people to access care, regardless of their HIV status. And some of those are listed there at the bottom of the screen. So participants were also asked about areas in daily life where they think people living with HIV might experience stigma. And what was quite striking to us was that 87% believe that stigma occurs within healthcare spaces. So we followed up then by asking them whether they had witnessed stigmatizing comments or actions from colleagues or classmates before, and it seemed like quite a large proportion of them had in some capacity. And they also provided very clear examples of these, which ranged from things like double gloving to more explicit refusals to interact with patients living with HIV. And 2/3 of the healthcare workers and students who responded, they reported that they thought it could be difficult for some people to disclose their HIV status. to clinicians for reasons like fear of discrimination or concerns about patient confidentiality. And linked to this is the way that HIV stigma can affect someone's care and access to care, whether it's related to HIV or not. So care that doesn't involve their HIV. There is an acknowledgement that stigma could affect how someone engages with services and maybe to issues in one's mental health or affect even their adherence to their medications. And I also think it's important that we mention the impact that HIV stigma can have on the wider community, not just in healthcare settings, because the participants suggested that stigma can prevent people from seeking out testing, can make them less likely to engage in prevention strategies like taking PrEP, and could also hinder open conversations that can be so important in the normalization and destigmatization of HIV. So on this slide is some of the main gaps identified through the needs assessment. It looks like 1 in 4 healthcare workers who responded had not received training related to PEP or PrEP, and close to half of the students at this point in their studies hadn't received training on these topics either. A large portion of workers and students reported never having training before relating to HIV stigma or discrimination specifically. More than half of the healthcare workers haven't received further training related to HIV since they qualified. But what is promising is that most of them did express an appetite for further training if it was available. There are also some terms such as treatment as prevention, where there was a lack of confidence in some respondents' understanding, which we think is important if you want to fully understand HIV in 2024. So with all of this in mind, why should students and professionals engage with RISE, and why should you all help us here to share it today? So some of the benefits that came to my mind, some of these here are quite self-explanatory, but the one that I think is most important in my opinion is improving the confidence of healthcare providers, because we often talk about HIV stigma and the negative effects that it has on patients, but I think it's also important that we acknowledge how beneficial engaging in such training can have on someone's skills and confidence in their work. And we also want to emphasize that there are mutual benefits to engaging in HIV stigma education, and we hope that it can be a positive experience for all the parties involved. So just before I wrap up, I do want to speak to some of the limitations of the survey and why it might not tell us the whole picture. So unfortunately, as many people here would know, the people who know HIV and get it, they really get it and they understand stigma. But the ones who don't get it often don't engage with events or materials like this. And we noticed that a high portion of our participants were members of the LGBTQ community or had already worked in HIV specialized care before. So we think this might skew the responses that we received in quite a positive light, especially around understanding. It also seems like many of the people who did take part in the survey, who had carried out further training, had sought that training out themselves, and so they have a vested interest in this topic. And so this is why I'm appealing to everyone to think about how we can break free from the bubbles that we exist in, but also work in, so that we can get this message out to audiences who might benefit most from it. So I really would appreciate, and we really appreciate as a team, any suggestions that you have about how we can distribute and engage more with students and healthcare professionals. I also want to say that we did receive funding to create the module, but we're now in a phase of wanting to expand and promote it, which we don't have funding for. So any leads on funding opportunities would be greatly appreciated. Otherwise, we will do it for free, but we would rather not do it for free because we're very busy. And yeah, I really hope that you can spread the word of RISE and share it with your classmates, colleagues, and join us in our mission to stop HIV stigma. Like I said at the start, this is the link again and some contact details for us. So you can take a photograph of it and share it on social media, and I'll be here for the rest of the day, so I'm happy to answer the questions you have. And I do have 4 copies of the report if anyone wants it, and if not, I can send them to you via email. Thanks.
Thanks very
Can I have a copy? Yeah, excellent. So our next speaker is Dr. Sean Gilmore. He is the head of general nursing and assistant professor in nursing and health systems at UCD. He also leads the program of research focused on sexual and gender minority health, inclusion health, and sexual health. John is also a Fulbright HRB Impact Scholar and has held visiting positions at the University of California, San Francisco, Columbia University, New York, and is a visiting fellow at Huddersfield University, UK. And entirely coincidentally, John, I'm going to remind everyone that we need to stick to time to get to lunch. Thank you very much.
Thank you, David. I will stick to time. So thanks very much. It's great to see everyone. Oh God, it's a countdown timer. It wasn't like that earlier. I will stick to time. So thanks very much, everybody, for in advance. So basically, what I want to talk to you is actually just kind of some headlines from a piece of work that I'm leading with colleagues from across Ireland and also the US, which is looking at a scoping review, looking at kind of what research is published on sexual and gender minority health in Ireland. People who've heard me before and who engage with me a lot know I talk about this a lot around the lack of research around sexual and gender minority health across the board. And while we're trying to build services and promote services, it's really important to have that evidence base. So while I was in the States, I was lucky enough to work with some wonderful colleagues who have been doing a lot of these scoping reviews in different areas of healthcare, but also in different countries. And this is the team. So Tonda, anybody who does sexual minority women's health will know about Tonda Hughes. She's the most prolific kind of researcher in this space. Started off 30 years ago, when nobody was researching this. And so she's led a number of these reviews across, she's done some in Eastern Europe, in the Netherlands, in Belgium. And kind of when I was working with Tonda at Columbia University, where she's Dean of Global Health, we spoke about kind of the potential of doing this work in Ireland. And I think one of the things that I reflected on is I thought there would be a lot less, but there is a little bit out there. And that's the rest of the team. So we're at the point now where we're coming together with the synthesis of the evidence and kind of thinking about how we present that forward. So this is the first presentation, so aren't you all very lucky? So just to say, there's no conflict of interest. We actually have no funding for this research. There's no big gay lobby aren't funding us a huge amount on this. And this initial synthesis is very much my view of kind of what's happening as principal researcher. So we bring that back to the research team. Just to acknowledge as well, the researchers that I'm working with and where I was working with in the States is often in unceded territory. So just doing land acknowledgement for the Lottie Ramaytush and the Matthew peoples, who are the initial inhabitants and custodians of the land. So really what we wanted to do is get a sense, that baseline sense of what do we know around LGBTQ plus health in Ireland through the published literature. So a scoping review is a type of methodology, unlike a systematic review or other types where we take a systematic approach, but we're not really judging the quality of evidence. We're not making any significant recommendations around whether we should or shouldn't do something. It's just very much to get the breadth of research that is out there and kind of what it's telling us, and highlighting maybe some gaps in the area for further research. We decided to stick with peer-reviewed published research for many reasons, and this was very much guided by our colleagues in the States, because that's where the policy base comes from. And while there is lots of research going on within NGOs, within community organizations, sometimes if it doesn't get to the level of being peer-reviewed and published, it's not going to feed into that policy, so it's about promoting that as well. So we just follow the standard scoping review process. We developed a research question which was very broad, and we talked a lot around that and what we actually meant by physical health and mental health. So there are the two kind of lenses we took, and we also looked at substance use. We looked at 5 databases, CENAL, PsycInfo, EBSCO, PubMed, what else, and developed our search terms, did a search, and then we went through the various screening stages. So we're now at the synthesis, so bringing it together and trying to get an understanding of what exactly that research is telling us and presenting it back. So we're looking at qualitative, quantitative research. So sometimes other research is brought together in other reviews. So there were a couple that we just discounted because it was duplication of the same topics. With the case reports, we looked at the last 10 years, 2014 to 2024, which is like, for me, I was like, let's just look at 10 years. And they were like, you have to rationalise it. And actually, there is a really good rationalisation for that 10-year period in Ireland. We're talking about research that was collected and conducted just before marriage equality and gender recognition, and up to that kind of present day. So it is actually 10 years makes great sense in Ireland. We just looked at English language, which made sense when we were in Ireland. So we excluded studies that obviously didn't have any LGBTQ plus people in them, and there were some. Or studies where we couldn't delineate the sample, so we couldn't, they included LGBT people, but they didn't actually kind of, incorporate them or delineate them out in the analysis, or any kind of non-research studies. And there was a whole amount in sexual health of abstracts from conferences that are published in journals, which are really hard to kind of decide, because some of them had really good research, but because while the abstracts are peer-reviewed, the findings aren't necessarily peer-reviewed or given scrutiny. So the first thing that we kind of learned through doing this was really kind of search terms are really important, particularly when we talk about marginalised, minoritized communities. We have so many different ways of describing ourselves, but also how other people describe us. So when we look at kind of the language that's used around men who have sex with men, or women who have very little memory of sex with women, but we just need to be cognizant of that. So those quite extensive, this is just from one of the databases, the search terms we use to try and get as expansive as possible as we could. Also, I thought Ireland was going to be a great limiting thing, so I was like, should I get rid of most of them? But I forgot that Ireland can also be like a surname, so we got loads of people that were like, not talking about health or LGBT stuff, but their surname was Ireland. So we to find those people and tell them to change their name. So this is kind of where we got to. So we looked at it initially around 1,200 papers. We got that down to about 164, which we did a full text review. So that means me reading all of them and colleagues reading a sample of each of them. And we ended up actually only the other day with 59, we excluded a couple more. So 59 studies on LGBTQ plus health published in the peer-reviewed literature in Ireland. And this is kind of this isn't the upstatement. Anyway, this is the typology, of health research that we saw. And one of the things that we were really surprised with, because our colleagues in the States were like, we're not looking at gay men and sexual health. No, because there's so much out there. And basically what they found in other reviews was that kind of overarched kind of the area. So there was so much on HIV and STIs for gay and bi men that they didn't really get a sense of the rest of the community. And I think that's something we do need to be cognizant of. It's great that we're trans health here today, but we do need to think about the wider kind of sexual and gender minority health, because oftentimes when I go to conferences, even now, it used to be just gay men, it's not LGBT health, it's G and T health. So we get some trans inclusion, we very rarely get sexual and gender minority women. But what we found in the Irish context, actually most of the research, most of the papers published were in the field of mental health, broadly around mental health. Sexual health came next, and then we saw some papers in general, kind of health and well-being, a few on substance use, an emerging evidence around gender-affirming care, although sometimes you need to question kind of the motives around some of those published papers, which I'll talk about in a second, and then a couple of papers on cancer. So that's kind of the lay of the land, and we're kind of now deep diving into that to see exactly what we're talking about. So our large series mental health, and in general what we were seeing in that, so the challenge around that, it's not necessarily around prevalence of pathologies, etc., because a lot of it is self-reported research. So some of it is using metrics which are batteries around general kind of anxiety, depression, etc. But it's not kind of hard kind of evidence around mental health, prevalence of mental health disorders, etc. But in general, what you're seeing higher rates of evidence of mental health issues and poor experiences of mental health. In sexual health, I mean, we kind of, I'd say in reporting, we probably divide into HIV focus and other sexual health and STI focus, because that's essentially, it's almost 50-50. So broad level, mostly around prevalence of STIs, prevalence around HIV, and then some other around sexual health behaviours, smaller. In health and well-being, it was kind of generally kind of some papers around healthcare access and experiences of healthcare of sexual and gender minorities, which in general were showing poor experiences, but not always with the heterosexual counterpart. The gender-focused papers, there was a couple just covering general demographics of who's coming to services. But also those papers that looked at experiences, they were in general poor, and the few cancer ones were on prostate cancer experiences, and then an interesting paper on trans and non-binary people in access to cancer. So kind of observations around what we should think about. Very little lesbian or bisexual, we need to think about if we're going to, so it's great to see the gay health forum opening space, but other spaces need to kind of embrace other areas of the community. That's not about taking away space from gay and bi men and other men of sex men, but it's about expanding that and pushing forward. There remains a superficial stereotypical approach. So we think about mental health, we think about sexual health, and that often comes when we generate a hypothesis based on a very narrow view of what LGBT people are. We think about them being mental because they have poor experiences of society, and we think about them having sexual health needs because they have different types of sex, but we need to kind of think about how we capture the whole health. Big issue for this, everyone certainly says, again, we've really poor integration of sexual orientation gender. We've very poor electronic health records in Ireland, very poor integration of sexual orientation, gender identity data within that, and that's not a simple thing to do. It's quite complex. Places like Fenway and Boston have done some really great work on that. There's a little reflection, and we're just doing this now, looking at them around how much LGBTQI plus people were involved in the research through public patient involvement, etc. So that's really important, great to see a sincere collaboration within the communities. And the other thing that I've kind of really started to say around my own work now is, well, we're doing a lot of research on the inequalities and disparities, and that's really important. There's a huge amount of valuable knowledge within our communities around how to stay well, because actually we're doing that really well. If you look at the inequities and inequalities, and you look at the risks around being LGBT, around stigma, around discrimination, around all of those things, we should, a lot more of us should be dying. We're not required to. We need to evidence that, and there are a couple of nice papers on that. That's me. Thank you very much.
We're going rogue because I think we're all starving and it's been a long morning. We're going to come back for Lorraine first after lunch. I would like to remind everyone that we have some poster presentations at the end of the stairs as well, and to take some time to have a look at those, and that maybe people who have submitted poster presentations can hang around near them in case there are questions or discussions about them. We will go to break now, and we'll come back at 1:30. Thanks. delivered relationships and sexuality education in primary, secondary and third level institutions and also within community settings throughout your career. The education team of Sexual Health West strives to deliver comprehensive, factual, progressive, inclusive, empowered, age-appropriate, non-judgmental and sex-positive RSE while ensuring they meet the needs of the young people they work with. Thank you very much.
Thank you very much, and sorry for that very long-winded introduction there, and thank you for the organisers of the event. It's just been fantastic so far, and we are delighted to be here from Sexual Health West. So I think it was a good few years ago I was here before, and I spoke about just myself driving around in a Ford Fiesta and delivering to schools in the Western region. Right now I do have a team, which is fantastic, and delighted to have them to support the work that we're doing. So as David was saying, the majority of the work I would have done would have been delivering. So I'm now taking a step back to do the coordination of all this work. But we would, as well as relationships and sexuality education, have various sexual health workshops for many groups throughout the West of Ireland. So various organisations that may get in touch with us and ask us just to help, I suppose, in assisting them with the capacity for their workers to deliver information around sexual health for their client group. So it can vary hugely. We also do rapid HIV and syphilis testing, support people living with HIV. We have a helpline, and as everyone was talking about condoms a lot, yes, we still promote condoms hugely amongst young people in schools, and other forms of contraceptives that I'll talk about very briefly as well. So just to confuse people, even though we are Sexual Health West, under the organisation, we developed WISER, which is the West of Ireland Relationships and Sexuality Education Resource. So this was in 2017, but before that, the education programme was still running, but we were constantly evolving it. And once I came on board as well, there was constant, well, often it was just myself, but working with other organisations to see what we needed to do to just constantly look at the information that we're providing to our young people in school. So when I was looking into this and when we would revise our programme and our own evaluations that we would do between, I suppose sometimes after each session, which would be 3 sessions, just to see how the information went down. But then often in some cases, because of COVID and we started doing some information online, it was often maybe just one evaluation after that. But through, I suppose, looking at the research around how inclusive we were being, now we thought we were fantastic. And we were believing that we were using language and terminology that young people could relate to within the community. When I looked into what was going on here with certain pieces of research that was done as well, we certainly weren't meeting the needs. And there was a piece of research done it was 2022, I have it referenced, but where teachers themselves and educators believed that they weren't using or didn't feel they were equipped enough to talk to our LGBTQIA community, they ended up just disregarding it. Like they didn't actually deliver the information at all. So they didn't even go, I'm really sorry, I can do this amount and hopefully look for resources for you. It was just ignored. And I'm sure there are lots of people in this room that have sat around tables with the NCCA consultations, which have been fantastic in one sense, but we still have issues around the curriculum, which again looks wonderful, but just actual content and how that's going to be delivered and who's going to deliver it. And it's so important to be the right person, to be the person that can relate to the community as well and be able to answer the questions that are being asked and not shy away from it. So again, obviously a lot of work needs to be done here. From our own evaluations, what we were getting, even though we had gone through what we thought was a whole session around relationships, around sexuality, around gender identity. And then we were also getting these snippets from what do you want more information on. And this was coming up again and again in the last couple of years. And it was around LGBTQ plus relationships. And in some cases, it was even about how to have sex. So we began to look into that, and I have to give absolute credit
to my former colleague, it was John Holloran, who's actually supposed to be here today. He has left the organisation and is no longer with us. So I'm just giving little snippets of what we are hoping to do in the future. But again, I was chatting to Kelsey, definitely want to talk to you, and any other organisations who can, I suppose, assist us in this as well would be fantastic, or just to give advice on how we can make it better. So we are hoping to develop an age-appropriate, relevant relationships and sexuality workshop for the LGBTQIA plus young people, but through local organisations. And I suppose the reason that I'm saying that, it's so important that we continue to do our work in schools. But again, we realise that often it's cases of young people not feeling safe in that school environment, as we all know from all the fantastic reports that so many people have done here. It's not the safest place to be out and to talk openly in front of your peers around sexual orientation or gender identity. So again, we've already had input and focus groups with a large organisation, and also some local ones in and around the west of Ireland. So we wanted, led by young people's needs, and from the information we gleaned ourselves from our evaluations, but also from the focus groups themselves, some of these topics came up. So I am not going to go through these in detail at all, but just to kind of give a slight little overview of what actually came up. And the interesting one about the history was where there was, and I don't know, was anybody in Galway, it wasn't this part, it was the year before, and there was the most beautiful exhibition down in the community hub. Did you see it? Oh, it made me weep. Like, it actually made me weep. It was just amazing. And you know, there was people that I saw there that I knew 30 years in Galway, and young people coming in to, is the Portershed in town, and young people coming in were just looking at these images and seeing these photographs, and just, you know, you can pave the way for yourself, but there is a history there already. A lot of it, I know there's a lot of trauma, and that's still happening, but there's also these fabulous, wonderful experiences that people have had and that they can share, and it was amazing. So anyway, that was something that when even with the focus group this came out, and just learning about people's experience from the past, but what we can also do to make it a better future for our young people in the future. So and I'm using the word biology there, and again, this is just from thinking about, and this has already been discussed a little bit, you know, we're all born with whatever organ we have, and you know, whether we decide to use it for sex or not, whether we identify with it or not, it's about just knowing how to keep it healthy. So when we're talking about sexual health here, it's also about thinking, well, I have this organ, I need to make sure that I am going for the checks that I need to go for. So just weaving this into our program as well of, you know, where do I need to go? What services do I need to access? Why do I need to access them? So again, around the cervical checks, around prostate checks, around testicular checks, that you know that you need to get these checked for yourself. Maybe partners in the future, maybe not, but just to think about that as well. And leading on then to contraception and protection, and knowing that it's not necessarily about where, you know, conception may not be an issue at all, but again, what do I need to use to protect myself? Where do I need to go for an STI check? And we all know that it can be very, very daunting for anyone to go into a situation where it's clinical. I know there's absolutely amazing, fantastic, wonderful staff, but just in that medical situation as well, telling our young people how to actually advocate for themselves. So throughout a program that we hope to have in the next few months, that it's about personal advocacy, that you can say to your medical person, you know, you can ask them to use your preferred pronouns, and just to be able to have the confidence to do that, which is very difficult, but also where those medical professionals are. Like, we've had a number of emails in the last 2 years of looking for LGBTQ plus friendly medical, like GPs and providers in the West. So again, I was ringing around myself and speaking to my own doctor, who is fantastic. But, you know, just if anybody else can recommend in the West, please let me know. So obviously the piece around sexual competency and consent is massive. And we have worked, you know, closely with UOG in the past, and would talk and do a whole session on this with our young people in schools, but making this very much specific to the LGBTQ plus community and how you learn about consent and where you learn about consent. And if nobody is talking about that at home, or, you know, it's not within your peers, is that all the time I've left? Oh my goodness. Okay, so that's a real issue. So, healthy, unhealthy relationships, obviously that would be hugely important. I'd love to do a lot more about consent. And then the other thing about image-based sexual abuse, and this is interesting, where there's a lot of research, again, gay bisexual men, it can be done in a really positive way. It's fantastic. Here I am, there you go, you've got an image you don't mind. But again, for other members of the community, there isn't much on just the negative aspects of non-consensual sharing. So the whole directing research there as well. So obviously we'd like to do a lot of work on just our learning outcomes as well. Delivery, 3 in-person workshops. Again, this would be so important that we have somebody within an organisation that we work with that can relate to the information that's been delivered and that would be on board. Say if it was one of our educators that was delivering the information, to be able, you know, to make it sustainable. I'm not going to say anything else, but the co-facilitation would be, as I said already, essential. And again, just if there is, you know, neurodivergence within the group, that we're trying to cater for that as well. So again, looking at resources. So there is some references there, and thank you so much for listening.
Thank you. That brings us to a close, I suppose, our morning session. Thank you very much to all our contributors to that morning session. I am now going to pass over to Peter, who's going to chair our Trans Health kind of middle of the day session. Peter is a Professor of Health and Society at the Open University in Ireland and a board member of GHN since 2023. He has over 30 years of experience in community-based research in the areas of HIV, LGBT+, health and rights and reproductive justice. For many years, he's a qualitative research lead for Sigma Research UK, and more recently, qualitative research director at NatSen Social Research UK. He has had honorary professorial positions at London School of Hygiene and Tropical Medicine, Trinity College Dublin. After 30 years spent in London, Peter has recently relocated back to Dublin. Congratulations on finding a house. Thank you all very much. Just one piece of housekeeping for this. We've over-prepared and we have a second Slido. We've decided to continue using the Slido Q&A that you've been using all day. No need to rescan. Thank you.
Thanks. So I wasn't expecting that kind of introduction. We're invading the stage because we figured that all that backwards and forwards and to and froing is waste of time. So yes, thanks for coming. We're delighted to be doing this session this afternoon. And I suppose just I have no time to present this, so I'm going to really rush through it. But I think what really led to this presentation is that international consensus around healthcare that apply to our community's health is generally really strong. We see excellent partnerships around things like clinical guidelines on sexual health and global programs such as ending HIV. You know, and the HIV Cities Initiative, for example, is a really good case. But the exception to that is gender healthcare. We have very good models around the world, but our two nearest and most influential neighbours, the UK and USA, trans healthcare is in crisis and is in retraction. And it's particularly concerning for Ireland at the moment because our domestic gender healthcare model is both highly medicalised, it's based on a highly pathological model, and it's very, very limited
in terms of access. It's very hard to get access to healthcare here. And it's very important that as a community, we come together to identify and consider other models of gender care from elsewhere that aren't from our Canadian and English-speaking neighbours, that are gender affirmative and not based on informed consent. And I think we need, and I think GHN are really taking this on board this year, we need to be very proactive in informing government in Ireland not to go down the road of the UK at the moment and many parts of the USA. We need to be very, very clear about what we want. So I'm delighted to be chairing this panel today, and it includes our keynote speaker, Dr. Beth McElroy, who I'll talk more about before she comes up. But before that, we're going to hear presentations from trans communities on trans healthcare models. From Trans Healthcare Action, we'll be hearing from Jess Black and Shabelle Call, who will be talking about the situation in Ireland and on the more controversial recent CAS report in the UK, which is informing gender care in the UK quite fundamentally. You'll then hear from Dara Dempsey from TENI, who will talk about violence experienced in trans healthcare settings, and then we'll move on to Beth, who will be our keynote speaker. So that's the lineup for today. As I said, so happy to introduce our first speaker, who will be Jess.
Get rid of that. Okay. Right, so I can't see this in front of me. So I am Jess, I use she pronouns. I am a committee member of Trans Healthcare Action, and I do what's called policy research. That's the fancy way of saying I have 25,000 pages worth of documents, including over 150 information requests, to understand what's going on inside trans healthcare in Ireland. Trans Healthcare Action, we are as a grassroots community-led group. We have about 40-ish volunteers at the moment. We're working towards these better models we talked about there. And we want these based on co-production, informed consent, and looking at it in primary care. So let's talk about trans healthcare today. So maybe have some knowledge, let's talk about it in detail. We were ranked worst in the entire of the EU by TGU there. And this is covered area by Portrait, trans healthcare, plus intersex healthcare were the only areas to get Fs in the shadow report from LGBT Ireland. Whereas de facto gender clinic, and there are no national anything for trans healthcare in Ireland. So there are major issues, such as a decade-long waiting list for primary public care. Like I figure, because it took me so long to figure out what's going on, that I lost a decade of my life. Having to wait another decade on a waiting list would be not great. There's no youth service, and there's denial of services in primary care. I'd like to explain what that means. I personally had to switch GP just to access blood tests so I could go on HRT safely. This is a common experience by trans people, because there are letters being sent to GPs and basically scaring them away from providing blood tests or providing any other care, like helping with shared care for prescriptions, and the implication being that if you provide any help at all, that your patients might kill themselves and you might lose your license. And they also claim that, there's no risk associated with hormone concentrations, which is weird because there's really well-known risks. And people sending those letters, their own guidelines emphasize those risks in bold. And this has gotten so bad that our organization actually maintains a secret list of GPs who are willing to provide trans people blood tests. And you can access that via Outhouse, TENI, and Trans Harm Reduction. And of course, surgeries, most of us have to go abroad. Spain's popular, for example. And there's no following of any standard international guidelines such as WFAT. There are also other issues, such as a lack of autonomy. Now, some people do manage to get access to healthcare, but many people don't. So the assessments that most people have are extremely invasive and inappropriate. You're expected to talk about masturbation, your porn habits, how you have sex, how you feel giving and receiving blowjobs in detail. If you refuse to answer, you will be kicked out of the service. The assessments, it can go on for we don't know how long. The HSE actually refused to say what the average number of assessments is. But we know people who've been strung along for years. We've been cases where parents for fully grown adults are required to come in and be assessed also. There's also issues that, of discrimination. So for example, we have multiple reports of people who are on disability allowance and unable to work, being told, if you want HRT, you need to get a job. We have an old case where someone that was discovered, they were unemployed, and so they were basically kicked out of the clinic and taken off HRT against their will. And we've had people who have been on HRT for years, had surgeries, have been told you are not ready for HRT. So the other things like autism is commonly used as a reason to delay and deny healthcare. And we also have claims that up to 90% of trans people are autistic. Now, we do know that autism is more common amongst trans people, but it ain't that high, and that is never a reason to deny healthcare. We just treat people as individual as everyone else, and there is common infantilization of people, of trans people and autistic people, as recently as in a paper yesterday published in the Irish Medical Journal. We also have that public statements that the gender clinic will frequently often say not right now, and they have publicly stated that they may ask for a patient to come back in 5 years. And this is not theoretical. I know people recently, and doing the math, it turns out they were effectively told to go away and come back in 15 years. And all of this, all of the basis for saying you must go do this is based on a service who have publicly stated they don't know how they're doing is right or wrong, but everyone else is wrong, which is an interesting choice. And of course, we have no involvement whatsoever in any policy development for our healthcare. And as far as I can tell, we haven't had in about 20 years of practice. So here's how it comes in terms to accessing healthcare. Considering the virtual non-existence of healthcare, Reaching the Long-Term Report, published back in April, found that over 2/3 of people have access to healthcare abroad, and 29% are self-medicating. This obviously calls for looking at parameter approaches, right? Because we need those bloods, and make sure people are having proper injection training. We in fact have staff from the main gender clinic have publicly called instead for anti-trans laws to prevent people accessing healthcare abroad. So on this, and here's one particular quote from that survey. I'll give you a second to read it. You may be interested to know that clinicians in Ireland oppose a ban on conversion therapy because it would interfere with psychiatric assessments, which I think is a rather telling statement. But obviously there's no consideration of the needs of the community here at all. So to give a little background then on the main gender clinic, which is called the National Gender Service, this is a name they picked themselves in September 2018, I think that was. They wrote their own model of care, they approved their own model of care. The HSC has not approved this model of care. Now, there is a 10-year waiting list, probably about 12 years by now. There are over 1,700 people on the waiting list as of 2 months ago. They see roughly 150 a year, when there is roughly 500, maybe 600 being added to that list per year. Okay, so clearly that's a 10-year waiting list. It's just going to keep on growing. There have repeated claims being made that increasing their staffing by about 60% above what they currently have will bring the waiting list from a matter of months rather than years. This is obviously nonsense. You would need far more resources for that to be the case. And this would not be a good use of money. This is not going to help. We need improved systems. And of course, they categorically refuse to engage with trans groups. And indeed, that IMJ article call once again, as often they've said, that anyone who's looking for better healthcare is an ideological activist. Apparently, we're also brainwashing the HSC. As once again also said publicly. Now, we are pretty much entirely excluded from this stuff, and this is more recent stuff. So this is stuff that HSC has done inside the last 18 months. They had a meeting, which they themselves called the Future of Transgender Healthcare in Ireland, with no trans people present. And they abandoned their commitment to WPATH, the Programme for Government. So I'm interested to know how the earlier speech from the Minister, how they called WPATH when they abandoned that, they decided to spend over €1 million on new model care and begun hiring. And none of this has involved any discussions with the community that we're aware of, or indeed that the HC has mentioned. They just said, "We'll talk to us due later." We've attempted to engage with them. There have also been other groups protesting. Any communications we're seeing, and we saw this earlier, basically contain anti-trans talking points and rarely, if ever, contain pro-trans talking points. So for example, continuous mentions of CAS, which Chanel will cover in their talk, and virtually never mentioning of WPATH. All indications are they are going to blindly follow the UK. And as a reminder, the UK has effectively banned all youth care for trans people. And indeed, we got the news last night that Northern Ireland is going to be banning puberty blockers on Tuesday, with no consultation with the community, one presumes. And you know, the UK is now, of course, starting the process of banning adult care. That'll presumably take a year or two. That's the way things are looking as it stands. This is not a model we should be following. We also know that when part of this process, you know, the Ministry of Health has asked to find a dual record, or basically a hate group was welcoming part of the process. The response was that this cannot be allowed to derail the HSE. So I found this particular quote from Minister Donnelly to be pretty useful. He said this back in January, because this very much describes what's going on here. He also, in that speech, promised to meet with Trans Action, said he'd be happy to meet with us, and has failed to do so. So we can't talk to anyone, unfortunately. HSE will talk to us, the Minister, we'd love to talk to him, and the National Tennis doesn't. So things are getting worse, things are getting better. What is it that we'd actually like to see? Because, you know, what we want to see is a new system based on informed consent, like we have in other countries. We want it to be in the community and primary care. That means going to a GP who knows how to recovery training. It might be going to a sexual health center. It needs to be an actual co-production with the trans community, not just a tick box thing where you do a consultation after you already made up your mind. We need an affirming approach to trans youth, not just endless assessments or psychological help. I mean, medical options need to be there. And you need to respect human rights like body autonomy. And informed consent, well, at its core is, well, you explain the risks, benefits, unknowns, and the person decides, and the medical professional is there to guide that decision. There's no discriminations, no participation, there's no gatekeeping. And just to share you some statistics from transit. So there's clinics around the world, including in New Zealand for better experience, but Malta, UK, private clinics in UK, Canada, US, parts of France. 71% of people on their first employment of adults walk out the door with a prescription. These are satisfaction ratings. So in Ireland, we have protests outside the clinics, the HSE, the Department of Health. There, people are happy. So we would very much like to have this sort of system, and talk about having this sort of system in Ireland. Thank you.
Hi, my name is Chevelle. I've been a pharmacist the last few years. Here to talk to you today about the infamous CAS report on right children reform and model of care. So I've been working in primary care the last few years. You know, some research advocacy experience, especially Trans Healthcare Action. I really think it's important as well to look at this through an inclusion health lens specifically. You know, we really get a good bang for our buck. It's minimal use of resources for a marginalised population, you know, with great outcomes. So 2022 is a really important year for our healthcare. There's an international consensus coming together, you know, it's the ICD is de-pathologizing, is recategorizing this into sexual health, gold standard guidelines being released. But then the interim CAS report drops. So that's 2 years after it's been commissioned. And the red flags were there from the beginning. You know, re-pathologizing this going against all this evidence that is being, the consensus that's being built, these misconceptions being raised again. I think it's really good growth here, you know, like that kind of unconscionable intrusion against pronouns, against the way people dress. You know, this is beyond a mental health guideline. You know, against the gold standard pro-conversion or exploratory therapy. I'll let this one sit for a minute to pay attention to last talk. You know, considering the our LGBT gold standard is doesn't really line up with what we know, and just that feeling of not being listened to, ultimately. So to give you a brief timeline, a year after the interim report, the HSC puts out a report to say how they're going to utilise it. And then earlier this year, I guess we got the full report dropped, so we were quite busy there. But this is kind of consistently like what we're getting back, you know, it's as if there's one source of information with lots of data in the world, as we've seen, and as we will see, they can do this well. So like what actually is it? I guess Dr. Cass was selected to lead this review with the idea of neutrality, and this is defined as having no experience working with trans patients. Of the one author that did have experience, you've got like strong conversion therapy links. We see the 7 systematic reviews up here. There's also 3 original pieces of research, and we get this kind of thing back of like, oh well, look, we haven't really found much in the literature, but then following on from that, we get radical recommendations on changes to care. It doesn't matter. And then kind of a later Q&A trying to roll things back when, as we've seen, the effects and consequences of this, you know, like the damage is already done. You know, and I think, you know, it's obviously was raising the red flags from the beginning, the way it's being weaponized. But every other organization I list here is a medical one. Represents doctors, nurses, healthcare professionals. We've seen the VMA recently look into investigating the Cass report. You know, these are all, it has to be noted, you know, these are community groups, these are advocacy groups, these are very neutral voices raising warnings. These are, you know, they've released statements, some of these groups have released statements in the past that haven't lined up with the lived reality of trans people. So, you know, to keep that in mind. We're going to talk about 2 pieces of research. The first that I was involved in, led by Chris Noon, and she's heard from John earlier as well. And a follow-on report then, McNamara et al. From Yale Law School. You'll notice a lot of the surnames there are the actual people who've had their research reviewed by Cass, and people who write, you know, the leading guidelines. Interesting perspective. So we've passed around some of those sheets there. I think this is the big thing you're going to see on our paper is that colour red, where we have a look at why there's such a high risk of bias across all 7 systematic reviews. 3 factors underpinning that. It is worth noting as well the individual critiques that have been published separately that kind of give you, you know, for different aspects of this report, the problematic parts. First of all, you know, like what is a protocol? Protocol is what you say you are going to do before you do it. So, you know, there was one published for all 7 reviews, which is completely unheard of. They say they're going to use one scale, they use another. The other scale that they use, they modify the scale inappropriately. You know, there's a lot of this tweaking, there's a lot of this fiddling under the hood kind of thing. Then the search strategy, you know, it's like I was saying before, you can't really say that you haven't found enough when you haven't looked hard enough. Your search strategy needs to be tailored to the intervention that you're looking at. But this, there wasn't enough of that. And I just think it's particularly egregious, the limitations, hiding the weaknesses of your study. When I'm looking as a healthcare professional in the study, trying to interpret in the wider literature and see how I can use it, I need to know, you know, it has to make sense of it. Other reviews that have looked at the same evidence and using the same tools, much longer list of limitations. You know, there's a lot of issues coming up here, you know, in the real life context. In terms of double standards then, you know, the bar is to the ceiling when it comes to the studies they're appraising. They're throwing out an awful lot of research. They're appraising quite unfairly, but then the bar drops to the floor when it comes to their own follow-on findings, their own the way they engage with research. Observational research informs most of my practice, most of general, uncontroversial therapies. I saw figures somewhere 2/3 or so, but you know, disproportionately thrown out. And as we will see later as well, it's, you know, this kind of incoherence of recommendations. Things don't follow through. This wouldn't happen in any other area of medicine, as we can see from Yale here. You know, it's really interesting, that last point there, if you see it. Statements are generally in line with WPATH, like we've seen earlier, that kind of affirming care, but then the actual recommendations diverge. As we've seen, you know, like other areas of medicine will this fly, you know, far from evaluating the evidence in a neutral and scientifically valid manner, the review obscures key findings, misrepresents some data, and is rife with misapplications of scientific methods. I include this play as a brief aside just to kind of talk about the idea of autonomy in a medical setting. So, you know, we get this list of psychiatric medications. You know, you get this real sense of someone not being listened to, not being taken seriously, not being engaged with. You know, it's patient views and preferences. We've said it time and time again. It's a cornerstone of evidence-based medicine. You can't have it. You need to have evidence-based medicine. So I have this picture here from the National Gallery. This lad with a pink cape and little rosettes in his shoes to talk about the idea of fine right of kings. The idea, like, how unquestionable is this really? Look at it like the 4 principles of medical ethics, like justice. We talked about some double standards. Consider the cherry picking and stuff involved. Last minute changes to the inclusion criteria, where Swedish and Finnish guidelines are included and ranked 2 or 3 standard deviations above the mean, with possible evidence of conversion therapy in their involvement in their creation. That subtext there is just about they're recommending psychosocial interventions when they themselves say they found the least evidence for them. In terms of do no harm, then, you know, your scientific communication is so crucial. We've seen the effects of this. You know, low quality evidence, that has a technical meaning in terms of it just means a lot of times means your observational studies, as we've said. But to the public, that looks like there's no evidence. You know, it's even being picked up by we've talked about the autonomy piece, but then in terms of like how we can do well, as we said, you know, there are a lot of other countries that do this well. So rather than, if we're going to copy our homework as a country, can we not maybe do it from somewhere that can do it as well? You know, rather than copy from someone with good grades here, you know. And just some ideas of our kind of principles, what we need to see in our care, what is possible in our care. I will hand over to Dara now in terms of kind of those patient perspectives, those real like lived experiences. You need to hear, they need to engage with that and get an idea of what our system is actually like. And Beth will walk us through, you know, what it can be, what we can change. Thank you so much.
Hi everybody, my name is Dara, my pronouns are they, them. I am the policy lead for TENI, the Transgender Equality Network Ireland. And what I'm going to talk to you a little bit about today is a research project that we ran over last year and into this year. It was a community-based research project looking at trans people's experiences of institutional violence, specifically in healthcare settings. So I guess we're kind of using it to sort of fill in some of what we know from like a policy piece, some of what we know kind of from different models, but really to kind of give a little bit of actual voice and to talk a little bit about people's actual experiences within the healthcare setting. Yeah. So just by way of kind of introducing the study, I'm not going to spend a huge amount of time on it because we don't have like, a lot of time, but we used kind of a mixed methodology. There was a questionnaire-based survey. There's the microphone. There was a questionnaire-based survey. We had 293 eligible respondents. We did 10 one-on-one interviews, and then we had 2 focus groups as well. So really trying to gather as much kind of data as we can from people, and obviously recognizing that some people prefer filling in surveys, some people like to do face-to-face work, all that kind of stuff. And then across the whole piece of research, we looked at people's experiences in like general healthcare, like in hospital care, in GP services, in mental health services, and then also specifically within kind of gender services and kind of obviously given the nature of the landscape of Irish healthcare, that was kind of specifically around the National Gender Service. The project was very much based around the idea of institutional violence. It came from a sort of funding call that existed already. So just to give you a little bit of background on our definition of institutional violence, specifically as it pertains to healthcare access, we looked at mistreatment of trans people within the healthcare system. We looked at refusing to treat trans people within the healthcare system, pathologization of trans identities, which as we have heard is absolutely rife and we would still consider to be institutional violence, and then putting up barriers or just even not providing services at all. So that was kind of the definition that we came up with and that we worked with, and that allowed us to, I guess, really kind of provide a framework for people to talk through their experiences. The study, just to say, it's not published just yet. I have a few copies, if anybody wants some, please feel free to have them. And we're going to be doing a launch a bit later in the year, so this is like a little sneak preview, so yes, that's just a little bit around the survey itself. So in terms of the respondents, I don't want to dig into too much of it, but just to mention, I guess, what we saw was that there was a pretty even spread between people who were non-binary, people who were like trans male mask identified, people who were trans women or trans men identified, and obviously kind of smattering of other identities in there. That was really interesting to me because I think it's useful to see kind of how the spread it goes across between the binary and non-binary identities. And just a note as well, like, a pretty severe limitation is that the research was quite heavily weighted towards like younger people kind of under 30. Again, reflecting, I think, like TEN's audience as an organization. It wasn't really something that we were able to mitigate necessarily within the scope of the research, but something we were quite aware of. So just bear that in mind, I guess, as we talk through it. So in terms then of people's experiences with their healthcare providers, what we found was, I guess, a whole range of different experiences. There's way more than this in the research report. I just picked out a few that I thought would be useful for this session. But what we saw was a really, really high rate of people whose healthcare providers discouraged them from exploring their genders. So like over a third of trans people who went to talk to a doctor or a healthcare provider across, again, like a huge range of healthcare sectors were discouraged from exploring that in whatever way they wanted to. And again, about a third of people had been belittled or had been ridiculed by a healthcare provider, and that might be around like their names, their pronouns, their appearance, and the kind of treatment they're seeking, whatever it might be. Quite a low, but still way too high percentage, 6% of people have been touched inappropriately by a healthcare provider. There was a very strong thread and theme coming through the research around inappropriate questions and touching, an inappropriate level of curiosity in trans bodies where it's not medically relevant. And so that was like a very concerning piece for us, obviously, even though that number is quite low. And then we kind of looked at the barriers as well. So again, about a third of people had been denied care or had their care ended because they were trans or non-binary. 18% had been discharged against their wishes. So again, like a very clear denial of care. And then a really high, and this again came through really strongly, was that trans people reporting that their healthcare providers just felt that they didn't know enough about care in order to be able to provide it. And this wasn't in relation to gender affirming care, this was from GPs, this is from mental health professionals, where you're going to seek support and help, not necessarily maybe to do with being trans, like to do with other mental health, there it is again, other mental health concerns, but being told that because of your identity, they don't feel able to support you. And so that for us speaks to a very clear need for much more training and education for all of our healthcare professionals across the board. There's quotes in here that I think are really illustrative, I guess. So there's a piece in here about someone's transition being impeded by a mental health professional. So if trans people, I think, are very aware of what you can and can't say and how that will kind of trickle through the rest of your access to care. In terms of how people responded to this, so we saw again like quite a varied responses. People withholding information from their doctors or lying to their doctors because they feel they won't be able to access care, avoiding seeking medical care or missing appointments on purpose. Again, a lot of anxiety and fear around interactions with medical professionals, and then really high rates of people who had wanted to and then had successfully harmed themselves in relation to their experiences in the healthcare setting. So we are really seeing a crisis in terms of how trans people are being treated within healthcare. We saw a lot of really damning, I guess, testimonials from people with their mental health experiences within healthcare, but also specifically within mental health services, and a lot of kind of coming through in terms of people's mental health worsening while they were receiving supposed supportive care. So then, just in terms of the kind of key findings, sorry, the format's kind of funny. So there's a few kind of themes that we pulled out. Again, this is not all of them, this is just what I thought would be useful. So really, really clear coming through was the lack of knowledge. So a lot of people felt that they had to educate their healthcare providers. Lots of people's doctors reporting that they just didn't know enough about this kind of care. And it's great to hear, I guess, about all the training that the HSE is doing. Obviously, in TEN, we provide training for HSE staff as well. But I think it speaks to the fact that it's just not reaching enough people. It's not embedded in the mainstream medical training, and it absolutely has to be. People reported really varied experiences with GPs. Lots of people had really, really positive experiences with their GPs. And then lots of people had maybe slightly more negative experiences. Again, usually from that, like a lack of knowledge or lack of sensitivity. But building on from Jess's presentation, we did see, and we had a lot of reports coming through this research about trans people going to their GPs being supportive, and then the GP receiving a letter from the National Gender Service saying that they absolutely cannot support a trans person, they cannot provide blood tests, they cannot do any bridging prescription, which is obviously completely outside the jurisdiction of the National Gender Service, and interferes in that individual's right to receive care from the provider. And then again, kind of similar to the Being LGBT in Ireland survey, so we had 23% were currently or had previously self-medicated. So again, speaking to the complete lack of access within the mainstream healthcare system. So people are resorting to buying hormones online or sharing prescriptions. And there's a quote here from somebody around what happened when their GP tried to provide them with care to support their sort of private care access. So just in terms then of the rest of the kind of key findings, so we looked a little bit at the kind of gatekeeping elements of it, so pathologization, how people felt about having to go through a psychiatric assessment, how people felt having to go through a gender dysphoria assessment, and it kind of ranged, I guess, people's experiences from really demeaning, like ridiculous, it's something you have to do, it's a hoop you have to jump through, but we don't really support it, into it kind of being a relief. And I think because it's used as a gateway, just getting through that was really meaningful for people. Trans people also reported having to look a certain way, present a certain way, tell a certain kind of story in order to be taken seriously by our healthcare providers. And then obviously quite a significant amount of the research was around experiences within the National Gender Service as kind of really the main gender affirming care provider, if we can say that, within the healthcare system. So we looked a little bit at the wait list. So what we're seeing is now that people who are being seen now within the National Gender Service were maybe referred like anywhere between 3 and 4 years ago. So that's kind of where you're seeing that percentages of people have been on the wait list. But the 10-year wait list is kind of what's kind of being extrapolated into the future, given sort of the increases in demand and how they're not really able to keep up with that. Really importantly, 73% of people said that their mental health worsened as a result of that wait. I don't think there's anything surprising in there. I think we know what it is to sit on a wait list for care that is absolutely urgent and not have any prospect of receiving it. In terms of people's treatment within the National Gender Service, again, there's way more in the actual report than I could put in here, but really importantly, nearly a quarter of people reported exclusively negative mental health effects as a result of their treatment within the National Gender Service. So even when you go through the wait list and then you get into the service, people are still reporting really adverse mental health effects due to the treatment that they are receiving. Only 8% of people reported having a positive mental health effect from their treatment at the National Gender Service. So again, we're seeing really low rates of satisfaction. We saw some of the figures from Transit. There's no reason that we should be providing care in this way. 84% of people thought that if they had a worry or a concern or they were distressed, that they would not speak to a doctor in the National Gender Service. There's absolutely minimal trust or relationship building going on between the service and the community, and then only 13% of people rated their care as satisfactory. So I think that kind of speaks to what people's experiences are within the healthcare system more broadly, in terms of trying to wait to get into the gender service, but then also in terms of experiences within that. And I want to leave us with the quote that's kind of centered in the box there around what is happening in these assessments. And you can see that people are being asked really invasive questions around their sex lives, their intimacy, their previous partners, how they feel, as Jess said, giving and receiving according to named sex acts. It's completely inappropriate. There's absolutely no basis for it to be happening, and obviously it's alienating trans people. Just to finish, I'm not going to go into this really, but we made recommendations in the report around what we would like to see. It's not going to come as any surprise. We'd like to see an informed consent model of care that's based and housed within the primary care system. I'm not going to speak to that too much because I know Beth is going to talk a lot about the models that we're going to be looking at and we'd like to implement here. So just to kind of leave you with that, that's my email, star@tenny.ie. If you want a copy of the report, I'm just going to front table here. But yeah, thank you very much.
Thanks very much, Dara and Siobhán and Jess. And what's remarkable about that presentation of both the state of gender care in Ireland and elsewhere, but also of the kind of research that's being done at the moment about that work. Speaking as somebody who's a background in health services research, I think a lot of the worry about the Kills report is that it's marking a new low in evidence-based medicine, and actually is putting evidence-based medicine under threat. Community involvement in the production of knowledge about care is key to evidence-based medicine. and that needs to be really said. But I'm so pleased now to welcome our keynote speaker for this afternoon, who is Beth McElroy. Beth is originally from Northern Ireland, and she's a GP specialising in gender affirming care, working in this area since 2015. She created the Gender Care Service in 2022, which is a fully funded gender affirming services in Hawke's Bay, New Zealand, servicing all ages. Beth is a member of the Executive Committee of PATHA, the Professional Association for Transgender Healthcare in New Zealand, and is also a member of the Advisory Panel at the Ministry of Health for projects supporting gender affirming care across New Zealand. Beth was co-author of the Primary Care Guidelines for Gender Affirming Care in Adults in New Zealand, released in March 2023. And now she's branching out. She's now working in Reykjavik in Iceland, leading the development of a national gender affirming service for Ireland. Welcome, Beth.
Thank you, Peter. Dear youth, Guten Dagen, which is good day in Icelandic, and Kior Tatum, which is good day and welcome in Te Māori from the Indigenous Māori population of New Zealand. So it's a real pleasure to be here today. Thank you, Peter, for the introduction. Thank you, David, for inviting me today. It is a pleasure to come and talk about this. I'm very passionate about trans healthcare, and it's really nice for me to come full circle from Northern Ireland via New Zealand, via Iceland back to Ireland, to talk about my experiences in gender affirming care on that journey. So my name is Elizabeth McElroy. I use she, her pronouns. I'm a gypsy, so I'm a GP with a special interest in gender affirming care. So this is just a little bit about my introduction. Coming from Northern Ireland, we don't often share a lot of information about ourselves, but having moved to New Zealand, whenever you introduce yourself, you do a PP hat, and part of that is saying who you are, where you're from, how you identify, and that's been something that we've learned since living there. So I'm from Northern Ireland. I was raised Presbyterian. I'm cis, white, straight, married female, and married to a Catholic man, which has been interesting in that it made our decision to go and live in New Zealand. We didn't want our children to have to choose coming from Northern Ireland. So we've had 3 children in Northern Ireland, or in New Zealand, over the last 15 years, 3 boys who are staunchly Kiwi, but sometimes Irish, depending on the sport, depending on who you ask them. So this is just a photograph of us traveling around the west coast of New Zealand last year. So I originally trained at Queen's University in Belfast, graduating in medicine in 2006. I completed my GP training in New Zealand in 2019, and I've been working in gender health since 2015. I launched Gender Care in 2021, and I'm now the clinical lead of the trans team and the new service in Iceland. And I'm newly elected board member of WPATH just this last week. So that's really interesting. I'm actually only one of 3 members who are not from America. So there's one, I'm the only European Australasian on board. So there's 5 Americans, 1 from Argentina, 1 from South Africa, and me. So it's going to be an interesting journey. So gender affirming care in New Zealand. So this lady, this photograph is Georgina Meyer. I don't know if anybody's heard of her. She's a very famous, iconic trans woman. She is the world's first openly transgender mayor. And she's from New Zealand, and she was the mayor of Masterton in the North Island of New Zealand. She's also the world's first openly transgender MP in Parliament. Was a Labour MP from 2007 to 1999 to 2007. Sadly, she passed away last year, but she was a huge icon and trans advocate for trans and human rights. So New Zealand's not unlike Ireland. It's got a population of roughly 5 million people. We think the number, the population of gender diverse people is 1 to 2%. So we did a census last year in New Zealand, and it was the first time they'd included gender identity. So we're still waiting on those numbers. So our main centres are Auckland, Wellington and Christchurch, where most of the population are based, but unfortunately healthcare is very sporadic, region dependent, and has been limited to particular individuals in particular regions wanting to take up the mantle to do the work. So it might be 1 endocrinologist, 1 GP, 1 sexual health physician. So it's still very sporadic, but this is changing. So in 2018, the Counting Ourselves study was released. This was the first trans study for trans people by trans people. So it was done by the University of Waikato. They surveyed about 1,200 trans people across New Zealand from 14 to 83 years old. And the information that I'll talk about in the next slide, the results of that. In 2019, PATHA was developed or established. It was originally ANZPATH, Australia New Zealand, as a chapter of WPATH, but in 2019 in New Zealand, the Kiwis decided we needed our own chapter. So I've been on the executive member of PATHA for the last 2 years. And it's a very important voice for trans people, and it's an international, or it's an interdisciplinary organisation for professionals working in the trans space. So now trans and non-binary people have a voice. And also the Counting Ourselves study gave clear evidence of discrimination against trans and non-binary people, especially in healthcare. But it's now moving into primary care, and we've got the funding to do so. So it's been very interesting work on this advisory panel to the Ministry of Health, because they've been funding new guidelines, they've been funding workforce development. Unfortunately, our government has changed in the last year, and we've got a much more conservative government. And that has been interesting, but we'll have to see what happens. So yes, we released the primary care guidelines for adult care in March last year, and that's been really revolutionary for GPs to be able to do this work in the community. We are redrafting and updating the national guidelines in New Zealand, and that includes adolescent and child health, with very clear information on puberty blockers and how to use them safely. We are also waiting on a review of puberty blockers in New Zealand. So the cash report sort of came out in the middle of that, and it's being stalled and stalled and stalled. So we're just hoping with the new government that that's not going to affect things as it has in the UK. But I don't think it will, because New Zealand doesn't tend to follow the UK in the same way. So workforce development has started across New Zealand. So I've been on the workforce team for that as well. So it's going out and teaching with different levels. We have levels for administrators in primary care, we have levels for nurses, we have levels for doctors who want to prescribe. So we're upskilling the workforce across the country. And GPs are gaining confidence and getting into the space. So the Counting Ourselves study that was released in 2018, the figures aren't unlike what Dara just presented, very similar. So you can see this through the numbers for yourself, but over a third had attempted suicide, and at least 12% in the year before. 36% avoided healthcare during disrespect and mistreatment. 19% had been homeless at least once. 19% had ever worked in the sex industry, and 17% had been offered reparative therapy, something akin to conversion therapy. And this is modern day medicine, so it's quite horrific, the results that we saw. But this was an important document to be able to lobby government and develop policy around. This is a slide on human rights in New Zealand, and this was the PRISM report was released in 2020, and it was written after a hui, which is the name for a meeting or a get-together of people with diverse sexual orientation, gender identity and expression and sexual characteristics who came together to decide what we need to focus on or what they need to focus on as a group. And these 6 points were highlighted for this population. And this was a really important document to affect policy in New Zealand, and it was because of this document that the census changed last year to include gender identity. So gender-affirming care, I'm sure many of you are familiar with gender-affirming care is and what it includes, but it's very diverse as well, and every person who is gender diverse needs a different thing and wants a different thing, and we have to respect the autonomy of the patient as to what it is they need. It might be a change in pronouns, it might be hormones, it might be a fertility preservation, it might be legal social advice, it might be everything, it might be some of them, but we have to respect the autonomy of every individual and provide what they need. And the hormone therapy is not complicated, it's not rocket science. We do this every day as GPs, we prescribe hormones every day. We're actually better equipped than most endocrinologists to do this work. So it's actually really interesting that people, even in Iceland, I find that all the GPs are like, oh no, this has to sit in tertiary care, this is a very specialised area of medicine. I'm like, no, it's not, you do this every single day. So this is the old or informal pathway in New Zealand. So there wasn't actually a pathway. It was something that was sort of fumbled together, and people, our transgender diverse population just had to kind of find somebody who would listen to them. So they had to always present to a GP. Often the GP was somebody they didn't trust or didn't like. It was a family GP or somebody. I've known many, many patients who the GP said, you'll grow out of it, it's just a phase, Then if they were lucky enough to get a referral, that referral had to go to a mental health clinician. They then had to go through multiple tests, readiness assessments, be diagnosed with mental illness, and they may have been provided therapy, but they still had to wait often many months or years to see a mental health clinician. Then they were passed on to an endocrinology or sexual health physician. This again is another waiting list, another barrier to care. An endocrinologist, they were just starting hormones and sent the patient off. There was no review, there was no follow-up. And there was no information to GPs about doing this. I've seen patients who were diagnosed on the lowest dose of estrogen, and I saw them maybe 6 years later, and they're still on the lowest dose because nobody knew what to do. So the current guidelines that we have in New Zealand, so this is the first one is the gender guidelines for gender-friendly healthcare. This is the one we're updating at the moment. So that should be coming out later this year, which will be really, I've read the adolescent chapter and reviewed it, and it's really comprehensive and really, really good. So I'm hoping that will make a huge difference. It will be controversial, but hopefully it will make a huge difference for primary care providers. So WPATH, the version of Care 8, which is the, took 11 years to produce this update from the version 7, but this is the kind of gold standard and what we work off. And then the third one is the document that we released last year. So these are primary care guidelines for gender-friendly hormone therapy initiation. It's adults only. It's directed at GPs. It's written for GPs by GPs, and also peer-reviewed by the community. It lays out the informed consent model, the process, the stages of initiation, and lots of questions, lots of forms, and it's very, very user-friendly, and it's something I would recommend all clinicians to look at if they're interested, especially GPs, to look at this document. So informed consent, so we already sort of talked about informed consent, but I really want to emphasize this is something we do every single day. If you're prescribing, you're doing informed consent. You don't prescribe anything without informed consent. You don't prescribe antibiotics without informed consent, SSRIs, statins, vaccines, menopausal HRT, contraceptive pill. Every single thing we have to inform the patient of what the risks are, what the benefits are. Patients are human beings have the right to choose, and we should respect their autonomy and their agency and allow them to determine what it is they want to use. So it's a collaboration between the patient and the GP. And we do assume capacity for adults to make these decisions. Sometimes capacity is reduced, health literacy may be low, but that's not a reason to not provide care. We just have to find other ways of communicating and supporting people. Even with a patient who's diabetic, who has low health literacy, we have to find ways of communicating with them and making sure that they get the appropriate health care. So these are the stages that the guidelines lay out. So sort of 5 different stages. These stages can be done in 2 appointments, in 3 appointments, in 5 appointments, whatever it is that you need to use to gather the information. But it's an information gathering exercise. It's a sharing of information. It's using information leaflets. It's, we go to patients and we say, look, this is how this works. What is it you're looking for? What are your goals? What are your, what is it that you want to get out of treatment? And then usually by the 5th stage, we're initiating hormones. But this doesn't have to be 5 appointments. So the Gender Care, this is the service that I set up in Hawke's Bay, New Zealand, and it was officially launched really in 2021, I think it was. But it was after many years of lobbying our local hospital to get funding, because I was doing this work and not getting funded for it, and seeing these patients and not getting any funding. And I was seeing all ages and all sort of for puberty blockers and for hormones. And I wasn't allowed, at that stage, I wasn't allowed to refer for surgery because I wasn't on a particular list. But I got that changed. But it was one of my senior colleagues when I started doing this work. She said, just keep knocking on doors, just keep knocking on doors. And that's what I did. And I kept knocking on doors and kept asking people to help me. And eventually I got funding from the hospital. So fully funded service in primary care for all ages. And I get people, we're now getting from all over New Zealand coming to the service, even though we didn't design it, people are welcome to come from all over. So we do it as 3 30-minute appointments in our service in New Zealand. So the first appointment is usually by the nurse. So there's a nurse, there's a doctor, I was a doctor, and we have an administrator. So the first appointment was the nurse. My nurse was sort of gathering gender history, doing a modified heads assessment, and for under 18s, we refer to a psychologist. The second appointment might have been the nurse or the doctor, and it was just moving on with blood tests, a summary of what gender-friendly care did, some information about what they might need and what they might want to find out if they want to share it with family. third appointment was usually with the doctor, and that was the initiation of the hormones, and usually signing a consent form or giving verbal consent. And then we do follow up every 3 months for the next year, and then try and maybe hopefully discharge back to GPs. So gender-friendly care in Iceland. So Iceland is a very quirky little place in the North Atlantic. It's got some of the most interesting people. I was driving to the airport this morning, and there was a volcano blowing up along the roadside. So it was actually just blowing up all along the road. And people were just driving past it. So it's a really unusual place. But it's in a very small population. So the population of Iceland is about 400,000. When we arrived, we brought up to 400,022 people. So they talk in tens of digits and tens of numbers for their population. And they also, I mean, they are very progressive. We know they're very progressive, especially in areas of trans health. And it's been interesting learning about what they've done there. In 2012, the Act was established on the legal status of individuals with gender identity disorder. So this Act, it was very important. It wasn't perfect, but it meant that the hospital had to step up and provide this care. So the hospital had to provide care now, a formalised form of care, it was far from perfect, but it was something. And then in 2019, the Gender Autonomy Act was passed by Parliament, and that was another landmark event to happen. It was more about defining autonomy, especially for people who were intersex and for children as well. So it's been really interesting, and also the hospital was then also obligated further to develop better service. So Samtök 78 and Trans Iceland, these are the two organisations that we work closely with. They're the two trans and queer organisations in Iceland, and they're very strong advocates for queer care in Iceland, and it's been really enjoyable working with them. So this map you may have seen before. This is the most up-to-date map for trans rights in Europe. So Iceland has been top for the last 2 years, having 30 out of the 32 indicators needed for trans rights, based on legal rights and human rights. And the only things they lacked were a policy on asylum seekers and a policy on hate crime. They have laws on these things, but they just haven't developed policy yet. So those are the two things they haven't got. But it's still not perfect. It's still not a perfect system. So this is the older system in Iceland. So from 1996, whenever trans people sort of started to come out and started being seen by a particular psychiatrist, one particular psychiatrist. So this is the hospital, it was a very ad hoc service. Basically the patient requested care, they were referred to the psychiatrist and a psychologist, and this took years and years of assessments and invasive questionnaires similar to what has been talked about, very invasive questioning, and people were often left traumatized by the assessments they had to go through. And then they had to wait a long time again to see an endocrinologist. And the endocrinologists, once again, were not equipped to do this work. They just did prescriptions. They would do prescriptions for the highest dose of hormones and discharging people. And with no follow-up. Patients were having to advocate for themselves to get blood tests, to find out. These people are so well informed, this population are so well informed, that they know more about blood tests than most endocrinologists do. When I arrived, people were still on 100 milligrams of soproterenol, which is now not recommended. It's a much higher dose than is recommended. I was quite shocked to find out what was going on there. Despite all this progress legally, there was still huge limitations to the service. So last year in January, the single psychiatrist retired. The endocrinology department said, we're not doing this anymore. And there was a crisis. And Iceland are very interesting in that they didn't have a word for planning. They didn't know how to plan. They didn't plan anything. So they just went into crisis mode, and that's when I was brought into the picture. And they said, in March, can you start? And I was like, okay, I've got a live family in New Zealand, a clinic in New Zealand. I'll think about it, and eventually I arrived in February of this year. So they had a whole, almost a year without anybody really seeing patients. So, but now we have a trans team. They call it a trans team, but it's a team for gender-friendly care, and it is a national service in Iceland. The law stipulates that it has to be positioned within a hospital sort of setting. So whenever I started in February, this team was brought together. So it's made up of me, the doctor, a social worker, 2 psychologists, and a nurse. And our goals in setting up the service were first and foremost working closely with our local trans and queer organisations, listening to our population. It had to be a centralised service to start with anyway, just because that was what the law stipulated. But we wanted to provide a service that was providing expertise, education, research and support to primary care to do this work. Being a GP, I know GPs can do this work. The GP population in Iceland is also in crisis. They're massively understaffed. And they have not been educated about this work. And it's been very difficult to engage with them, but that's one of my goals, is to engage with the primary care populations. So our service is for adults only. Kids are seen by a team called BOOK. They're like it's a mental health team for children, but they're doing, again, they are providing really good care, but I haven't had a chance to have a good look at the children's service. So my goal was also to introduce the informed consent model. So the first thing I did was take out this model of readiness assessment. So I introduced informed consent. It's meant that our psychologists are doing a lot less than they were doing, but our psychologists are now doing therapy instead of diagnosing. In the past, all they were doing was diagnosing. They weren't doing any therapy, so now they're doing therapy, which is a much better use of their time. So I'm keen to teach medical students. I'm keen to bring in medical, psychiatry and general practice trainees, bring them through the service so we can upskill the future workforce of Iceland. We're also establishing a pathway with the Netherlands with a couple of teams to have gender reassignment surgeries done over there. We have no surgeons in Iceland to do it, but we're working with teams in the Netherlands to do that. So our vision is to provide the best gender-affirming care in the world. So our name, we came up with this name, Unnost. So this is the name of our service. So this lady here is Anna Kristjánsdóttir. So she was the first openly trans woman in Iceland. And the first three women in Iceland that were openly were called Anna. And Unno is a form of Anna, and Unnost means we care for you. So this name meant we care for you, but also honoured Anna. So she was the first trans woman that had gender affirming surgery in Iceland as well, and she's been a huge icon, a trans advocate for Icelandic trans people. So the new pathway that we're developing in Iceland is probably similar to what we were doing in New Zealand. So a patient can self-refer, can be GP referred, can come from BOOK. So we take the kids from BOOK and they come and see us. So our first appointment, we do sort of 3 appointments. The first one's with the social worker who does a wellness check, does the sort of heads assessment, does a gender history, gender body goals, and they can also refer as needed. So they have the ability to refer to psychologists. They can refer for surgeries, not gender reassignment, but all the other surgeries. We have got hysterectomies, orchiectomies, tracheal shaves available and funded in Iceland, and top surgeries as well that are funded in Iceland. So our social worker can refer for those. Our social worker can also refer for fertility preservation. Unfortunately, it's not funded, but we're working on that. So our second appointment is then with the nurse, who will do a health check, do some blood tests, do some motivational interviewing, and start talking about the gender affirming hormones. And then third appointment will be with the doctor and will initiate care. So we're trying to get that pathway to be within the whole process to last maybe 3 months. So from the beginning to the end, ideally it will be 3 months. So as of today, and this is within the last 6 months, so this is while we were building the service. As my husband keeps telling me, we were building the plane as we were flying it. So if you can imagine building something and flying it at the same time. So that's what we were doing. So, and learning a new system, a new language. So as of today, we have 611 patients within our service, and they are all either waiting review or initiation of hormones. So far in the last 6 months, I've seen 197, I've had 197 consults, and I've seen 163 patients. So we have 44 people waiting to begin the service for the first appointment, and our current waiting list for that is 4 months. And we have 12-month waiting list for hormone initiation, but my goal is to make sure everybody's seen within the next 6 months. So we have 70 people waiting on gender reassignment surgeries, but those lists are coming down rapidly. So we had 163 referrals to the team last year and 101 so far this year. So we're making progress. So ideas have already been discussed as well with by the others, but nothing about us without us. This is a really important statement for the trans population. Nothing about us without us. Don't make decisions about a population without talking to them. It's inhumane, it's unethical, it just doesn't, I don't understand why anybody would do it. Research is invaluable. Pathway is similar to PATHA, so having their own voice, having their own advocacy, having their own interdisciplinary team or interdisciplinary organisation for professionals working in gender care in Ireland is really important. Considering national guidelines and considering a national pathway are all things that could be considered. And those conversations have to be had, and I don't know the answers to those, but there's so much potential here. We have such an amazing network of people working together, and there's such an appetite for success. And I really think that it's something that can be done really well here. And the informed consent model is the gold standard. So final thoughts. So access to health, accessible healthcare, safe healthcare, appropriate healthcare. It's a basic human right. Nothing about us without us. This is not rocket science. This does not require tertiary level care. This does not require specialists sitting on high telling everybody else that they can't do this work. You have to do what you can with what you have. You may not have the perfect system, the perfect person, the perfect service, but you have to work with what you've got and you have to make it better. And most of all, it's the right thing to do. Thank you.
Thanks so much, Beth, for a really, really amazing presentation. I'm just going to ask David, what time do we have till we've got some time for a panel discussion now, but you're in charge, basically. I don't want to put you in the spot. Minutes. Okay, thank you. Thanks. I just really wanted to check that. So thanks so much for all of your presentations, and we've had some questions coming in here, and we're pleased to put more of your questions. But two questions seem to kind of emerge to the top. The first is quite a straightforward one. Where do you think the best models of gender care are internationally? And what is their characteristics?
So some of the models we see obviously in New Zealand, but we've also got like say Planned Parenthood in the US, where I gather it's one appointed, and they were very apologetic during COVID. There was a 3-month waiting list because it's going to be a week. But anything which has informed consent and is working with the patient is an assistant.
I can speak to that as well. I guess, just as simply as Jess put it, to some of those points that I put up to the end of the slide, that idea of an informed consent system, one that is co-produced at every stage, engaged with us at every stage, like Beth said, nothing about us without us. What was it again? You said a week? For the wait list.
Yeah, well, until the more recent political happenings in the US, last numbers I heard a year ago, that there were over 100,000 queer internal refugees in the USA due to anti-trans laws and like that.
I think the best model is what you can make it be in the particular community that you're in. I think it's going to be different everywhere, slightly different. You can't really replicate one place. You can't have the same thing everywhere because everywhere's slightly different. Health systems are slightly different. Funding is different. I think you have to work with what you've got, but it has to be worth the community. That's the most important thing, and you have to empower GPs and primary care to do the work and educate GPs to do the work as well. But we want to work with, it's important that we work with the communities, and that's what has to be done. But there's no perfect model. And I think it's doing the best you can with what you've got.
Can't add anything to that. So it's this kind of idea of co-production and nothing about us without us being an absolute key to actually any service that's produced, any kind of service, and indeed informed consent as the absolute norm in medical practice. Another question that actually emerged this morning and this afternoon is about sexual health, and we were speaking to an audience here of a lot of sexual health practitioners in the audience. What do you think the role, certainly say within the Irish context, of sexual health might be? I know we talked a bit about GPs and primary care, But sexual health, and one of the questions that comes up here is, well, why can't our sexual health services provide these cares if it's, as you said, not rocket science?
I mean, in New Zealand, we do have the adult sexual health service in Auckland do gender-friendly care. They do. So there's no reason why they can't do it. They can absolutely provide this care.
I think for me, there's a real appeal to looking at how we can integrate gender-friendly care into sexual health services, because looking at my whole presentation and all of our research around trans people's experiences with like healthcare professionals in general is there's a real lack of trust, there's a real kind of breakdown in communication and all that kind of stuff. And I think within sexual health, we've seen like really successful interventions in terms of like community-based care, in terms of the kind of care that is run by and for the queer community. And I think there's really promising kind of like relationship building that's happening there that I would love to see gender-friendly care kind of recognized as part of queer healthcare and as part of sexual healthcare, and have that kind of built into that really positive work that's happening. So I think for me there's a real draw there.
It's you know, I mean, it's following on from everything there. You know, you probably start to see this real like, what was it? You know, this real opportunity there. I think, you know, we obviously have heard, and we know it's across the board in practice. We're all born out. It's, you know, we're overburdened and underfunded. But you know, think about the opportunities here in terms of, you know, we have papers on like the cost effectiveness of this care when it is provided locally, it's provided accessibly. You know, you are saving the individual and you're saving the taxpayer in terms of like kind of 5-year tenure endpoints. You know, all the follow-on sequelae, the follow-on consequences of someone not receiving this care. You know, they're higher risk for different sexually transmitted infections, for alcohol and drug use, homelessness, job loss. You know, so there's not real opportunity there to actually, you know, if there is that state of being underfunded, to kind of, you know, maybe make that argument that you can provide that care, that you can save that money, provide better outcomes, involve the community, get, you know, advocate for funding for sexual health and that matter. And that is actually going back to the first question. That is something, again, that we want to see, is that kind of locally accessible care, you know, through sexual health, through maybe university health, through GPs, primary care, nurse-led teams, whatever we can make use of out there, working as a clinician in primary care. You know, there is that opportunity, I think, and it is a lot of times people's kind of first point of contact with a lot of healthcare. You know, you see people earlier, you know, save a lot of money, much better outcomes. You know.
So there's a sense there in which we could be looking at hybrid models of delivery in terms of, you know, primary care and sexual health, with real strengths to sexual health. One of the things that occurs to me, of course, is, I mean, thinking about my background with HIV, I mean, a lot of the reasons that HIV services became quite well developed was because they were part of an infectious diseases thing, meant that the services were free. And then therefore didn't have to interact with the partially private, semi-private, I don't know what you call it, but anyway, it's not public health system in Ireland. So thinking about how to best fit gender care that suits, you know, people who need it of all incomes. I mean, any comments on that, or is there?
Also, yes, for somebody else to keep in mind is that people are already getting bloods every 3 months. If that could also do the bloods required for people on HRT, whether that's coming from, you know, self-prescribed sources, whether that's coming from a service abroad or whatnot, like maybe their GP isn't willing, having that service available would be a help, even just, you know, for harm reduction or whatnot. So even small steps will help us. And like there are services like the pilot service in London, which is a full gender service operating out of the sexual health service. It's like these models like this exist, and you know, I think a hybrid model is there, especially as we know there is a GP shortage. So more ways we can spread this work around is good. Like we're never going to have an SH24 service because you need better straws, but there are other things we can do.
It is a key aspect of like, you know, in terms of like concept analyses on like, you know, our stigmatization as trans people in healthcare. You know, it's a key thing we brought up in our proposal for the second national sexual health strategy. Please feel free to contact us if you want a copy of that. The inappropriate siloing of our care, you know, it should be it's very much possible, as Jess said, to integrate this with other care. It's already happening. It's not that much additional onto your consultation. It's just kind of, even as a pharmacist myself dispensing these medications, it's kind of just getting yourself to look at what you already know in a different perspective. The side effects I already know about medications, but kind of, it's a different lens, I think. It's important there.
Yeah, I mean, that touches on, certainly, from my perspective as a health researcher, we often see health systems as huge behemoths that can't be moved, that are so hard to bring change into. And actually we've seen with COVID, change happens so quickly when it needs to change. It's very easy to bring about change, which leads to another question that's been asked a couple of times, which is the area of GPs. So, as you said, it's not rocket science. Much of this care can be provided from a primary care perspective. How could we be thinking about then skilling up or enabling the GP population of Ireland to deliver as much of this care as possible?
I mean, I think it's hard because it's how you find, I know in Ireland it's quite difficult because there's sort of stealth mode. It sounds like GPs are doing this stealthily almost, which is a real shame to do this. But I know in New Zealand, for instance, we set up this workforce development team, and we, took 4 of us to set up a team. So we just upskill primary care. Everybody in primary care that wants it, pharmacists, nurses, doctors, everybody that's involved in primary care, and it's providing some sort of formalised training that does help. But I think it does have to come from the person as well. The individual has to have, it has to be the GP or the pharmacist or the nurse. They have to want to do this work as well. So it's like, and you want the right people to be doing this work. You want people who are passionate, who care to do this work as well. So it's just, it's not an easy question, but I don't know what the services are like, the teaching services are like in Ireland for primary care for clinicians. But I think probably really importantly it has to be built into the education systems, the degrees, the universities. It has to start there, and we have to bring it into the education.
I think it's worth noting also that GPs can and do prescribe hormones in Ireland all the time for people who are not trans and sometimes for people who are trans. And I think the barriers that are there are certainly there's a skill piece and there's an education piece, but really significantly the barriers that are also there are institutional and particularly coming from clinicians within the National Gender Service who are seeking to stop GPs from providing this care. So I think there's a bit of that in it too. It's not necessarily always about the skill level or the education needs of particular GPs, but it's more about it's a political issue.
Political piece. Really transparent to political piece for everybody. It's not nobody, it's a very political subject. It's not actually about trans person. It's about politics.
As we've seen, around the world, but particularly in the UK, the politics has taken over completely within the care. And I think that's, as I said earlier, that's a huge concern that a lot of both clinicians and health researchers are feeling, that actually this is a question of health and care generally being, this is a wedge issue for health.
It is, and health professionals are often quite risk averse.
Yeah.
Especially the secondary level. Pediatricians are very risk averse, endocrinologists are very risk averse. GPs less so because we do have to work outside the box sometimes. We do think outside the box quite a lot, which is why it's better suited to primary care. We should not be, endocrinologists do not need to do this work. Pediatricians as well, but it's I think, but it's the political side that's the big issue.
Okay, so given that it's a political question, I'm going to ask a political question, which is, what can here we have the LGBTQI health community in the room. We have an election coming up, I think November the 9th is the date, is it? I don't know, that's what I heard. Apparently I've seen great news. What could this community do to improve gender care? What if you had to kind of ask various organisations that are represented here, and I'm sure they are doing plenty, but kind of politically, on the political sphere, and strategically politically, maybe as well. What's the ask? What could best be done?
I mean, it's everything we've already been saying, isn't it? It's, you know, it's advocating for somewhat of a primary care-led service, it's advocating for our involvement, allowing us to be involved in the creation of the system. It's advocating for an informed consent model, one that de-pathologizes us, as is the as is the international consensus. You know, as simple as just to listen to us, really, you know, to engage with us. It's that simple. It's that straightforward. It's and in terms of the advocacy, I would stress what I said again. You know, it's a bit of, it can be a bit of a unicorn kind of thing. You probably know, like that kind of thing where you're like, we could do it cheaper and we can get better outcomes. People are like kind of feck off, you know, like. But you know, this is what we have the evidence for. This is what we are seeing elsewhere. So it's, you know.
Research too is really important. I mean, research is really important to prove, because they keep using this, you know, quality evidence phrase, and I mean, it's like we do good research, but we need more research, I think, and that helps to prove. But we also need to we need to advocate for trans rights. You know, we need to say this is a basic human right to services. We should have these services, and we should have them available and accessible. You know, I don't know. I mean, I don't know. I'm not sure of the kind of the medical landscape in Ireland, but I mean, whenever I was in New Zealand, I just started doing this work. I just started doing it. I didn't ask for permission to do it. I just started doing it. And as soon as I started doing it, the pediatricians were more than happy for me to do it. The endocrinologists were more than happy for me to do it. And I got them on side, and they helped me lobby the hospital to fund it. So I just did the work.
It seems kind of, I don't know if you agree with this, but it seems kind of less adversarial. You know,
like, yeah, I think that
you're actually like you're working together a bit more when you're creating space for. I think trans people, like in the clinic, actually be honest, be open, and there's less of a, you know.
Yeah, and it's really important. I mean, the amount of people that I've had in Iceland who, you know, have started to DIY with their hormones. I mean, and if we be open and honest with me, it's fine. I'm not going to stop you. Like, we're going to work together. And if you need to get this hormone overseas because you can't get it in Iceland, that's fine. I'm going to support you. I'm going to do your bloods. I'm going to keep you safe. You know, and it's just being really open and honest with them, and being transparent, so that they're transparent and honest with you, and they're not afraid to do so. And it shouldn't be a barrier to care, you know.
So the message remains the same. So it's about a informed consent model and one that includes community. Okay, I have one final question, I think, just coming from the list here. Somebody says here, sounds like we need GP allies, which is interesting that when you talked about that kind of stealth medicine, which often, you know, we find over the course of lots of different developing areas of medicine that they're often done by stealth, especially in reproductive and sexual and gender care. I think that's the way these things start. And indeed, gender care started in that way around the place. But so, yeah, then thinking about this more top-down idea. So somebody asks here, is the Irish Medical Council involved in trans care? And what are their recommendations in regard to medical therapy?
So the Irish Medical Council regulates doctors. It has no role.
Okay.
And what I've heard of the complaints going for them, that they went nowhere. Basically, this doctor says they're following their role model of care. We're not investigating further. So the more relevant bodies would be things like the ICGP, who provide GP training, and so on. So engaging with some of those would be useful, because the current guidelines are basically refer to the NGS, otherwise talk to the insurer, which is basically saying here. So obviously, we'd love to work with the medical community to improve those guidelines and to talk about things like harm reduction, like if someone is accessing estradiol injections, because those are not licensed here, then we should be able to support them and, you know, maybe get them on some GRHAs, so they reduce their dosage or something, and just try to find out what works for them and improve their healthcare, rather than a situation where GPs are afraid to have transmissions and effectively keep them out of their practices.
There is that, like, it's, you know, and that can be, you know, nearly feeds into that stigma again, doesn't it? I mean, there's that, like, there's a stigma against us as trans people. There's stigma against the clinicians that provide this care as well, you know, it extends to that as well. So it's, it is an important piece to try and demystify maybe our care about that. Perhaps, it be straightforward. There's only a couple of meds in it. It's,
It is bringing our young doctors into the picture. You know, I think, I know especially in Iceland, I've seen that, and in New Zealand, that our younger doctors are very keen to do this work. They're not afraid of it the way that some of the older doctors are. They're not as intimidated. They're not as, you know, old-fashioned in their ideas, whatever. They're not as transphobic, and they are very keen to learn. And Iceland has been interesting because I've asked the directors of the college of GPs there to come and educate them. I said, look, I'll come and talk to you at lunchtime. I'll come to where you're at. I said, I'm discharging these patients to you with or without, you know, whether you want me to or not. They're going to be discharged to you, so you need to look after them. So you need to know what you're doing, you know. So it's really a case of you need to do this work. It's just the right thing to do.
There's a real sort of perception that trans healthcare is this like really scary, specialized thing, and I think it makes GPs really nervous to provide this kind of care. And as we said, like, there are GPs who are doing it, who are allies and who are afraid to be known that they're providing this care. And there's just so much that I want to do that's not around a top-down approach. It's around like a kind of bottom-up approach of saying, this is a normal part of healthcare. This is a normal part of the variety of human experience. This is care that you can and should be providing. There's nothing special necessarily about it. Similarly with blood tests, similarly with like recognizing the realities around people are self-medicating, and we need to not be scared of that conversation. And I think building it from the ground up is a really effective way of creating change.
And not denying care is what we're doing. You know, they dress this up. Clinicians who will dress it up as, you know, first do no harm, but actually it's their own fear and caution that's making them do that. It's actually, they're just dressing it up in their own way, but it's actually not reality. You know, they do lots of things, doctors, clinicians do lots of things, but yeah, it's just respecting the autonomy of the individual.
Like if there's 1,700 people on the wait list for the National Family Service, say, there are like 4,000 GPs in Ireland. So it doesn't have to be everybody. Do you know what I mean? It only has to actually be like a small-ish proportion, and that wait list would be like eliminated on a certain night. So I think the scale of it can seem really huge when you're looking at it in this way, when you hear the thing like a 10-year wait list, but actually drilling down into like what it is at a population level, and especially when you're not bottlenecking anybody into one service, like it actually becomes a really manageable problem, in my personal opinion, not that anybody has to.
I think one of the models that Ireland could look to, if, you know, it's okay, like I know in Iceland I'm not thrilled with having a centralised service, but it's what we have to do. But I think it's okay to have a centralised service for expertise and to support GPs to do the work. Then they know who to talk to. You know, we have that informally in New Zealand, where the GPs are doing it in the regions and outside the main centres, but we know who to talk to when we've got an issue. So you do need some expertise, but I think the majority of this, if you'll have more support and more GPs will be happier knowing there's somebody they can call if it's a problem or a complex case or whatever. So I think it's some sort of hybrid model would work.
Yeah. We're full of those kind of examples in other areas of primary care centres, especially in instance.
Even in my own clinical experience, like advising colleagues about trans care and stuff, you know, there's a lot of them that, you know, they might want to help and they kind of get these prescriptions, never learned anything about this in college or anything. Just the benefit of a quick conversation, a quick informal conversation, game changer, you know. So it's not like having a phone line, something like that, you know. It does really help.
I'm going to call it to an end because there's a little clock there flashing around it. Just to thank everyone for this session, and I think there's so much good information we can take away from this. But thanks very much.
Hello again, everyone. I'm just standing in for James. James from LGBT Ireland will be here today. He sends his apologies, and he's a part of our working committee for organising this. He said he can maybe or maybe not blame Callum now from EP last weekend, but yes, we're sad not to have him here. I'm going to introduce our next and final three speakers before the closing remarks. First up, we have Graham Ryall, who's the senior addiction practitioner in Rialto. He's advocating for and working with individuals in the support and therapeutic capacity, addressing their use of chems and blood drugs, and individuals participating in chemsex. So thank you.
Thanks very much for the invite to speak here again. I think this is the third or fourth year I've spoken. Initially, I was to do this presentation with Derek Bourne, who unfortunately can't make it today, so he's with me here in spirit. So yeah, listen, rather than going through the whole chemsex thing, because I'm sure you are all aware of all of that now, right? I'll just go through one or two quick bits. For myself, in 2023, working in Rialto Community Drug Team, I had 49 new presentations throughout that year, alongside working with people who previously engaged. And of the 49, very quickly, 25 were Irish, and they would be from across the state. So that leaves 24 from outside of Ireland. One of the things that from this year is, for the first time, outside of Ireland, another cohort have become the main presentation, and they would be from Eastern Europe. And I've seen a significant jump in people engaging with me from Eastern Europe. One of the changes that they're bringing is that their use of methadone. Now, methadone has been here since the head shops in 2009, 2010, but not really part of that chems menu. And what people are saying to me is, again, the come down experience and their mental health being affected through their use of methadone. So there's just the breakdown of the primary chem of choice. So when you actually think about it, that G is the one that we do have the G detox in the Club Drug Clinic. Whereas, and again, people would disclose this to me, that certainly there seems to be a lot more T in use rather than G. And at this moment, we don't have a clinical response to that. And why I'm bringing that up is that the instances of T-induced psychosis are certainly on the rise. Last weekend, I had 3 separate incidents from hospitals. Just fly through these ones, okay? Yeah, addiction is not the problem. It's the attempt to solve the problem. And that's from Gabor Mate. And if ever that is relevant, it is certainly relevant to the chemsex issue. Whereas people present, and in their heads, their addicts and the whole kind of cloud that brings, right? In certain cases, that is not the case, because the vast majority of them, as I view it now, and I'm working 30 years in addiction, it's self-medicating, it's not addiction. It's really are two separate things. Those problems that Gabor Mate talks about, the issues between the underlying determinants, every one of them that's up there can be found in evidence-based research from across the world, but also each and every one of these have been disclosed to me through working with people. I first spoke of intimate partner violence 2 years ago when it started being disclosed to me, and perhaps that was connected with the ending of lockdowns and stuff like that. But the last one I have here is the one that's new since we last put together last summer, and that's neurodivergent conditions. And when you ask someone, have you got a neurodivergent condition or a history of neurodivergency, they're all, what do you mean? But when you mention ADHD, ADD, or autism, suddenly they're literally sitting in front of you, really interested. When my teacher always said, or my mom always said, or whatever, right? When you then ask that person, and again, the majority being T, being their primary chem, when you ask them, explain to me your experience in T, it calms me down. I can focus. I feel normal. They're the ones that are said to me. Okay? So I've now started to refer people for assessments for neurodivergency. Now, that is not an easy thing to do. There's an excellent service on the north side through Keltside, and psychiatrists will then assess, diagnose, and in some cases medicate. Because at the end of the day, again, the amount of people who's really good to hear someone say it earlier on there, self-medicating, right? And we don't have that on the south side. I'm just going to leave that out. Right. Right. Other emerging trends. I've always brought this up, and like I said, intimate partner violence was once brought up 2 years ago, right? So, very quickly, because literally I had 40 slides for this, right? Be cutting them down there, right? So, intimate partner violence, or as it has been referred to in American research from about 10 years ago, the double closet. This is something that was rarely discussed, right? It's really good to see in the recent ad campaign around domestic violence and intimate partner violence that there's a male involved. Because up until now that wasn't the case. And again, working with people, and you're asking, well, what you're saying to me, what do you call it? They don't recognize it as intimate partner violence, as domestic violence, okay? It's broken down into 5 areas. And again, listen, we could have a whole seminar on this the whole day long, right? Physical abuse, psychological abuse, coercive control, financial abuse, and sexual violence. The come down associated with T, you know, after it gives you that initial euphoria, connection, sexual experience and all that. And the vast majority of people who take the chems, who participate in chem sex, you know, they're managing it, right? But to those, the minority of those that go along that trajectory towards the abuse and dependency stage, right? T can be an incredibly negative experience. That incredible connection that was there initially is no longer there. And just as you're reading that, like, right, the one is significantly irritability, aggression, and violence are further detrimental aspects of T use, giving rise to the possibility of aggression, violent behaviour, and outbursts. And again, if that's, like, you know, through prolonged use of whatever chemical, especially Tina, right? And if the perpetrator themselves carries underlying determinants, this is what's triggered when that person is in a come down or is so over medicated that the dopamine is gone, so it's tapping into something very dark and negative. The findings from a study from a couple of years back suggest that IPV experiences may be a significant risk factor in exacerbating a person's chem use and a motivating factor for maintaining ongoing chem use for both the victim and the perpetrator. Again, any of the victims of this, and of course the goal is to turn them into survivors, absolutely, right? Again, that issue of self-medicating is a huge determinant to their continued use because of the abuse, be it on whatever level that they are experiencing. GB MSM victims of IPV display higher rates of substance or chem use when compared to their heterosexual counterparts. And again, numerous studies from across Europe and the UK and the US will highlight this. And the use of T is particularly popular among young gay men as it lowers sexual and physical inhibitions and alters critical thinking, both of which can lead to high-risk behaviour, aggression and violence. A recent study maintains that chem use can provide fuel for violent confrontations, heightening emotions of jealousy, suspicion, and reducing behavioural inhibitions and conflict. And whereas you might have a couple who are in an open relationship, again, if there are chems, and again, not everyone goes to this darker trajectory of use and abuse, but those issues around jealousy and suspicion can again fuel incidents of IPV. A study from 2018, a small study, and there are some figures in relation to what people experience on various levels. Okay. Again, I've forwarded this on to Alicia, so I'm sure she can send it on to anyone who is interested in it. Right. I felt that I really needed to put this slide in. Okay. because these are the testimonies of people who I'm working with, right? And it is really, you know, I'm not being sensationalist when I say like some of the work that we're carrying is pretty harrowing. Some of them may have experienced domestic violence as young people themselves at home, and then perhaps experienced homophobic bullying in school and the school bus and stuff like that. And when you're working with someone, say like the people mentioned here in their 40s or in their mid-30s, when you're doing this work with someone, it's like you have that 12-year-old kid sitting in front of you. Okay. But that gives you a really good indication of what is unfortunately happening out there. There is a kind of coalition of groups looking at this, and hopefully consensus will be reached and some strategy introduced. But even like, I'm not that, like my partner is a social worker in maternity, so domestic violence in IPV is huge. But at least, Jesus, there isn't anywhere near enough refuges and hostels for women and children. But where does a gay man go that is seeking refuge, right? We talk about harm reduction in relation to substance use and addiction, right? And you're asked, well, what does harm reduction mean? And you're probably, you know, needles, condoms, methadone maintenance, stuff like that. Listen, the main reason as to why people are addicted or self-medicating, homelessness, dual diagnosis, and issues like that are driving that more than anything else. And where you have a couple where there is IPV, one partner wanted to leave, perhaps financially, and this is where financial abuse can come into it, can't leave the accommodation. And that again is exacerbating the situation. So listen, that's me for the moment. I hope I've left some issues for thought for you. So thanks very much.
Thank you so much. Next we have Peter again. Peter, I haven't met him in just that he is a professor for the Health and Society at the Open University, and member of the Gay Health Network Board, and he's just back from the UK.
Hello, I'm just back from the UK. Literally. Okay, so yeah, this is you have a slightly misleading title because although I was supposed to give a history of the GHN in its 30 years, that's not what I thought. I thought I was giving a history of research at the GHN in its 30 years, and I'd be the worst person to talk about 30 years of GHN because I just got back from the UK. Okay, but I think in order to think about this, we need to think about a very key question, which is, why is it important for our communities to do research, to engage in research? And the first thing to say is that research has always been key to how we understand ourselves and how we're described as queer people, yeah? And medical research and scientific research, whether we like it or not, is a key part of that. You know, one strand is the medicalization of homosexuality and transgender, which was mainly around, as we've just been hearing, thinking about homosexuality and being trans as disordered states, worthy of treatment, that kind of thing. And science and medicine have been, to a greater or lesser extent, as I said, part and parcel of how we have developed as communities, how our sense of ourselves, what it means to be gay or bisexual, has been informed by medical research. But obviously, some research, there's research and there's research. And I don't need to talk about, for example, Magnus Hirschfeld. I'm sure everyone is highly aware of this kind of history, but I will talk about it anyway. So certain research has to be suppressed often, and other research is often vaunted. So we see the story of Magnus Hirschfeld, of the Sexology Institute in Berlin, throughout the 1920s and 30s. It wasn't alone in terms of producing scientific research about our communities, which in the middle, in the wars, in the years leading up to fascism, had to be destroyed. And we see, this situation here in 1933 of a mass book burning and paper burning of research archives from that. And that information is lost, and it lost forever. And alongside this, over the course of this time, we have many other attempts to demedicalize our sexualities, to break the links between, being queer and illness and deviance, etc. You have, that's Evelyn Hooker there, whose work de-linked homosexuality from pathology. You have the work of Schneider there about deviance and medicalization. You have McKinsey, this Bellen Weinberg on the left, which was a major study from the 1960s into the 70s on male homosexuality, which really did a lot to start trying to break those kind of links. But what I think this tells us about, the only point I'm really doing this history lesson for, really, is to say that research around our communities is highly contested and highly political, as we've just seen in this panel. There are tropes and backgrounds and discourses that are promulgated in different types of research that are done about us. And I suppose this is where I'll start getting to the more recent history about, because this kind of brings us up to about 1980, 81, 82, when HIV started emerging, and that's where I want to focus on now. And so how did HIV emerge into this very contested research space? Well, new struggles emerged almost immediately around HIV. Wow, it's changed the font to something I've never seen before. Okay, so HIV emerged in the early 90s into this space. Early research attending to HIV, and this is actually when I started doing this work, I'm embarrassed to say back in 1988, tended to have a lot of problems. It was based on very limited understandings of people's lives, their desires, and there was an implicit homophobia in much of this research. For example, much research focused on gay men continued, what was asking, why did gay men continue to have sex in an epidemic? This is research from the early to mid 80s. What is wrong with these gays that they continue to have sex in an epidemic? Can't they just be monogamous like everyone else? I mean, firstly, that assumes that everyone else is monogamous as well, which is a bit of a problem. But what this research had were incredibly heterosexist, sexist norms of normal sexual behavior, very stigmatizing tropes. There was tons and tons of research on sexual compulsivity that we just couldn't help ourselves. And this was also linked to the fact that we were self-hating, internalized homophobia, and that we were bridges of infection, for example, especially bisexual men. They were awful because they were bridging infection into the kind of worthy heterosexual majority. So it was all of these incredibly stigmatizing tropes that were going on in research, and certainly when I entered the field in the late 80s, that were going on. And actually what was funny was I was trying to find some pictures of good old-fashioned kind of papers and journal articles to show you. So I went to Google all of these things about sexual compulsivity and unsafe sex, and I found papers from as recent as 4 years ago. So these tropes still continue in mainstream biomedical and sociological research. And I guess that's my second point, which is we often tend to think of the bad old days of biomedical research and queerness as being kind of over, as those battles having been won. But they haven't been won. There is still a very, very strong discourse in this area. And again, the last session that we saw, the Cass report in the UK, is a classic example of how biomedical research and biomedical paradigms are used to marginalize and stigmatize sexual and gender minorities. Now, the other side to this picture of this early, this kind of mid-80s research was communitarian research, or community-based HIV research. And really, I mean, this is a kind of oversimplification, but mainly it didn't focus on what was wrong with individuals. It started from the premise that being queer, being gay, or being trans was helpful, health-giving, beneficial. Yeah, it didn't look at just the individual. It looked at the individual with other people. So it didn't ask like how can we stop people having sex. It asked how can we enable people to have sex better. It looked at contexts. It didn't look at the individual. It looked at the individual's partners. It looked at all kinds of social contexts, such as back rooms and saunas and, well, this is before online stuff, but it looked at all of those, BDSM and kink and all of that. It started to think about, well, how can sex be better negotiated within this range of settings? It also looked at the social and political things that mediated the kind of sex that we had. So it was much more kind of outward looking. And I suppose my point is that the work, I'm sorry, I'm going to go through these because this talk is such a tyranny. It made huge differences. It changed drug trial protocols and procedures. It changed HIV care. It changed how we diagnose things and our approaches and categories. And it repurposed treatments and technology. U equals U and PrEP are all the result of communitarian responses to biomedical things such as drugs. Yeah? So these are either community-led or community-included research. And that is where GHN emerges, and this is the history of GHN. And finally, with 1 minute 30, I'm going to start talking about GHN. I'm going to run over a little, I'm afraid. So this is Out for Ourselves, a book that came out, I'm sure you've all seen it, in 1986. I found it in my library in the UK. My own copy, which I bought in 1986, with my name on it. And this was a really good attempt, an example of our queer communities speaking for themselves, producing knowledge about themselves, speaking to power of themselves. And this is as far back as 1986. And that story continues, I guess, all the way through. And Ireland, specifically, in this group of people here, is an amazing example, a remarkable example of this kind of work. So we have these periodic gay men's sex surveys, a history of them that runs actually nearly 25 years. The first one was in 2000. It was done in collaboration with Sigma Research in the UK, where I worked and I recently returned from. These were periodic annual surveys of gay men's sexual behaviour, looking at things that mattered, how we could start preventing HIV. And at one point, I think in 2010, this was extended out to Europe and the European Men's Sex Survey, a really, really remarkable example of community-led or community-based research on a global, not a global scale. Well, it went actually to the Caribbean as well. So this is a huge, huge example, which was taken up when that closed down for a while. It was taken up locally here in Ireland with NISI, which was a survey in 2012, I can't remember, anyway, reported in 2015, 2016, and then EMIS took over again with 2017 EMIS, and now, of course, we have EMIS 2024, which was presented to you this morning. Now, I'm talking only about these surveys. There's so much other work going on. But what this is an example of, as I've said, a really, truly remarkable example of community-led research. So I'm going to finish with just a couple of thoughts about where to next. And I think one of the things we're facing at the moment, we've seen in the panel earlier on how I think evidence-based medicine is in a bit of a crisis at the moment. There are political agendas that are being met through medical research. Again, it's not that they always were, but it's so obvious now. We need to start thinking about that. We really need to start thinking about that. The other question is, despite all of our community research and around the world, we're in a terrible trouble in terms of being around reproductive justice, reproductive health, the rights of queer communities globally. That kind of research has not stopped Roe versus Wade in the United States being revoked. It has not stopped the revocation of queer rights. So we need to think quite radically as communities about what kinds of knowledges we're producing. And so a couple of thoughts about the future. I think we really need to improve community research literacy and criticality. We as communities need to be much more able to read and critically engage with and debunk research if we need to. The kinds of scientific research, and I'm not trying to set up wedges between researchers and communities, because I think actually in Ireland we have an exemplary example of how this works. We need to engage in more explicitly political knowledge production processes. We need to get more political about what we're saying, and we also need to think about not how we include the voices of marginalized people in research, but how we as researchers enable marginalized people to make their own knowledge, to make their own research. And that's a different thing. And we really need to think about how we do that. And we need to attend to the wider structural stuff that relate to our health. And indeed, the kind of solidarities that we could be creating around our health. I know that if I was speaking to a UK audience, that might be something quite new. But actually what I really noted about here is that there are those broader structural alliances, these concerns with migration, with poverty, with race, which actually inform what we do. And we need to use different methods and approaches. And what's the good news is, those methods and approaches are great fun. The co-production, the co-productive and participatory kind of research approaches that I think we should be doing a bit more of, in addition to our surveys, are hugely life-enhancing, wonderful things. We need to be doing much more creative research. So that is I've gone 3 minutes and 40 over, I'm so sorry, but that is my whistle stop tour. Thank you.
And we're going to have our final speaker now. And sorry, just after that, we'll also have a Q&A. So just remember, you can still use the QR code to answer or ask any questions. And then we'll also have our closing remarks. So now we have Brian Teeming. Brian will be presenting an exhibition presentation, Out of the Strong Came Forth Sweetness, aka GHN for 30-year project. I have a bit of an introduction here, Brian. He's an Irish multidisciplinary artist living and working in Dublin. He has no fine art qualification and is entirely self-taught. His work explores themes of queer, working class dynamics, psychogeography, cosmology, automotive psychology, and portraiture. Recent achievements include becoming an associate artist within the theatre group. This is Pop Baby 2024, an acquisition with the Arts Council of Ireland of his work Declan Flynn's Dublin 2023, and the release of his third book, In the Glow of a Frozen Flame, commissioned by the Crawfield Gallery Cork in response to their Building as Witness programme with Jenny Taylor. Forthcoming work includes Skin Deep group exhibition at Photo Museum Dublin, and Blunt Pain at the Receptor solar exhibition at Garter Lane, Waterford. So please welcome Brian.
I'm probably going to have to read all that about myself. So I'm here to talk about GHN 30, which is titled Out of the Strong Came Forth Sweetness. So there. Out of the Strong Came Forth Sweetness is an exhibition that we're going to have later on this year. I'll talk about it later on. When thinking about this exhibition, actually there's a this first. So Gayhan Network was established in 1994 to organise and share resources in relation to HIV and sexual health, aimed at gay and bisexual men and to challenge HIV-related stigma. And I've included a nice little photo there of Michael Dillon wearing the So Do My t-shirt in front, and then that's the Dice Man in the back dressed as a sailor helping some pink premonitions. That's courtesy of the National Library of Ireland from the Christopher Robson archive. And then just go back to Out of the Strong Came Forth Sweetness. The exhibition title, it kind of came from, I was thinking about like HIV and AIDS and the era of like, the 80s and the 90s, and how a lot of the language used to describe the community and to talk about HIV and AIDS was like quite like biblical. There was lots of lots of shame and plague used. So especially from the red top newspapers. So when thinking about biblical language, I came across this Samson's riddle, which is like a strong came for sweetness. It was about Samson killing this lion and then coming back to find that a beehive had grown in, which you could take honey from. And it also references the Italian poet, director, and artist Pier Paolo Pasolini. So for GHM 30, we are celebrating art's role in shaping stigma, fostering inclusivity, and sparking crucial conversations about sexual health and education. One of the main inspirations for this show is actually Oliver Stanley. That's a portrait of Oliver Stanley there in leather chaps and a leather waistcoat for the club Shaft. That photo was actually taken by Conor Horgan, and the flyer itself was designed by Oliver, as is my t-shirt from the gin sauna where Oliver did work as well. These t-shirts are not available just yet, they will be soon. So Oliver, who died in April 1995 from age-related complications. He was, according to Conor Horgan, who took the photo, he was a really good friend of Oliver. He was a vibrant, waspishly funny and deeply kind man who made a real difference to many people's lives in the gay community and beyond, remembered with love by those that knew him. So, for art and sexual health activism has always had a deep connection with many artists in the 1980s and 1990s turned their artwork into activism to raise awareness of the emerging AIDS epidemic. And some of the artists, for me, which inspire me in my practice, but also have inspired what we're going to be doing later on in the year, are David Vonarovich, Felix Gonzalez Torres, Matt Bush, and David Robilliard. I'll talk about those just really briefly. So this is David Vonarovich, who was born in 1954 and died in 1992. He was an American painter, photographer, writer, filmmaker, performance artist, songwriter, recording artist, and AIDS activist prominent in the East Village art scene in New York. He incorporated personal narratives influenced by his struggle with AIDS, as well as his political activism in his art until his death from the disease in 1992. This portrait that David took, actually, he staged his self-portrait in Chaco Canyon in New Mexico just over a year before he died of AIDS. At the time, fueled by bigotry, political leaders dismissed and downplayed HIV, delaying research and medical care that led to thousands of preventable deaths. Reflecting on mortality in the age of AIDS, David Vonarovich wrote, "The first minute after being diagnosed, you are forever separated from what you would come to view as your life." Felix is one of my favorite artists of all time. Felix was born in 1957 and he died in 1996. That's Felix on the far left in the dark sunglasses, and that's his partner, Ross Laycock, in the lighter sunglasses there. Felix lived and worked in New York City between 1979 and 1995. After attending university in Puerto Rico, his practice incorporates a minimalist visual vocabulary and certain artworks that are composed of everyday materials such as strings of light bulbs, paired wall clocks, stacks of paper, and individually wrapped candies. The work on the right, untitled Portrait of Ross in LA, is one of my favorite works of Felix, because it really brings the kind of the tragedy of HIV and AIDS to the front as it's a very, very sad piece. It's about it's named after his love and life partner Ross Laycock, and it's about his personal experience of AIDS as well as the AIDS crisis as a whole. The pile of sweets can take any form in any gallery, and they have an ideal weight of 175 pounds. I don't know what that is in their money, but it's a reference to Ross's healthy weight, which diminished because of the virus. So when you enter the gallery, you'll be invited to take a sweet from the pile, and before they're diminished in the pile, I think for me, I think it's a commentary on society as a whole, like, in their, I guess, kind of lack of action when it comes to HIV and AIDS and their kind of complicity in the crisis. Ross died from complications to AIDS on January 24th, 1991, and Felix would go on to make the work later that same year. This is Hamad Bush. He was born in 1962 and he died in 1994. And Hamad is a Pakistani British artist who was born, he was born in Lahore, and he studied at Goldsmiths in 1990. Around the same time as all of the new wave of the YBA British artists. He was actually a contemporary of Damien Hirst. He's kind of underground and not well known. There is an exhibition actually that I'll plug in Emma in December of Hamad Butt's work. He was described as a hazardous artist, definitely in relation to his past status and HIV and AIDS. He took this on. He made a lot of work that was quite hazardous. The one on the right you can see it's called Cradle, and it's a monumental variation on the death toy, the Newton's Cradle. But rather than metal balls that knock against each other, it comprised 18 vacuum-sealed glass baubles filled with lethal chlorine gas, which would smash a set in motion. There's like a bit of dark humor evident in these sculptures that invite participation, but can also kill. Again, like you could argue that's kind of a metaphor for meds. And then my new favourite artist, Mr. David Rouillard, because I didn't want it to be all, tragedy, etc. But David Rouillard, he's a self-taught Guernsey-born artist who came to London in the 80s. And he took happily along the boundary of creating his own line in comedic visual poetry, describing witty, poignant musings on sex, friendship, and the urban experience onto these square white canvases, illustrating despair, slightly absurd figures. He was mentored by Gilbert and George, the famous living sculptures artists, and they dubbed him, Gilbert and George dubbed him as the new master of the modern person. This work in particular, I just think is so funny. Too many cocks spoil the breath. 1987. David actually passed away in 1988. He's an incredible person, and like he really had like such a gallows sense of humor. When David found out that he'd become a boss, he started to introduce himself at parties as David Rouillard. So he's a very funny person. So the exhibition that we are doing, it will include both historical artworks and new works that embody the LGBTQ+ experience in the present day. There will be artworks that promote a sex-positive, thoughtful, innovative, and daring approach to the lived LGBTQ+ experience in 2024, and that also challenge HIV-related stigma. This is one of the artists that has been selected from our open call we did earlier this year. This is Sabri Reid. Sabri is a 26-year-old autistic trans male queer artist who's currently studying printmaking at NCAD. And this beautiful self-portrait called Blue. So there are over 20 artists selected from the open call process and an invitation as well to exhibit. I'm not going to read all of them out because I'm very conscious of time. I'm not even going to look at the clock. But I can talk about this work here. This is by Karen Donlan, who is a psychic artist, energy healer, and educator. And this work is called Saint Agatha for Disco Tits, which is made of rose quartz, pearls, and consent. We also have some other work in the show. This is a lovely painting by the artist Rory Draper. It's called After It All, Pipeworks. Rory's a very interesting painter. He paints a lot of scenes from bars, clubs, saunas, what have you. This was one of the least risque paintings we could put in. He's an incredible artist. And then Padraig Robinson, the researcher and artist, this work is called A Faggot is a Unit. And this is 7 years of research material, notes and sketches from various books, archives, and the selected material is arranged in a retrograde moving calendar format. We'll have a completely new version of this for the exhibition that we do later on in the year. We also have a selection of archival material from numerous community and personal archives, like the Healthy Hot and Horny Guide here, which was designed by Declan Buckley, not Shirley Temple-Bar, a different Declan Buckley. Declan, who was a very, very active graphic designer in the 80s, and who did a lot of work with like the All Ireland National Gay Conference in 1982, 1983. And he would have worked quite actively when he moved to the UK in the second half of the 80s. A lot of his graphic design and posters and stuff that like challenge that to do with sexual health are all in the V&A in London. We also have some images from the Crystal Robson archive. I believe the one on the left is Pride in 2000, I believe, with the streamers, and then on the right there is a photo of some drag queens. I think that's from 1993. And then just through a bit of rooting around in the archives, I found these two very interesting ads in the Pride Guides. One is from 98 and one is from the year 2000. The one on the left is actually from Outhouse, inviting people to take a HIV test. And the one on the right, you've also got condoms from GHN. I don't know who designed both, but we'll find it out. So when is this happening? It is happening on the December 2nd to the 16th, so there's 2 weeks, just the day after World AIDS Day. And then, so where is this happening? It was quite tricky to find a space in the city to do something for longer than 2 weeks, but we managed to get it. We were in discussions with a few places, but we managed to get the Science Gallery in the end at Trinity College. So a nice big space, 2 floors, that also comes with the Packet Theatre, which is directly next door to the Science Gallery, which will actually allow us to facilitate some talks, some workshops. And there are some additional events that we're going to do as part of the Strong Paying for Sweetness program. We have a partnership with Gaze, more to be announced on that. We will have the series of talks, and we will have a series of workshops during the day for the run of the exhibition, and also a party, more on that later on. So for the network members, I'll obviously be getting in touch with you, but please also get in touch with me and figure out how we can work together to make use of the workshop space, to invite people down to the exhibition. I'm happy to give curator tours to any of the network members that want to get involved. And then, yes, if there are any workshop ideas as well, whether it be anything that's sexual health related or community related or just general conversations on research or archives, be more than welcome. And I just want to finish with a video. Thank you to Susan Donlan for sending this on to me. This video is from 2007 and is part of the Stamp Out Stigma campaign. 5 prominent Irish celebrities appeared on TV with this ad. And I think it's just it's going to be in the show, and I think it's just nice to end with Sinead, who is obviously an icon. That's all from me. Thank you.
You don't know me, but my story is a common one. Some years ago, my country went to war, and then soldiers came to our town. They raped me, and I became HIV positive. First, my husband left, and then my family burned my clothes and branded me a witch. I lost everything then: my family, my business, my dignity. Not my words, but the real-life experience of someone forced to live with the stigma that we attach to people living with or affected by HIV. The thing is, there's now good treatment for HIV, but where's the treatment for the way the rest of us think?
so much thank you, Brian, for that. So that concludes our presentations for the day. We didn't have any questions come in on the app unless there's anyone in the audience with any questions right now. Just to say, we're having a little after drinks in 366. You're all more than welcome to come. And I'm just going to introduce Paul O'Connell, who's going to do our closing remarks and thank yous. So Paul leads the TikTok's content regulation legal team, where he's responsible for the team that oversees the implementation of new content safety laws. For example, the Europe's Digital Service Act and the UK's Online Safety Act, and provides ongoing advice on those laws once they are in effect. And Paul has been a member of the Gay Health Network board since May 2021. So yeah, please welcome Paul.
Hi everyone, I've also come from the UK today, so pitching on to Peter's bandwagon there. I think one word that really kind of stood out to me from a couple of the talks today was history, and the importance of history and context that comes through all the conversations that we had today. And that's the history that's highlighting the progress that's been made, the challenges overcome, and the challenges that we need to convert from challenges into progress. When we look at the progress made, we also see the associated history. We have come a long way on these issues, and yet, as Peter and others have noted, we've not come far enough. Today reflects that spectrum of progress and challenges, with a warning highlighting the progress made even in the last year on topics like PrEP, adoptee PrEP, home testing, HIV fast-track cities, and so on. But an afternoon focusing on significant and profound challenges faced by the trans community and the healthcare, and in relation to chemsex, among others. On trans healthcare, the aim must be to get to a place that's more akin to this morning's discussion. By no means perfect, but foundational improvements in care and sentiment, putting the care back into healthcare. And that we move from nothing about us without us to a world of all about us and with us. In terms of progress, it's amazing to see so many passionate and dedicated organizations and individuals in the room today, making really positive impacts directly into the lives of individuals and to public health more generally in the country. Progress is on a spectrum and is happening in many different forums, including this one. We listened to where there were gaps in the forum provision previously that were provided last year, and we've hopefully addressed those gaps and made meaningful steps to address those. But we're always listening, and if there are any other gaps that remain or people think there's topics that we haven't addressed in a particular way, please don't be shy in letting us know. Finally, I want to thank all of our speakers and contributors. We appreciate the time that you've given to us today, to the forum, to everyone else, to the knowledge shared and gained, and in particular the time that goes into preparing for today. We also want to thank our amazing interpreters throughout the day for sharing the knowledge with everyone else. Thank you also to those who were instrumental in bringing today together. On the GHN side, I want to thank Claudia and Alicia and the board, and a huge thanks to Luke from Dublin Pride for doing the live stream and making sure that this audience and that the knowledge shared today goes beyond this room. And with that, I'll close today's session. Thank you.